the marker of the Manta device, and this was the flow we achieved post closure of the with the Manta device, and there was no any wooge or leak or any hematoma. And the post procedure, the gradient was also, mean gradient was also less than 10. So the take home message is like the success of TAVR hinges on the meticulous patient selection through a collaborative multidisciplinary approach, and it offers a safe and effective alternative to surgery in appropriate patient with aortic stenosis with rapid recovery and favorable clinical outcomes. And the Manta vascular closure device provides a safe, effective, and a time-efficient solution for large bore femoral arterial access closure in transfemoral TAVR procedures. It minimizes vascular complications and supporting rapid patient recovery, as vascular complications are the most common complication we see in patients we do TAVI and TAVR. Thank you.
It's a very interesting closure device for large bore. What was the size of your introduction catheter in French? 20, 22, 24? What was the size of your introduction? The size in French.
Like the Manta device,
The size of your sheath, introducing sheath. Do you understand?
it was 14 French, sir.
Did you do the procedure yourself?
No, sir, I was assisting the procedure.
Oh, so you don't remember the size of what you closed? Can you help me?
14 French.
Only?
Yes, sir.
With which device you did the TAVI? The Cribier, the...
My wall, sir, my wall.
My wall.
Oh, even better.
Merrill.
So your comment, sir?
Yeah, it's a good thing.
We have 30 seconds.
Yeah, we have moved from using devices for this closures. Simple things we were doing, 8-stitch and all that. But these are very easy, and large bore things needs to be closed with device because the procedure goes on well, but we end up with this complication. Manta experience is latest and it's good. Thank you.
Manta is more expensive than per close, the cost wise. And here the result, you see that femoral flow is very slow. What do you think that? What is the reason? Slow flow, the punter side. What is the chance for thrombotic occlusion in Manta post procedure? Occlusion vessel.
It's rare. It's rare. Mostly we don't see.
Don't torture him, please. No torture. Can you introduce the next? Thank you, sir. The next.
Yeah, thank you. I welcome the next speaker, Anupam Bhambani from Patna, stenting in intrahepatic Budd-Chiari syndrome. Dr. Anupam.
Bonjour, madame. Bonjour. You have 5 minutes. Keep on time, please.
Thank you. Very good morning to everyone here. So my case is, it's a case of a young lady with Budd-Chiari syndrome. Clinically, this was a 23-year-old lady with chief complaints of vague upper abdominal pain and discomfort for preceding 6 months, mild abdominal distension. Labs were mildly elevated liver enzymes and elevated INR. Bilirubin was normal. Ultrasound revealed mild hepatosplenomegaly, minimal ascites, predominantly in the pelvis, and mildly altered liver parenchymal ecotexture with diffuse coarsening. There was a tight stenosis observed by the radiologist, or also we call it a web, at the hepatic venous confluence and IVC junction with multiple veno-venous collaterals. So this was the ultrasound abdomen showing a web between the hepatic vein confluence and the IVC, and this mosaic shows turbulence at the IVC where it should have been connected to the confluence of the hepatic veins. This web measured 1.3 centimeters, so it was a thick web. Venogram was done using internal jugular vein access, it showed multiple veno-venous collaterals, and after repeated attempts by the radiologist, he could not enter the hepatic vein from the IVC. So he understood that this was not possible, so he referred the case to cardiology and asked us to help. So what we planned, we kept from internal jugular vein, we introduced a sheath, 10 French sheath, and we kept where we expected the confluence junction between hepatic vein and IVC to be, and then hepatic access was taken percutaneously, and then the catheter was placed at the confluence so that we could know where the two were meeting, the catheter coming from superior vena cava into inferior vena cava and the hepatic confluence. So this was the point where the connection was supposed to be. Access into inferior vena cava using hard end of the 0.032 inches pterymohydrophilic wire was taken, and the hard end was used to puncture the confluence and from hepatic vein to enter into the inferior vena cava. Followed by this, the wire was exchanged. The catheter was, of course, advanced to exchange the wire, and wire was exchanged for an 0.35 inches pterymo wire again. Wire advanced deep into the IVC with a J tip forwards this time. Snaring of the wire was done into the internal jugular vein because the stent has to be facing upwards because of the anatomical direction of the structures. But it was not possible to advance the bulky stent over the pterymo wire, and a super stiff wire was required. So through and through access was taken with pterymo wire. However, we could not advance the super stiff, the bulky stent. So the Picard catheter, which was entered from the percutaneously from the hepatic vein, was advanced over pterymo wire again, and it was advanced up to the sheath into which is coming from the superior vena cava. Now, exterior to exterior loop was established between the hepatic vein and the internal jugular vein. So this was the loop. Following this, a super stiff wire was advanced through this catheter from superior vena cava end and was exteriorized again through the hepatic vein puncture site. So here, this is a Picard catheter into the long sheath into internal jugular vein, and super stiff wire was exchanged. Balloon dilatation of the stenosis was achieved, but collaterals persisted even after balloon dilatation, so it was necessary to stent the lesion. A self-expanding bare metal stent 12 into 40 millimeter was deployed across the stenosis. The collaterals disappeared immediately after the stent deployment. This was the post-procedure day 4 ultrasound with good opening of the stent with color flow showing disappearance of the turbulence, and this was the 2D B-mode ultrasound. Post-procedure anticoagulation, initially with Clexane, followed by oral anticoagulation lifelong, is supposed to be continued in these patients. Prophylactic antibiotics were used during the procedure, and patient was transferred back to gastro team for further care. Take home, periodic follow-up with imaging is required because sometimes these procedures are to be repeated. Lifelong anticoagulations are the norm. Reintervention as and when needed. Good short and midterm outcomes have been observed in different studies, and long-term outcome studies are still awaited. Thank you.
You keep my micro open, please. It was a very interesting procedure, quite complex. How many people were working on the patient?
Other than my nursing and technician team, we were two, me and the radiologist, interventional radiologist. The radiologist gave me a hepatic vein access, ultrasound guided, after which I continued.
So you worked in a team approach?
Whenever needed, not always, but such complex cases, we do.
Second question, how long was the procedure?
About 1 hour.
Only?
Yeah.
So you were finally very fast. One more question in the panel during a few seconds. No, nothing. So thank you very much.
Thank you so
Thank you.
much.
Great case.
The next paper will be given by Ashika on a radial solution for femoral. Ashika, please. You have 5 minutes. Keep on time, please.
Respected faculties, today I would like to present a case which I would like to title as Small but Mighty, Radial Solution to a Femoral Challenge. My patient is a 68-year-old female patient with history of NSTEMI in February 2025 and had class 2 angina since then. She had a clinically normal CVS on examination and her echo showed EF of 52% with RWMA of LED territory. She was posted for an elective coronary angiogram. So for the coronary angiogram, initially we took a right radial access, but it was converted to right femoral in view of spasm. This was the angiogram. The left coronary angiogram showed a tubular eccentric disease of the distal circumflex and a diffuse disease of proximal LAD. We went on to proceed with the right coronary angiogram, but then the femoral artery was tortuous, and while torquing to cannulate the RCA, the 6 French JAR3 diagnostic catheter got kinked. So this was the kinked catheter. The kink was around 4 centimeters from the distal tip. Initially, we attempted to pass a 0.035-inch thermo wire through the catheter, which it failed to cross the kink. And then we attempted to pass a 0.014-inch coronary guide wire through the kink segment, which also failed to pass the kink. So we then attempted gentle torquing in the opposite direction to straighten the catheter, but still it failed to unwind the catheter. So the available bailout strategies that were there for us were: first was gentle traction in the with opposite torque, which had risks of catheter fracture and kink worsening if done excessively. We attempted traction, but still we failed to unwind. The second option was over a wire straightening. The risk here was if we attempt to pass the wire through the kink multiple times, there are also risks of fracture. We attempted to pass the thermo wire and coronary wire, still it failed. Our third option was snaring via contralateral left femoral axis through a sheath large enough to accommodate the catheter folded back on itself. But here, the risks were the kinked catheter here was a femoral catheter, and if we insert the snare through the left femoral approach, the snare will be parallel to the catheter in the aorta, which will make it hard to capture. And also, the right femoral was a tortuous one, so there was possibility that the left femoral will also be will also have a tortuous course. Our fourth option was to inflate a balloon near or inside the kink segment, but our kink was resistant even to a coronary guide wire, so we did not have an option of passing a balloon. And our fifth option was to go for a surgical retrieval. We attempted to straighten the kink by pulling down the catheter all the way to the right femoral axis, and we tried traction against the femoral sheath tip, but still the kink did not unwind. So we pushed it back to the aorta, and we went on to proceed with the rescue snaring. So, but then, as I already told, the left femoral, if we insert the snare through the left femoral approach, the snare will be parallel to the right femoral, the kinked catheter in the aorta, which will make it hard to capture. So, anticipating this difficulty, we went on to proceed with the left radial approach. Through the left radial approach, we inserted the snare, and the snare tip captured the catheter tip, and we proceeded to tighten the noose. But as we tightened the noose, the catheter got kinked at another distal point. So more and more we tightened the noose, the kink got further hard to unwind. So we loosened the noose again, and we gave alternate torquing at the right femoral axis and left radial axis alternately. Keeping a light hold of the noose at the catheter tip, we then went on to pass the hard end of the thermo wire through the kink segment. Luckily, the hard end of the thermo wire could pass through the kink segment, and the catheter tip got straightened. The catheter was then pulled out through the right femoral axis, and we proceeded with the right coronary angiogram. She underwent a PCA to LED and LCX in the same sitting itself. So the take-home message here is kinking of diagnostic catheter is most commonly associated with a radial axis, but then, however, this is a rare case where the femoral catheter itself got kinked and the radial axis was used for successful retrieval. So selection of access site for snare introduction is important to facilitate capture of a kinked catheter. It depends upon the location of the kink and site of the anticipated capture with the snare. Thank you.
Thank
have
you very
only
much.
one question. It's rare to have this kinking.
Sir,
So why do you think this happened?
sir, our hospital has a policy of using the catheters for 3 times, sir. We
Yeah,
sterilize
so
with
reuse
ETO.
is,
Sir.
it's quite common that we reuse and we get into this issue. Thank you.
In my
Thank you.
institution, if something goes wrong during catheterism of the coronary artery, because you had a long procedure and you spend a lot of material, I call my standby surgeon, and he does the mammary artery with sternotomy. Maybe it's a good solution to work in that way. What do you think?
I endorse that. I'm from AIMS, and we always have a standby anesthesiologist for a monitored anesthesia care. And the OT is kept standby because any case which too much tortuosity in a high risk PCI, wherever you are, the backup of a cardiac surgeon is very, very essential. And many times, these are the cases you were lucky you got through and
Yes,
you pulled out, and your technique was foolproof and it helped you. But there's cases where you create an MR worsening or an VSD rupture in such cases, and those are the cases where a cardiac surgeon is imperatively needed.
Anyway, she did well at the end.
That's the
Thank you very
clapping.
much.
That's the clapping. Thank you.
Next.
Next case by Dr. S. Vishnu, tackling PCA challenge with the balloon.
Good morning, faculties. Today I am here to present a case tackling PCA challenge with a balloon. A 64-year-old gentleman presented with effort angina functional class 2, dyspnea on exertion functional class 2 for 6 months, hypertension since 10 years, no addiction, and recent NSTEMI, which was managed medically, and ECG, sinus rhythm 75 beats per minute, T inversion 1 AVL V5 V6, 2D echo, EF 74% with no RWMA, concentric LVH, and mild MR. So we proceed with the coronary angiogram, which showed 2 vessel disease of LAD L6 and minor disease of RCA. LAD 3 mm osteoproximal LAD, diffuse disease maximum 90% with calcification, LCX 2.75 mm CTO, JCTO 2, OM2 2.25 mm vessel with discrete eccentric 90% disease. And so we plan to do a PTC to LAD and distal OM2. Floppy wires were parked in distal LAD and distal OM2. OM2 lesion pre-dilated with 2 into 12 semi-compliant balloon, followed by LCX OM2 stented with 2.5 into 29 drug-eluting stent, followed by post-dilated with 2.5 into 15 non-compliant balloon, and a final TIMI3 flow was achieved, and the procedure was uneventful till then. Then we proceeded with the PTCA to LAD. LAD lesion pre-dilated with 2 into 12 semi-compliant balloon at 6 atmosphere for 10 seconds, followed by 2.5 into 15 non-compliant balloon at 16 atmosphere for 10 seconds due to heavy calcification. So while removing the balloon, we noticed only the metallic part came out, and the remaining, the transition part and the balloon was stuck inside the coronary. So for retrieval of this balloon, we wired D1 with a new floppy wire, and a new 2 into 10 semi-compliant balloon was dilated at 12 atmosphere for 10 seconds in the catheter with the transition part of the fractured balloon in situ. Here we can see the fractured balloon in the coronaries and the dilated semi-compliant balloon in the guide catheter. So we removed the guide catheter, the coronary wires and balloon as N block, and we retrieved through the right femoral approach. So still we can see the fractured balloon outside the gate catheter and the dilated balloon inside the gate catheter. So it is retrieved through the right femoral approach. It's coming out through the internal iliac artery, and through right femoral approach we have removed, and no parts were seen remaining. Then we proceed with PTC to LAD. The LAD lesion again wired with floppy wire, mid to distal LAD stented with 2.5 into 26 drug eluting stent, followed by LM LAD stented with 3.5 into 36 drug eluting stent, and a LMCA port done with 4 into 15 balloon. And a final TIMI 3 flow was achieved. So, in a case of balloon shaft fracture, first we have to inspect with a fluoroscopy. If the balloon shaft is within the guide catheter, balloon trapping technique can be done using a 2 mm balloon for 6 French and 2.5 mm balloon for 7 French. And in case of balloon shaft outside coronary, but outside guide catheter, it can be in aorta, then we can snare it out. If it's failed, we can go with surgery. If it is in coronary artery, we can snare it, or a surgery is a valid option, but a conservative approach is never advised. So, take home message: with balloon shaft fracture, first step is to identify where the fracture and whether a portion of the retained balloon fragment is inside the guide catheter or not. If inside, it can be trapped with another balloon and successfully removed as we discussed. If the retained balloon fragment is outside guide catheter, snaring of the retained balloon catheter fragment can be attempted. If the above mentioned technique fail, surgery should be considered.
Keep the mic on, sir.
Please, have you ever seen a fracture of the shaft of a balloon? I'm involved in technique since 30 or 40 years. I've never seen that. Is it the quality of the balloon, quality of the manufacturer, or something, a bad maneuver? What do you think? Tell me honestly.
Yeah, I'm from Jaydeva, where we do 250 to 300 angiograms per day and 100 to 150 PDCA every day. And we do face a lot of, this fracture of shaft, of balloon, and sometimes the stent, it gets skinked and moves and all that. So balloon shaft is a rare thing to happen. So, but do we have encountered? Probably we think one is the quality of the balloon. So a lot of companies are coming out, and other is this calcium was there, and we don't know. And other thing, the basic of cardiology is not to force or not to pull. So when we exert more,
do the people realize that you can kill your patient immediately by the occlusion of the balloon? So they were lucky to save the life of the patient. Congratulations. They did well, but difficult case. Next.
Thank you.
There is a question? No, you are the next.
The problem is because of reusability of the balloons, which are.
Who are you? Can you give your name and
I'm
your
Dr. Subhash, cardiologist from Anantapur.
What is your question?
No, the same thing. The problem is because of reusability of balloons in India, because the profile of the balloon is changed after first use. So it will be difficult, because that's why it will get stuck. Mostly in European countries, everything will be N balloons, all N material which is being used.
You reuse the balloon in India?
Yes.
Don't tell that in public, please.
That is the reason.
it's a common practice. That's why, see, this becomes a responsibility of the primary operator. See, we depend on the technician, we depend on the cath nurse, and we have to check every time before we even insert the balloon. We have to inflate and see whether, because reusable is still common, and it commonly happens with 3 size, 3.5 size. And I think in this case, more of, using a pull, we should never force. Thank you.
Next, we call upon Dr. Vishal Potni, Chivar, with a novel approach in an emergency situation.
You have 5 minutes, and please keep on time.
Good morning, chairpersons, and I'm presenting my case: a 66-year-old male patient, diabetic for 4 years, hypertensive for 6 years, and chronic obstructive pulmonary disease for 10 years. He presented with abdominal discomfort for 3 to 4 days prior to this event, followed by sudden onset giddiness, loss of consciousness, which was transient. He, however, recovered on time. He was taken to a nearby hospital and was resuscitated. Because of his loss of consciousness, he was taken up for CT brain and abdominal discomfort and abdominal pelvis CT was also done, and an incidental AAA with focal disruption at the right lateral aspect was detected, which was a large periaortic hematoma. He was immediately shifted to a hospital in an emergency room. His heart rate of 120 per minute, blood pressure of 90 in spite of resuscitation. He was conscious but disoriented, no focal deficits. And on evaluation further, he was detected to have a bicuspid aortic valve with an ascending aortic aneurysm of size of around 5.1 centimeters, descending abdominal aneurysm with concealed rupture. He was already in acute kidney injury, severe metabolic acidosis, and circulatory shock. So these are the CT aortograms. It's a long cine. Because of the time, I'll just skip and say this is at the juxta-renal position where there is an aneurysm involving the renals. It is involving above the renals, so it's more of a pararenal aneurysm. This is at its maximum diameter, which was around 9 centimeters. And prior to bifurcation also, it was still there. So the treatment options: open surgical repair, fenestrated endovascular aortic repair, chimney EVAR, or a hybrid repair. So if you look at the CT analysis for this, the superior mesenteric artery to aneurysm distance was 14 millimeters. So that's the proximal landing zone which we wanted to define. The superior mesenteric artery to aortic bifurcation was 153. The right CI aneurysm was a length of 52 millimeters. Left was 46. The renal artery origins patent arising from the aneurysmal segment, but the left renal artery was more posteriorly located origin-wise. The distal landing zone in bilateral common iliacs was adequate, and excess femoral arteries were suitable. So if you look at this, if we break up this is where the SMA to aneurysm distance, 14 millimeters, SMA to aortic bifurcation, 153. And if you look at the diameters, the pre-renal diameters aneurysmal segment was 26. That is the proximal landing zone diameter of 26. Just post-renal, it was 27. If you look into the mid part of the aneurysm, it is 82 millimeters. And if you look at the iliacs, it is 11.4 millimeters. So on an average, if you look at the proximal landing zone, which is needed to define, 26.1 was the diameter for him. Then the devices were planned accordingly: 36 contralateral limb, left limb, and right renals, and the left renals were covered stents. So these are the angio pictures. This is the difficulty in cannulating the left renal, which was evident throughout. So what we did was, the cannulation of left renal was performed via right brachial access using the mother-daughter technique. And it was not a routine catheters, it was an EBU 8 French catheter with a 6 French guiding catheter over the roadrunner wire. This was something which was a novel approach, because usually we don't use coronary guiding catheters for accessing these stuff. And once we got this, it was then a smooth ride. The cannulation of right renal was performed by a left brachial and using a destination sheath. And the usual steps of chimney EVAR was done. And if we look at the final deployment images, so these are the deployment images. We had a type 1 endoleak initially. So there is a type A endoleak through the gutters, which we post-dilated it and resolved it. So this was the post-dilatation. The simultaneous kissing balloon inflations in both the renal covered stents as well as the proximal landing zone, proximal sealing, and it was sealed off nicely. So if you look at the final picture, so these are the final pictures. No endoleak, all good. So the speed and availability is needed. CHIVAR is something which is the way to go. Alternative to open surgery, even addressing the hostile anatomy. Patients who are unsuitable for fever also can be done. And in ruptured aneurysms, definitely this is something which we need to do. So this case, we had difficulty in cannulating the left renal artery with the usual approach, and so had to adopt the mother-daughter technique, which is the telescoping technique, using the 8 French and 6 French EBU guiding catheters. We had to cut down the distal end of the 8 French catheter so as to allow the 6 French guide to pass through and achieve the desired length, and also to pass the covered stent. Corrected the type 1 endoleak on table and achieved a satisfactory result in such a sick patient. So emergency chimney EVAR is a valuable tool in the armamentarium for treating complex aortic aneurysms in high-risk patients. Thank you.
Very good case for chimney evar. But suppose you've done a fevar in this or a tevar. Did you do it because you had another kind of a catheter, the mother-daughter
Mm,
guide wire catheter, or did you do it because of the landing zones being adequate and your entire artery, the left renal artery, being a complex site?
So, had there been an SMA involvement with the aneurysm, I would have gone for fever in this patient.
Okay.
But because it was just the renals and we had a landing zone, proximal landing zone of 14 millimeters just below the SMA, so it was an adequate landing zone for putting in for a Chiva. So that was the reason. And also the patient was quite sick. Fever would have taken up, sorry.
I have a more fundamental question. You probably save the life of the patient avoiding the laparotomy. But how could you get the good graft in your room? Was it you have an emergency graft kit or what? How do you get the graft and how could you get it so fast?
So I belong to a city called Rajkot, which is in Gujarat, and it's 2.5, 3 hours away from Ahmedabad. So all the hardwares are there in Ahmedabad, majority of them, which is a major city in the state of Gujarat.
So you have
So within 3 hours,
you have emergency graft in the room.
yes, we could
So
easily
the
access.
patient was very lucky to find you because usually we order the graft and the graft is delivered. Probably use.
And we do quite a few complex cases like this, so we have a good access to all the covered stents and all, so, which is always there in our inventory in cath lab, sir.
Other question? Mesdames, Messieurs,
No. Thank you.
we must announce the result. Thank you, sir.
Thank you, sir.
Pardon?
This is the result of the semi-final of the case technique and review, best case competition. Number 1, Anupan Ban Ani. She had the advantage to be a lady. Number 2, our last speaker, Vishal. You were very close of Madame. Number 3, Srimant.
Srimant from Mysore.
Srimant, you are number 3. You could be proud of yourself. Thank you very much. Next session.
I met you in Morocco long years back, 5 years back. I'm Dr. Poonam from AIMS.
I know you,
I
but
met
why
you.
you arrived so late?
Why am I late? No, I'm for the second
sit down.
session. I'm for the second session. He asked me.
So the next session, I will not be part of it. I call Srinivas, Preeti Gupta, Vishal Poptani, Siddhant Trehan, Ponan Malhotra, Bharat Gupta, there is 2 Gupta, 2 brother maybe, cousin. Vishal Poptani,
Welcome,
again,
Raman.
you are a star.
Raman.
And Raman Shola, come to the podium and I go away.
Thanks a lot, Dr. Vis.
Put a note on 10 and be indulgent, please.
You set the ball rolling in a very nice way. Thank you so much. And I hope we too in our session stick to the time. I'm Dr. Poonam from AIMS, and I'm not a cardiologist. I'm cardiac anesthesia critical care intensivist. And I run the ICU for us at AIMS, which is 84 bedded. And we are up and down in the cath lab with more than 5,000 cases. And today it's my proud privilege to call one of the winners again for the cases. We have a set of 6 cases here. And these 6 cases would be presented in a time period of 9 minutes each. So please stick to the time.
Yes, it's very important.
That's very important. We'll stick to 7 and we'll ask a couple of questions. And I welcome all my colleagues. One by one, we'll be asking you. So your case is a drug-eluting balloon angioplasty for renal artery stenosis in a young girl with Takayasu arthritis presenting with encephalopathy press. So over to you, Srivat. And your time begins now.
Good morning, everyone. So coming to the case details, we had a 10-year-old girl who presented with multiple episodes of seizures to a pediatrician on evaluation. She had a blood pressure of 180 by 120, which is too high for this age of 10 years. So she was evaluated for this hypertensive emergency, and on evaluation, she was found to have bilateral renal artery stenosis, wherein the CT showed a right renal artery to have 90% stenosis and the left was reported as 100%. Celiac artery had 100% stenosis and there was abdominal aorta narrowing. So she was diagnosed as a case of Takayasu arthritis and she was requiring multiple antihypertensives, 5 at that point, and the BP was still 150 by 100. So ultrasound also revealed a smallish left kidney, ESR was 40 and CRP was 20 elevated inflammatory markers. So this is the CT scan which shows the right renal artery is almost 90% stenosed and the left is completely obstructed on this. So we then, with a smallish left kidney on the ultrasound and left renal artery being 100% occluded, we had the doubt of left kidney being viable. So we did a DTPA scan to this, which showed a relative renal function of 39% on the left kidneys and the right kidney was 62%. So we decided, so we wanted to be sure whether to intervene on the left or not to intervene on the left. So we didn't take her for angio under general anesthesia because she was not caught. Right femoral artery approach was taken and her 6F RDC catheter was taken. So the right renal angio showed 50% stenosis on the contrary to the CT which showed 90, and the left renal was 95%. And since the DTPA showed a viable left kidney, we decided to intervene the left renal stenosis and to leave the right renal for medical management. So we wired through a run through 0.014 wire and pre-dilated with 2.5 NC and at 14 atmospheres and 310 at 14. We did not want to be aggressive at this point because it was acute phase of Takayasu arthritis. Our aim was only to get the kind of adequate control of blood pressure so that she gets out of this episode, and then to give adequate immunosuppression and watch for the resolution. So we did gain a good luminal gain after pre-dilatation. So I wanted to avoid the stent for two reasons. One is the chances of ISR, considering she's too young, and making the if at all she has ISR and future surgeries is required, so that would make it more complex. So we did use a drug-eluting balloon 3x17 mosaic. It's a sirolimus eluting balloon, and it was inflated at 7 atmospheres for 60 seconds. And the luminal gain, we could get a good final result after doing a drug-eluting balloon. So we did a follow-up angio after 5 months. By this time, we had good immunosuppression, methotrexate and steroids. ESR was 10 and CRP was 3. So the current BP is 94/76, which is good for her age, and she's not on any antihypertensives at this point. So the left renal was having a residual stenosis of around 40%. Right renal was the same as earlier, which was a good result. So we did a OCT just for academic purpose. The rest of the lumen was all fine. So at the ostium, we had a dense fibrotic lesion with I'll just short it to keep up the time. This is having a fibrotic lesion just proximal after the ostium was the tightest point, which was having a luminal area of around 4. So and at the ostium, we can see it is all healed fibrotic lesion. So we'll do medical follow-up for her. So DEB in Takayasu arthritis is emerging as a good option. It keeps the patient like the ending's case options open for both surgical and endovascular intervention if the need arises again in the future. This is a disease known for relapses in the future. Thank you.
Renin-angiotensin hyperaldosteronism as a cause of resistant hypertension. And you did a good job and avoided a surgery. And the surgical results were 40 and 50%. I mean, your procedure results were 40 and 50% after the dilatation. So are you satisfied? And what is the follow-up of this patient?
Ma'am, it is acute phase, and Takayasu is, once you give immunosuppression, it is a case known for good collateralization, and they do good with immunosuppression. Over-aggressive dilatation would definitely lead in the acute phase for dissections and would end up putting a stent, and these are hard fibrotic lesions. So they'll not yield without a cutting balloon, and aggressive dilatation can end up with more and more complications.
Did you add some antithrombotic for follow-up?
Yeah, we have kept her on aspirin for that.
Did you contemplate to use a scoring balloon in this prior to
Sir,
the
it was in
drug?
the acute phase. I did it in the acute phase. So my aim was just to reduce the BP at that point. So acute phase will always be having more complications. If it were to be in the chronic phase, if now she develops, comes back, I'll definitely use a cutting
No,
balloon.
but the recent practices which we do is always use a scoring or a cutting balloon and then use a, because we need to at least get to at least 1:1 of the artery. If you had used a 3 mm balloon, it was a sizable 4+ vessel if you look at the OCT. So we don't need a cosmetic result. We need.
This was a follow-up, sir. The follow-up, I didn't do anything because our BP is anyways controlled. So we didn't have any this thing.
So a cutting balloon prior to DEB is always indicated.
That will be my option, considering if she had come, whatever the follow-up angio would have been my first angio, and she had uncontrolled blood pressure, I would have definitely went ahead with cutting balloon and.
Agreed. Thank you.
Secondly,
this was a follow-up OCT. This was not done in the
still,
first
IVUS,
case.
large vessels, IVUS tends to do better. Secondly, if you want to deliver drug-eluting balloon, whenever we're trying to escape a scaffold, it's good to do imaging prior to using whatever device that we're using. So
No,
that's just about it.
the first intervention was done in the acute phase. I would agree to that IVUS, but IVUS will not give us the information with regard to the intima. I was more interested into seeing what kind of the lesion it is, and for it was done purely for the academic purpose, not to plan the procedure.
Yeah. See, one way of looking at it is once you are saying it's acute lesion, what is the indication of intervention in acute lesion? Let me give you a statement. Let me give you a statement, please. If patient has acute lesion, acute activity is going on, basic method is give steroid for 4 to 6 weeks to see what happens. And significant number of patients do actually automatically becomes normal. Even renal becomes normal. So if you say indication was acute lesion, you could not dilate to 1:1, that's not acceptable. Once you're saying acute lesion, why do you intervene then?
No, acute because blood pressure was not controlled.
See,
And she had
150 blood
presented with
pressure,
press.
if you are taking one antihypertensive, 140, 150, if you give steroids for some time, about 2 to 3 weeks, watch again.
No,
I am
she's a 10-year-old girl, sir. 150 is too high for a
That's
10-year-old.
fine, sir. Acute lesion, you should not intervene unless you have given steroid for 4 to 6 weeks to see how the renal artery respond. Number one. Number two, if you want to intervene properly. Lesion was 50% still residual. That it is not going to benefit significantly.
No, sir, I would like to correct here. One of the indication, class 1 indication in Takayasu in acute phase is uncontrolled hypertension, which is not being controlled with drugs. That is one of the class 1 indication. So that was the indication for this. And that is to reduce the blood pressure. This was, you reduce the things, not to put a stent was the goal.
Also,
and
your
that was
patient
done.
had press. The
Yeah, it was
encephalopathy,
press was the class 1 indication. He was throwing
worsens with
multiple
ongoing
seizures, so I
hypertension.
had to intervene. So we had no time for like 4 to 6 weeks.
Did you give steroids afterwards with the
Yeah, steroids and
antithrombotics?
methotrexate both were given.
Thank you.
Yeah.
Thanks a lot. We call on, continuing with Takayasu's, on our next case, hybrid AVAR in Takayasu's by none other than Saran Mohan from Bhubaneswar. Welcome, Saran.
Praise presentation is hybrid AVAR in Takayasu arthritis. Myself, Dr. Sharan Pranvan, Department of Cardiology, AIMS Bhubaneswar. This is a 27-year case of Takayasu arthritis on oral steroid and azathioprine, presented with shortness of breath. ACR Euler score was 10, ITA score was 15 for active Takayasu arthritis. ECG was showing sinus rhythm will be LV strain, echo, mild LV dysfunction, and mild EMA. One CT angiogram with 3D image construction was showed multiple pseudoaneurysm in the infrarenal aorta, 20 mm distal to the renal artery. PET CT showing metabolic inactive circumferential wall thickness in the aorta with multiple fusiform aneurysm in the abdominal aorta. There was no active signs of diseases in PET CT. So our plan of management was interposed graft. The pros was immediate and 5-year patency are similar. Cons was more immediate mortality. EVAR was not possible in this case because there was diffuse lesion in the right iliac SS. So our plan for EVAR management was not done this thing. So we plan for hybrid procedure. So in that immediate and 5-year patency is similar. So this was the procedure detail. A diagnostic angiography by 6 French pigtail catheter from left radial with 0.35 thermo wire was crossed the aneurysm by 5 French JR from the left femoral artery. The Endurant 2 stent graft system was taken from the left femoral access, positioned with angio from the pigtail. So Endurant, this was the cine image of Endurant stent graft deployed from the infrarenal aorta to the left common iliac artery. Final cine after stent deployment. So after that, we passed the case over to the CTO surgeons. They did a femoral bypass surgery from the left femoral artery to the right with 6 mm ringed PTFE graft. So follow-up CT, after 1 month, we found that a type 2 endo leak was present. So this was the procedure. We did an angiogram for the type 2 endo leak, but we found that it is like there was no increase in the sac size, and the patient was managed conservatively. So on follow-up after 2 months, we patient on hybrid EVAR. Patient was on dual antiplatelet and treatment for Takayasu arthritis. Patient complained of swelling and pain in the back of the right knee. Ultrasound revealed a large right popliteal pseudoaneurysm. This can be associated with Takayasu arthritis. The CT angiogram of the lower limb followed by, we are planned for CT angiogram followed by thrombin injection. This was the ultrasound of the popliteal artery pseudoaneurysm was present. This is a swelling or ring yang sign and to and fro signs. CT angiogram showing a large saccular outpouching 5.2 into 6.3, 0.3 centimeter right distal popliteal artery. So course of management, patient was managed conservatively with antibiotic and analgesics. Patient was to inject thrombin percutaneously into pseudoaneurysm. However, it spontaneously thrombosed. And patient was discharged on dual antiplatelets and DMARD for the Takayasu arthritis. This was the completely thrombosed pseudoaneurysm. So Takayasu arthritis involving isolated infrarenal aorta with multiple aneurysm is rare. Treatment motion, open surgical interposed graft to aneurysmal part and femoral graft for occluded right common iliac with more immediate post-surgical morbidity. Stent graft to the aneurysm part followed by same setting femoral graft for occluded right common iliac is less invasive. So hybrid procedures has compared result to surgery both for immediate and long-term patency using Takayasu arthritis disease with modifying drugs and NOAC, and antiplatelet. SSIT issues may happen during initial procedure or during follow-up. Monitoring after EVAR can be handled well with early detection and needful intervention. Thank you.
We do as well. Hybrid procedures and hybrid OTs are the need of the hour today. And to decide which case is the team, multidisciplinary team approach, where the cardiac radiologist, the cardiac surgeon, the anesthesiologist all take part. And as an anesthesiologist, I've seen I'm both in the cath lab as well as in the hybrid OR with the same patient. Did you do it on the same day or did you give it a week's gap or 2 days gap between
No.
the two procedures?
Same day, ma'am.
Same day.
Same day.
So we give a day's gap. If we've done the cath lab today, we'll do the thoraco-abdominal next day in the OR. And then next morning, we'll do the thing. And our incidents like this for endo leaks that you saw are minimal. So not even type 1 endo leaks are we seeing in our last 10 cases, which we've done this year itself. So I work in a hybrid OR and looking at it, I think imaging plays such an important role and the role of the cardiac radiologist in our lives has become so important and using the right graft. I think it was a very well tackled case.
Nice case, congratulations. So, I mean, one question, which was the source of type 2 endoleak which you had in this patient?
Mostly like internal iliac, not internal, like internal, this collateral circulations was present and there was mostly the lumbar arteries.
We need to keep a close follow-up for that. Immediate, there was no endotension which developed or the increase in the sac size, but in follow-ups, we need to take care of that.
There was no increase in the sac size, so we managed it conservatively. We didn't do anything.
Thank you. Thank you. Sir.
Thank you, sir.
So for the third case, would invite Mr. Rajaram Rautu from Hyderabad. Emergency coiling of renal arteries for life-threatening bleeding.
Good morning, everyone. Today, I am going to present two cases which are iatrogenic renal AV shunts, that is arteriovena shunts. One is post-PCNL, that is percutaneous nephrolithotomy, and another second one is post-renal biopsy cases. As you know, this PCNL is mostly used by our urologist colleagues, and both the things, biopsy as well as PCNL, involves the piercing of the renal parenchyma and entering into this PCNL requires it needs to enter into the calyx to break the renal stones. So my first case is a 60-year-old male patient who presented with the complaints of fever, pain, abdomen, burning, micturition, and he was diagnosed to have bilateral renal calculi with obstructive uropathy. And he has got multiple comorbidities. He is a known case of IHD, underwent CABG. Right now the grafts are patent with moderate LV dysfunction, diabetic hypertension, etc. Finally, he with the diagnosis, he underwent double J stenting with the right PCNL. And 3 days after the post-op period, he was having severe hematuria. His hemoglobin was dropped from 11 grams to 6.5 grams. Initially, he was managed with the blood transfusion and conservatively. But after 12 days, when hemorrhage was increased, then he was subjected for the renal angiogram. So this is the renal angiogram. The left renal angiogram showing osteoproximal lesion is almost a critical lesion, 95% stenosis. But whereas right renal angio, you can see here the DSA picture. There is a early filling of the IVC, the filling of the renal vein followed by early filling of the IVC. This is the most diagnostic feature in the renal angiogram. So to diagnose the AV fistula. So then on ad hoc basis, we went ahead for the coil closure of this device, this AV fistula with the JR 7 French guide, with the support of the microcatheter, Vascular plus microcatheter and regular wire. We have passed that microcatheter to the site of the AV fistula. Then we have deployed 3 mm into 10 centimeters barricade complex coil at the fistula site. This is the detachable coils. So final result was good. And immediately we went ahead for the stenting of the left renal artery with the same JR guide. The lesion was crossed with the cyan blue wire, regular wire, and then pre-dilatation done with the 2.5 into 10 mm Tazuna and 4 into 12 mm NC-truck balloon. And then we have deployed 6 into 12 mm Herculean chelate stent. So this is the final result where a complete closure of the right AVF is you can see. My second case is a 58-year-old female patient who presented with anasarca. She is suffering from CKD on hemodialysis. She has got multiple comorbidities like hypertension, diabetes, etc. And she underwent a left renal biopsy for diagnostic purposes and then discharged subsequently after 2 days. Then after 7 days, she came back with a severe hematuria and then low hemoglobin levels. Again, we did the angiogram showing left renal artery AV shunt or AV fistula. So again, we went ahead with the regular wire. Free pass microcatheter was passed to the site. And then 3 mm into 12 centimeters per density coil deployed. And post coiling check angio, you can see complete closure of the AV fistula. So iatrogenic or traumatic renal AV shunts are usually defined as single pathological communication between the renal artery and vein, and its incidence is 7.4 to 11% after renal biopsy, but only less than 1% requires some kind of intervention. So usually the patients presents most of the times asymptomatic, or they come with the reduced hemoglobin levels or massive hematuria, low blood pressure. If there is any perinephric hematoma, then they complaints of abdominal pain or flank pain. And if it is a chronic AV fistula, then patient may present with hypertension and high output failure. And persistent hematuria, if we cannot treat it, then it is a life-threatening condition. The risk factors for AVF is the diabetic, hypertension, or using of the large bore needles for the biopsy sake, renal fibrosis, etc. And during this renal stones, it is the large stones which causes the more incidence of AV fistula. Usually, it is diagnosed by the ultrasound with the color Doppler, or contrast enhanced MDCT is the best. If it is not available, then MRI can be used, but the gold standard is DSA. So catheter directed treatment with the use of coils or liquid embolics is minimally safe procedure, and it is safe and effective. If coil embolization fails, the resection of the fistula with vascular repair, partial or total nephrectomy may be used to control the hemorrhage. So the procedure, what needs to be taken is based on the number and size of the feeding arteries, fistulas, point draining veins, and then shunt flow, etc. And these are all the various things available, gel foams or coils or liquid materials. Thank you.
Gel foams versus ethanol. Have you tried the difference, the rate of failure in the coiling?
Yeah, actually, we have not used any gel foam, madam. In this renal. Always we go for the coils because gel foam rates, the recanalization rate is almost 3 to 5% recorded in the literature. Because incomplete closure, sometimes heavy flow, torrential flow through the AV fistulas and all those things. So those are all, most of them, the failure rate is 3 to 6%. So that is the reason either you combine with the coils with the gel foam.
Gel foams, yeah.
That is more better if
Especially
you are
when
not able to control with the.
especially when the collaterals are great and the
Yeah.
bleeding is uncontrollable.
Yeah.
And ethanol, along with it, is a very, very good hemostasis agent, which is surprising, but it does wonders. Tried it in 8-10 cases by the cardiac radiologist, and we found good results, especially in the adults who are more prone to
Congenital
bleeding.
AV malformations with the nidus.
Yes.
The nidus is better for all these things. But simple, this AV, fistulas and all those things, most of the times we can get away with the coils. If necessary, once in a while, we can use this gel foam and all. But
Well
as
tackled
you said
case.
rightly, the congenital AV malformations will have a nidus, large nidus, which requires multiple usages.
Agents, yeah. Any
As you have done very good cases, you should go to be as super selective as possible to that particular branch. Try to avoid kidney infection. As Madam has suggested, I think I have used a lot of gel foam with impregnated with alcohol. Absolute alcohol dipped in gel foam, the material particle that acts beautifully in spite of coils. So I'll prefer that because that might save renal artery in future if we recanalize. That recanalize will not open the AV fistula again.
No, I think there's an inhibition to use it. There's an inhibition. We're so used to the coiling that there's an inhibition. But if you have the armamentarium ready and your mindset accepts it and you see literature proves it, then you'll be seeing many cases in literature which says that gel foam with ethanol is equivalent or maybe better with coil. Sometimes you may need all three. That's what I wanted to emphasize.
I did recently, I did out of the context, but I've gone for the urinary bladder hemorrhage. There is a severe hemorrhage. Then I went for the gel form embolization. I felt it is not that
It didn't go well. Maybe some cases
I
and
think,
depends on the
as I
collateral.
searched
I
the
think,
literature,
first of
almost
all,
the failure rate is, recanalization rate is almost 3 to 6%. So,
I think whenever we have to sort of close off something, best to go to something which you're most comfortable
yeah,
with
yeah, more comfortable
instead
and more
of
reliable.
trying different things. And just one more thing, that in the first case, maybe we could have done the left renal artery on a different day, because we want to keep a prothrombotic environment. And if we're going towards the left artery side at that time, I mean, we can come back another day. Patient was living with CKD and that 90% left side stenosis for a long time. So, but I think great. It was salvaged well. Patient did hemodynamically excellently.
Both cases tackled well.
you.
Congratulations.
We call upon our next speaker. Giant left coronary artery aneurysm in a young female with Takayasu's. Aarti Mishra.
Good morning, Delhi. I am Dr. Aarti Mishra. I am representing Mumbai here. I am presenting this case which I have done with my guide, Dr. Nagesh Wagmare sir, from Bombay Hospital. The title is Giant Left Coronary Artery Aneurysm in a Young Female with Takayasu Arteritis. It's a rare case association. So we got a 34-year-old female who was evaluated previously for dyspnea and fatigue, and subsequently she was diagnosed as a case of Takayasu arteritis based on her CT aortogram findings. She was found to be having severe aortic regurgitation, so referred for coronary angiography and CAT study to us. So this was her CT aortogram, which was showing aortic dilatation. It was ascending aorta dilatation as well as aortic arch dilatation. In CAT study, we found there was grade 3 aortic regurgitation. While performing coronary angiogram, there was a surprising finding of a giant left coronary artery aneurysm. When we tried to engage right coronary artery, it was 100% occluded and receiving retrograde collaterals from LAD. So this was the picture where we got a very large left main coronary artery aneurysm. It was measuring around 15.4 mm, huge coronary aneurysm. It was left side. So this is the still image of the same giant aneurysm. This is the depiction of the same picture in different views. Along with the left main, the proximal LAD and circumflex, they were also aneurysmal segments. And the arteries were calcified as well. When we tried to engage the right coronary artery, we were not able to engage, and it was 100% CTO lesion, and it was contralateral filling from the contralateral LAD side. This is the aortogram where we took the views for subclavian artery, common carotid artery, and we got finding that even the right subclavian was fibrosed and it was stenotic. This was the aortogram till renal arteries, and there was also additional findings on the right renal artery stenosis as well as left renal artery stenosis. And this was the aortogram which we took during cath study and angiography. It was showing a dilatation of the aortic root. Aortic root was dilated to 50.67 mm. This is the renal angiogram. So in this case, my point was to tell a giant coronary artery aneurysm. In Takayasu arthritis, usually we get stenotic lesions. However, getting coronary involvement itself is 10%. Whenever we get coronary involvement, it is usually in the form of stenotic lesion. Usually proximal ostial stenotic lesions are detected, and very few cases, 1.45% is the prevalence of coronary artery aneurysms. And if we get in a young patient, in a normal young patient, whenever we get coronary artery aneurysm, they are usually right sided, but in Takayasu we get such findings of left coronary artery aneurysm. So this was a rare finding. This is a rare of the rare case, so I have to present this case for out of interest. This case demonstrated coronary aneurysm in Takayasu arthritis, which is an atypical finding. Previously, various case reports were there where there were aneurysms found, and the patients, along with the aneurysms, they suffered from myocardial infarction, right coronary artery aneurysm. Along with the left coronary artery, there were subclavian artery aneurysm, but in our case, it was definitely a huger than the previously reported aneurysm. So it was 15.4 mm. So these were previous case reports where they have reported aneurysms. So learning point out of my case was Takayasu arthritis patient can surprise us with atypical arterial findings. Thank you very much.
Very good case, Sasha, and well presented to the point. We had a similar case of the right coronary artery, and we were surprised, and the aorta was beyond 55. And the patient had to undergo a surgical aortorenal shunting done with the conduit. And then an endoleak happened and was again revascularized in the cath lab. So I think you got away with without complications, and the aneurysm was well tackled by the
Yeah, ma'am.
team. It is a big congratulations. But I just want to say that whenever you see Takayasu, which is an inflammatory process, which has got some genetic turnovers, which is associated with so many other problems, the AKI that happens in the post-op period is disastrous, and the bleeding that happens on the OT table is something to be seen, because you don't know where the collateral or the aneurysm is going to open from. And aortic lesions need to be corrected first and foremost in these cases. So aorta and renal arteries both repair,
And
not needed in your case, is a big challenge, and you
Sorry to
did
interrupt.
well.
Before, ma'am, any big procedure, we have to see coronaries. Then we saw the coronaries are very surprising. And it was huge aneurysm, so our team decided to start with antiplatelet, single antiplatelet to prevent thrombosis. And
That
yeah. So we managed her with medical management. ma'am.
So the plan is medical management for her?
Yes, sir. Sir, 1 year we managed her medically with prednisolone, 40 milligram per day. And actually, unfortunately, after 1 year, she migrated to Nagpur. Then we lost her follow-up. But till 1 year, no surgical. But there was plan by CVTS team for aortic valve regurgitation. It was a grade 3 AR. But for 1 year, it was not done. They wanted to
No,
stabilize.
so LV is 42% or something.
No, sir. LV was good, sir.
LV is normal?
LV was normal, sir. Yeah. But
But you
AR
had a
was there.
dilated aorta, which will give rise to a severe AR.
Yes, sir.
And sooner or later, she will come for an
It was
AVR.
planned, ma'am. It was planned, but slowly it was in the process. But after 1 year, we lost her follow-up. Yeah, 55 aortic root. It was planned before. For that plan only, we did coronary angiogram. Otherwise, usually we avoid doing invasive coronary angiography in Takayasu. We prefer CT angio, coronary angio. But for this purpose, we wanted to assess AR also and coronaries also. So we took her up.
Any question?
Thank you
so
very much. Thank you on behalf of Mumbai.
Thank you so much, Dr. Aarti. Next, we would like to invite Dr. Logesh from Vellore, who's going to be presenting a case of a fenestrated endovascular aortic repair of a visceral aortic aneurysm in a patient with the stenotic aorta.
Good morning, everyone. I thank the organizers for giving me this opportunity. Special thanks to my mentor chief, Dr. George Joseph. So I'm going to present a case of fenestrated endovascular aortic repair of visceral aortic aneurysm in a patient with stenotic aorta. Case details. She's a 38-year-old female presented to us with intractable back pain of 1 month duration. She also gave history of dizziness on exertion and mild left upper limb claudication of 3 years duration. On examination, her left upper limb pulses were absent. Both her lower limb pulses were feeble. Her right upper limb blood pressures were significantly higher when compared to the left upper limb and both lower limb blood pressures. There was an abdominal aortic and bilateral carotid bruit heard in her. Her inflammatory markers were elevated. She was diagnosed with Takayasu arteritis type 5 in active phase. She is a known hypertensive on 3 drugs, and her echo showed moderate LV systolic dysfunction. This is the CT aortogram of a patient. You can see the left subclavian is occluded. The right subclavian had a aberrant origin from the proximal descending thoracic aorta, and it was normal. There was a long segment DTA and abdominal aortic stenosis. There were multiple saccular aneurysms in the abdominal aorta, and her left renal artery was occluded. Having a closer look into the aneurysm, you can see that the descending thoracic aorta and abdominal aortic stenosis was looking significant, and the abdominal aortic aneurysm looks complex with multiple sacculations. All the visceral arteries were arising from the aneurysm per se. Our left renal artery was occluded with shrunken left kidney, and it was non-functioning. We decided to do a fenestrated endovascular aortic repair for this abdominal aortic aneurysm as stage 1 and to do carotid procedure in a staged manner. While planning the case for the endovascular repair, we had few challenges in this case. You can see from the first picture, the neck of the aorta, the neck of the aneurysm is pretty small. So it's measuring only 7 to 8 millimeters in diameter. The smallest endograft available in the market is 22 millimeters, which is too big for this small aorta. So which endograft to choose was the first major challenge. And in such a narrow aorta, what cannulation strategies we should employ to cannulate the fenestrations was the second challenge. You can see the second picture, the vertical yellow line, which the arrow points, depicts how our stiff Lindequist wire will bias inside the aorta while doing the case. At the level of celiac artery, we can see that it's very close to the celiac ostium. So that means when we are deploying the fenestrated endograft, the endograft will hit the wall, so there will be no space to work around the celiac fenestration. So how to tackle the celiac fenestration is a major challenge in this case. Third, she had a single functioning right kidney. To preserve the right renal artery is mandatory in this case. With all these challenges, we did the planning, and we decided to do the fenestration. We chose an endurant iliac limb for fenestration. We used a 16-16-156 endurant limb for fenestration. 3 circular fenestrations for 3 visceral branches were made. Since all were arising from the aneurysm per se, we attached mini cuffs to all the fenestrations to improve the seal and reduce the chances of endoleak. The limb was resheathed then. So this is the baseline iotogram, which is similar to what we saw on the CT. So there was a baseline gradient of 40 millimeters of mercury across the aortic stenosis. Next, we went ahead to do pre-marking of the visceral branches. The celiac artery was pre-marked from the right brachial axis with the help of a 4FJR with a Filda wire. The right renal artery and the superior mesenteric artery was pre-marked from the left femoral axis. After pre-marking, here comes the deployment of the fenestrated endograft. With the help of the pre-marking catheters and wires, the fenestrations were oriented to their respective target vessels. After confirming their position in 2 orthogonal views, we started deploying the fenestrated iliac limb. As we can see in the first image, as the celiac fenestration popped out of the delivery system, we stopped deploying the endograft. At this stage, from the right axillary approach, we brought in a 6FJR with a stiff thermo wire and we cannulated the celiac fenestration. The red arrow clearly points out that there is a space around the celiac fenestration at this point of time because the endograft is in a conical position, which helped us in cannulating the celiac. Next, the SMA fenestration was cannulated from the right femoral approach with the help of a 6FGR and a stiff thermo wire. The right renal fenestration was cannulated with the help of a steerable Agilis sheath. We crossed the fenestration with Agilis sheath and then we got into the renal with the help of a stiff wire. After successfully cannulating all the fenestrations, we did post-dilatation of the aorta. The aortic lesion was cracked with a Conquest 12 mm balloon at high atmospheric pressures. After post-dilatation, we went ahead with stenting of the fenestrations. The celiac fenestration was stented from the right axillary axis, initially with the help of a balloon expandable covered stent, later lined internally with a self-expanding bare metal stent. The right renal fenestration and superior mesenteric fenestration were stented from femoral approach. So this is the final iotogram picture we got at the end of the case. The aortic stenosis was treated, the aneurysm was successfully excluded, and there was no endoleak, and all the fenestration stents were flowing and patent at the end of the procedure. On the fourth procedure day, she developed swelling and severe pain at the axillary axis site. We initially closed the axillary axis with a 6 French angioseal, which gave away, and she developed a axillary artery pseudoaneurysm, which was treated with a self-expanding fluency covered stent. She came for follow-ups at 6 months and subsequently at 12 months. You can see that the endograft had excellent positive remodeling. The aortic stenosis has disappeared and there is no aortic gradient then. All the stents were patent, all the visceral arteries were patent. The aneurysm was not seen anymore with no endoleak. She also underwent staged revascularization for her carotids. At 6 months, we did right carotid recanalization and stenting. And at 12 months, we did left carotid recanalization and stenting. She came for clinical follow-up at 18 months. She was asymptomatic then. There was no claudication. Her lower limb pulses were excellent. Both carotids were well palpable. Echo LV function is recovered. Her inflammatory markers were normal at follow-up. Her hypertension was well controlled with one drug. Coming to the learning points from this case, so Takayasu patients with complex lesions can be treated by staged percutaneous interventions, which we have published in JACC last year. And fenestrated endovascular aortic repair is feasible in patients with extremely narrow aorta. In such cases, an endurant iliac limb can be used for fenestration. Proper case planning is crucial for procedural success in such patients. Thank you.
Good good challenges met very, very competently well. And I think choosing the right limb and penetrating all the three vessels at the right time and doing a stage procedure helped. But was the patient induced with GA, of course?
Yes, ma'am.
And while you were on GA, did you extubate on the OR table or did you extubate
On the
in
day,
the
on the day.
CCU on the
On the day.
table? And the patient walked around on the next day?
Yes, ma'am.
Because femoral artery, if allowed to walk on the same day, which is IRAS protocol coming up in a big way today, even for cath lab procedures, gives disastrous results. And this is what I'm seeing the new challenges coming up with, that you develop good hematomas there at the groin. So give pressure and make them walk only next day. That's important, whatever you're doing next, but well tackled.
Thank you.
Very nice case. Could you elaborate the sizes of the stent grafts and the cuffs and the visceral?
Yes, sir. So the SMA and celiac was a 7 mm fenestration. We used a 7 mm cuff. And the right renal was a 6 mm fenestration with a 6 mm vascular cuff. And we have put 1:1 covered stents, and we oversized by 2 mm for the self-expanding bare metal stents.
Okay. And when do you cuff it and when do you don't cuff it?
So when the target vessel is in the aneurysmal segment, to improve the seal, we cuff it. And if it's in the landing zone or sealing zone, we don't cuff it.
Do you find any issues when you cuff it? The origins are compressed, the proximal.
So we
portion?
have a technique, sir. We avert it and then we suture it so that it doesn't fall in. So that on the day of fenestration, we make sure that it doesn't fall in. And even then, we use a 5-op roll-in to kind of avert it. So it can still break in and then it can fall. But based on the cases, scenarios, we have a wire loop so that even if the cuff falls in back, with the help of a wire loop, we get out of the fenestration. But in this case, we didn't have to use a wire loop.
Great case.
Thanks.
I think this is absolutely splendid the way it's been planned, and it was planned so well that it was extremely unlikely that you were going to fail. I mean, this is out of curiosity. How long was the procedure?
I think it didn't take much time. We finished in 3 to 4 hours.
That's great.
Full with full anesthesia.
Congratulations.
Yeah, really well, very well planned and very well managed case. Since how long? What antiplatelets she's on?
Sorry, sir.
What antiplatelets she's
So we gave dual antiplatelets for first 3 months and post that single antiplatelet for all the procedures.
Oh.
3 underwent 3 procedures for 3 months, DAPT followed by single antiplatelets.
Great case, well managed.
Do you shift to tisaglor when the patient goes home at a later stage?
No, ma'am. It's only aspirin
Only-
clopidogrel, 75.
Be doing that because we're seeing good results, smaller dose and not twice a day. But last thing, when you do a fenestration, is the distal landing zone easy to find? Because that's where the time happens. When you're doing 3 close grafts and 3 fenestrations, is the distal landing zone just as easy when vis-a-vis when you do it in a complete graft, a TEVAR without a fenestration?
No, ma'am. Doesn't matter.
Okay.
Thank you. Thanks.
Thank you, boss. Now we are going to invite the last speaker of this session, that is Dr. P.K. Ashokan. He's going to talk about coarctation of aorta in adults.
Good afternoon. So good morning, respected chairpersons, friends. And just presenting an interesting case of coarctation of aorta. Actually, you know that life history of coarctation of aorta, if you don't treat, more than 2/3 of patients die on third decade, then the subsequent mortality is around 6 to 7% per year. This is Campbell's. Now, this patient underwent surgery at the age of 8 years. We don't have any records. Probably end-to-end anastomosis at the coit segment. This 31-year-old male presented with acid hypertension elsewhere, diagnosed resistant hypertension despite of 3 antihypertensive medication, and he had headache, fatigue, and muscle cramp. And as is mentioned, a surgical repair of coarctation was done at the age of 8 years, and details not available. And presented with a significant coarctation of distal aortic arch, blood pressure in upper limb was 220 right side and left side is 130. There's a disparity. Lower limb is 100. And ECG showed evidence of LVH and strain pattern, and echo constant LVH, good LVH function, showed dysfunction. And CT aortogram, you can see that there's a coarctation of the aorta at the left subclavian ostial level. It's not just a notch below, probably because we are seeing a case post surgery. And no pattern PDA ductal tissue at the site. And bilateral subclavian arteries are present, left subclavian artery and proximal left vertebral arteries are dilated. And you see that this is a collateral and small early epicollaterals from the proximal descending aorta and no significant map cast. And there's a disparity in the size of rima and lima. You see that right side rima is dilated and left side and lima is small here, probably because there is occlusion at the ostium of the left subclavian artery. And you see that proximal descending thoracic aorta just beyond left subclavian takeoff is size is 23, and mid descending thoracic aorta is 22, and distal thoracic aortic diameter is 18, 19. It's very important to assess the size of the stent in this case. So mid arch, immediately proximal to the coax segment, this size is around 15 millimeter. Distant to left common carotid artery ostium to the proximal coax segment is 3.5 centimeter, and minimum caliber of the distal aortic arch at the coax segment is 8 to 10 millimeter. Length is short. And see here, and you can see that it's a coax segment here, and it's very difficult to cross a coax from the femoral side, so I have to do it from the right radial and to snare that thermo wire across the coax segment, then exchange with the arm large super stiff guide wire. Then using the snare, 15 mm snare, and we used for the procedures 12 French femoral sheath, Cook sheath, and a long sheath, then arm large stiff wire. Then actually to dilate this vessel, when that coax segment used the Atlas Gold, there's a barred balloon, NC balloon, 20 mm and 20 into 40, and cipher stent is a cobalt chromium stent, that is bare metal stent, and balloon expandable stent for this. And you can see that the stent is outside the sun, just to take the measurement. You can see the sheath here, and it's a deployment is a cipher stent, as I mentioned, that's a bare stent. And you can see that it's a coax segment. Here's a tight portion, and finally, slowly, the pressure of 10 ATM is almost expanded without any residual stenosis at the site. And here you see the RBB in this balloon is around 18, should not go beyond that. But actually, once you get that result, I think you have to stop inflation at the site. We got it around 10 at ATP. And this is the post-procedure angiogram, and there's no significant residual stenosis at the site. It's a coax segment, and stent in situ and covering the ostium of the left subclavian. The flow into the left subclavian is not affected. And CT aortogram. So this patient is totally asymptomatic. We could reduce the number of antihypertensive drugs. Then after 2 years came back as he was working in Middle East. Then echo showed a gradient of around 12 slight increase in the peak systolic gradient across the coax segment. Otherwise asymptomatic. Anyways, follow-up CT angio done here. And ascending thoracic aorta, ascending root is no significant problem. So here, what you can do, the coax segment where we extended, the stent is patent and no significant restenosis, no aneurysm. That's very important. After coax stenting, one of the complication usually you see is the aneurysm at the site, or you can have the dissections or thrombosis formation, a fracture of the stent. That's one thing that can occur in late stage also, maybe after a few months or few years. And here, none of the complication present, and aneurysm, that subclavian and vertebral artery is patent, and the size is not increased in that side also. because there's some small aneurysm in the proximal portion of subclavian artery that remains same. And this is the this one distal instant diameter is still maintained as 18 to 19. We deployed is around 20, and no residual is there. So what I would like to say here is requitation can occur. Follow-up of this patient is essential, and once there's a surgical requitation in adult, the treatment is the aortic stenting. There's a controversy whether to use the covered stent or bare metal stent. That depends upon the site of the lesion and choice of the, selection of the, it depends on the patient characteristics also. Suppose Turner's adult syndrome, there we have to use the covered stent. And if there is a branch, major branch, you can avoid covered stent. And if there is a atretic aorta, is where you have to use the covered stent. Otherwise, there's not much difference in covered stent and bare metal stents.
Thank you, Dr. Sokan. I think you tackled the case well. But something for the follow up that we've seen in some 100 odd cases of adult coax, they're very, very rare. But when they come, we do follow up for a lifetime because somehow we've seen that they don't live very long. These patients with interrupted aortic arch, even whether surgically or stented, do not have a very long lifespan. So follow up is essential, and something that really kills them is a stroke, intracranial berry aneurysm. Histopathologically, you've seen a lot of these are associated with genetic syndromes. DiGiorgi syndrome kills the hemostasis and the bleeding syndrome in these patients. So their platelet requirements, their some of them are Turner syndrome, the XO10 syndrome. A lot of syndromes are associated with the adult coag due to interrupted aortic arch. And I remember as early as 1999, when I joined as an assistant professor in AIMS, we did a series of cases, surgical versus stenting, in these patients. On the surgery table, they would die within 3 to 4 hours because of bleeding. At that time in 1999, hemostatic measures weren't great. Today, we have Planixa, we have hemostats, we have so many hemostatic agents, but not then. We have point of care testing today. But I think these patients need to be followed up for 3 reasons. A, the platelet dysfunction and the coagulation abnormalities, which are in plenty due to genetic disorders, they are associated with them, which get unnoticed. They come to a center like us, a tertiary center, very late. Secondly, the aneurysms that come up in the brain. And these are such small aneurysms that they give rise to sudden death due to stroke. So one has to be very careful when you tackle adult coact. Even a pediatric or a neonate coact is a difficulty to tackle, but an adult is one of the most disastrous on the OR, and you did it in the cath lab. Heartiest congratulations.
It's a great case. I think, like ma'am mentioned, that antiplatelet effect, anticoagulation effect is a huge problem in these patients in the long run. In fact, I happen to have one of our patients who has an arterial lusoria, happens to be an interventional cardiologist. I might know the doctor as well. So he's had multiple episodes of right arm thromboembolism, which is, and being an interventional cardiologist, it becomes extremely difficult. So what's important to understand is that whenever we're leaving a stent in a coax segment, it's on a bend. And whenever we leave it on a bend, we are always going to have some sort of a malapposition somewhere. And also, whenever we are in a bend with malapposition, the chances of having turbulence is going to be high. Every patient is going to react differently to these metallic scaffolds inside the body, and they might have a higher anticoagulation requirement. And so that's just one thing to follow up for the long term.
It's very important.
So I think, thank you, Dr. Sokan. Thank you so much. I think at the end of it, each one of the speakers did very well. Takayasu arthritis is on a rise. It goes unnoticed, and many cases go on till old age, and they die unnoticed and unobserved because renal artery stenosis with a small kidney is what makes them die, along with, let's say, a coagulation or maybe more than that, a stent failing or a stent fracturing or a OR hybrid procedure giving rise to bleeding and death on the table. I would request Dr. Popat to declare the result. We have first, second, and third position for the best speakers, and I would want him to declare it. You're okay with the result final? Yeah. I think all six of them did well, but I think if we have to declare the first, second, and third position, here they are.
Yeah, congratulations to all. All the cases were quite interesting. If we come to the third prize, goes to the emergency coiling of renal arteries for life-threatening bleeding, Dr. Rajaram. The second prize, the hybrid EVAR in Takayasus, Dr. Sarah Mohan. Congratulations. And the first prize, case of fenestrated endovascular aortic repair of visceral aortic aneurysms, Dr. Logesh. Congratulations.
Publish your cases. I'm an editor speaking here. I run the Journal of Cardiac Critical Care from AIMS. And any one of you wants to publish any of these last 10, 15 cases today, most welcome. The JCC TSS is the name of the journal. It's Scopus Index on its way to becoming PubMed Index. Thank you.
We close the session here. Thank you.
Thanks to the chairpersons, co-chairpersons.
The topic for this session is line case, line in box from Henry Ford Hospital, Rochester, USA. The expert panelists for this session are N. Khanna, Jams Guske, Vijay Rehan, Ramesh Dakovati, A.H. Srinivas, B.K. Asokan, Natesh B.H., and Vishal Koktan.
Yeah, may I call upon the speaker, Dr. Nishit Choksi. He will be joining from US. Is it Zoom? Yeah. The topic is endovascular arterialization of deep veins in no option CLI patients. And Dr. Nishit Choksi.
Good morning, and thanks for the opportunity to talk to this august group of people in New Delhi, and thanks to all the delegates. So what I want to talk to you about is a new life limb-saving, I should say, procedure for CLTI. As you know, this is Can you see my slides? Hello?
Yes, sir, we can see our slides.
Can you see my slides there?
Yes, we can see the slides.
I'm not able to move the slide. Can you move from there?
This is the live in box from the prestigious Henry Ford Hospital, Rochester, USA. We can see the slide, sir.
I can see the slide, but I'm not able to move the slide. Can you move it from there? Can you roll the slides for me, please?
Can anybody from the audiovisual team?
इंस्ट्रक्शन देने बोलो फिर So we are playing the recorded content from here.
Meanwhile, the audiovisual team is getting ready. Sir, can you just enlighten us on this endovascular arterialization of deep veins?
Certainly. So basically, these people are, they have no options left. They have no arterial blood flow going to the foot. They've had previous devascularizations, be it percutaneous or surgical, and then they'll come to a dead end with what they call the desert foot. It's mainly disease of these small vessels, small arterial disease, as they call it, SAD. And most of these patients may end up with amputation. So majority of these patients are Rutherford class 5 and class 6. And this particular treatment, which is called lymph flow treatment, is a methodology where they connect the artery, generally the tibial artery, to the vein in the foot, and thereby supply arterial blood from the artery through the stent graft into the foot. So that's the premise of revascularized, but then no vessels are left in the foot. So here we insert catheters in the artery and also from the vein below. And we connect, we make a creation, we create a connection between the artery and the vein, generally at the tibial artery level. We try to do it somewhat distal as much as possible, only because we don't want to disturb the collateral circulation of above. And then the blood flows into the blocked arteries of the vein, reaching the foot. The Promise One trial had about 32 patients, of which majority of them were Rutherford 5 and some of them were Rutherford 6. And it was a feasibility trial.
Sorry to interrupt, sir. We are at the global burden and patient suffering slide.
Okay. So as I think I talked about it a little earlier. About 3.8 million Americans have this problem with CLTI, of which about 150,000 amputations happen over the year, over year in year out. The mortality rate is high, and post-op mortality is also high. Next, please. Could you show me the next slide? Could you move the next slide, please?
So we have shared the slideshow from here. You can see it
I've
on
shared
one
it
of
to
the.
both the secretary and to the gentleman I talked to about an hour ago.
Yes, sir.
I've sent a PDF file, so this shouldn't be. This is just a video thing, but I've sent a PDF file, so that should be that can be played slide by slide.
Yes, if you can share it right now over the call, we can share it from here.
He's telling he has already sent it.
It's in a video form.
No, even the
so
PDF he has said yes.
Not the
Okay.
PDF, even the other one I sent, so you can see it slide by slide. Mhm.
So you can share the PDF file over the Zoom call, and I will try to share it from here.
I think Mr. Chowda has it, Rahul Chowda has it.
Just checking it.
Is Mr. Chowda loading it?
Just checking
So I
it.
just want to go step by step and show the procedure. It's once you see that, it'll be very easy for the physicians to do it back in India and elsewhere. It's not a very difficult procedure. It's just has to be done stepwise. So I just wanted to show that.
So sorry to interrupt you. So send your PDF on email, sir. We'll share it from here. You're sending the video. We have received your video, but video doesn't have the audio.
Okay, just sent it. You should have it now.
Sir, shall we play the video and I will be telling which slide it is? Can you just look at it, your laptop and have comments? So that the video will be running here and we can take
Yeah, I
the
could do
questions.
that. But I just sent it over the email, so you should have it now. I just sent it again.
Go.
Mr. Chowda, can you help us, please?
They are trying,
you
sir,
can go.
that.
You can start. Or share.
It was just working moments ago when he was on the line, Mr. Chowda.
Okay, you can go, sir. You can start the presentation.
So we are sharing the screen from here, and you can just instruct her to move to the next slide.
Okay, I can do that, but I will not know which slide you're showing.
So you will be seen.
So let me just go to the procedure itself. I think I already talked to you about the Promise 1 trial.
So can
Then
you
the
see
Promise
the
2.
screen share now? So you will not be able to move.
I've shared it a few times. I don't know how many more times I can share, sir.
So you can just have to instruct us to move to the next. Say next,
Okay.
and we'll move to the next slide.
All right. So let me talk about what is lymph flow. Can you see that?
Fine, sir. We are seeing.
Okay. So again, I said to you earlier, it's an innovative procedure. That's a very precise device that FDA approved a few months ago. It restores blood flow in the leg and the foot. It reroutes the blood from the blocked artery, usually the tibial artery, to the vein in the foot. And generally, we try to get the tibial vein in the foot. It's minimally invasive, so there's no surgery involved. It's last resort option when conventional therapies don't work. And it does decrease chance of amputation as evidenced by PROMISE 1 and PROMISE 2 trials. Next slide, please. So we insert a 7 French sheath in the ipsilateral femoral artery, common femoral artery, or sometimes you can go directly into the superficial femoral artery. And then we put a 5 French sheath in the plantar vein, the posterior tibial vein, lateral plantar vein. Before we do that, in the pre-cath lab area, we kind of map the vein in the foot. So when we take the patient in the cath lab, we know exactly where to go. Before we poke the vein, we put a little cuff right above the ankle, pressure about 30 to 40, so the veins get pumped up. And then, of course, under local anesthesia, we would put a 5 French sheath. It's very important to map the vein whilst the patient is in the holding room because the foot is very sensitive and you want to poke the vein in the single poke. You don't want to try multiple times, otherwise the veins will go into spasm and the whole procedure would have to be canned at least for a few hours. One can give nitroglycerin once the sheath is in. Once the venous sheath is in, we give about 2,000 to 3,000 units of heparin. And thereafter, we put the arterial sheath in the common femoral or the superficial femoral artery. And that's a 7 French sheath. Once that is done, as you can see in this diagrammatic picture, we try to make a connection between the artery and the vein, just like a dialysis fistula. Next, please. I think I talked about this earlier. PROMISE 1 trial, 32 patients, 97% technical success rate. This is a feasibility study. In this study, they included patients with dialysis. Next slide, please. Next slide, please. So the 24-month results of PROMISE 1 are very promising. There was 77% limb salvage and 88% complete wound healing in this group of patients. Of course, small number, 32 patients. Next, please. So PROMISE 2 trial at 107 patients, as I mentioned earlier, there was 69% limb preservation at 12 months with 92% of the patients having complete wound healing, which was the Rutherford 5 patients. It's interesting to note that these were the sickest patients, and in most of the previous trials for CLTI or CLI, they did not include patients on dialysis because the results are generally very poor in dialysis and stage renal disease patients. But in this particular trial, they did include those patients. Next, please. Next, please. Next slide, please. So here is our patient, previous slide, please. 57-year-old gentleman with history of diabetes. They tried to revascularize his leg ×2, amputation of 2 toes, new gangrene in the foot. The surgeons were planning to conduct above the amputation, and the arterial angiogram does not show any flow in the foot. Next, please. As you can see, the vessels are calcified. So this is the venous angiogram of the same patient, just to show the anatomy with the venous valves. It's very important to note the venous valves because during the procedure, we'll have to do valvulotomy, and I'll show you that. Next, please. So I was telling you earlier, it is important to map the veins before, so you don't poke the patients multiple times to get access. Then the local anesthesia, of course, and then a 5 French sheath is placed in the vein, which is the tibial vein extension into the lateral plantar vein. Next, please. So this is the arteriogram from above. We had placed a 7 French sheath in the common femoral artery, and we usually try to do it over a stiff wire because there's an angulation and you want to make sure that the sheath goes in easily. Once the short sheath is in, we extend that out to a 7 by 45 sheath so the tip of the sheath sits in the popliteal artery. Next, please. At this stage, a simultaneous venogram and arteriogram is performed to find out where the vein and the artery are the closest. Next, please. Once that is done, there's a V-seaver, which is like a snare that is advanced from the vein, from the foot, up into the area where the artery is close to the vein. And the arrow shows the deployed V-seaver, which is like a snare. It's metallic. Next, please. We then place an arterial catheter from the arterial sheath. It's called the ARC catheter, which is like the Outback catheter that has a needle on it. We try and bring it as close to the V catheter as possible. And once we are there, we then try to rotate the catheter so that the needle faces the V catheter, which is like the snare. And how do we do that? So when you fluoro, you will see a wider needle, and that points towards that shows that the needle is pointing upwards. Now, when you rotate it about 25 degrees or so, you will see a thinner version of the needle. That's where you know that the needle is pointing towards the V catheter, as you can see in the diagrammatic picture up above there. Next, please. So here's a needle that is coming out from the catheter and is now in the basket, which is the V catheter. Once the needle is there, we try to move the basket up and down to make sure that the needle is indeed within the basket. Once we are sure of that, we pull the needle back just a bit, and we put a 14 wire, 0.014 inch guide wire from the catheter through the needle into the venous system. We then pull the basket back into the catheter through which the basket was deployed, just like any snare. And then we externalize this wire through the sheath in the foot. Next, please. We would then dilate the junction between the artery and the vein, generally with a 3 millimeter, 3.5 millimeter balloon. Next, please. Here is what we are showing, the externalization of the arterial wire through the sheath, through the venous sheath in the foot. Next, please. So now we have a wire that extends from the artery through the vein into the foot and is coming out of the foot. Then over this particular wire, we place a valvular tome with a 14 wire. And once it is beyond the junction, you don't want to cut the junction. So once we are beyond the junction into the vein, we release the valvular tome, and then we do integrate cutting of the valves. So we go all the way down, and we have to do some aggressive cutting, particularly around the ankle where there are multiple valves. Next, please. This step is very, very important because if you don't cut the valves, if you don't lyse it, then your stent graft is not going to open fully. Once the valvulotomy is done, we dilate the vein with a 5 millimeter long balloon generally, and we have to make sure that there's complete balloon expansion. So if you can see that in the area where the arrow is, and just above that, the arteries, the vein is not completely dilated. We took a shorter balloon and went to high pressure, 20 millimeter pressure, and now you can see full dilatation, complete dilatation of the balloon. Next, please. We will then place the proprietary stent graft that the company has. This is a 5.5 millimeter stent by 200. Usually there will be a couple stents going into the vein, and you want to place the distal end of the stent graft at the border of the calcaneus. Next, please. And then, of course, the next stent would be proximal to that, and then the final stent would be a tapered stent, which is 5 millimeters distally and 3.5 millimeters proximally, as shown in the cartoon next to the angiogram picture. Next, please. So once the stents are in, the stents are dilated with a 5 mm balloon to high pressures. So we know that there's complete dilatation of the stent graft. Next, please. And then we will dilate across the stent into the lateral plantar vein, because we want to make sure that all the valves are open and fully dilated. Then advance the vial in the plantar loop. Next slide, please. And dilate the loop, as you can see on the right side of the image. Next, please. Once that is done, you can see arterial blood going to the lateral plantar vein. Next, please. So here you can see the connection between the native tibial artery, and then you can see the darker area, which is the stent graft.
Can we have
which
Dr.
is the
Ramesh on
process
stage?
junction, that is
Please.
the fistula connected between the artery and the vein. Next, please. And there's a final picture that carries arterial blood through the stent graft into the plantar vein. Next, please. So this is pre-lymph flow, 3-month follow-up, 6-month follow-up. It heals up very well. It is very, very important that we don't do primary closure of the transmet if that is done, because it is bound for failure. There will be more gangrene and ulceration at the suture site. So we like to keep it open. And it's very important to have a team of podiatrists, foot doctors, infectious disease doctors, pain management people, and of course the vascular physicians to work together to get ideal results. Next, please. There's another patient where the first two pictures are pre, and then the next picture is post. Next, please. And at 12 months, it's healed up completely. Generally, it takes about 6 to 8 weeks to start seeing some healing. Initially, the ulcerated area, the gangrenous area may get worse because of extreme swelling of the foot, and therefore it's very important to manage that very delicately, because if you put a tight bandage around it, then things will become worse. So of course, elevation of the legs and gentle ace wrap around the wound and around the foot would be very important. The only two reasons to go back in again is severe pain, which would mean patient may be getting ischemic, or infection. For follow-up, we would need to do vascular studies every 2 weeks and make sure that the flow is good. We are looking at a flow of 190 to 200 cc's a minute, or a velocity of 55 or more. If it is less, then there's an issue of decreased flow. Generally, it is at the junction of the distal edge of the stent and the plantar vein. So balloon angioplasty of that segment would generally take care of the problem. We like to use drug-eluting balloons if they're available. Next, please. So this is what the vessel should look like at day 0 and day 60. And what arterialization generally means is there is there's angiogenesis that happens, and it takes a good 2 to 3 months for that to happen. And after that, you get good healing, and you can save the limb. And next, please. So these are the 4 steps that you can see that we talked about. Venous access and valvulotome and dilatation of the artery and the vein junction, and then finally stent placement, balloon dilatation of the stent, and then a good flow. Obviously, just like any other vascular procedure, we give full dose heparin once the arterial sheath is in. We're generous with nitroglycerin, make sure there's no spasm, proximal or distally. These patients are on dual antiplatelet for a minimum of 6 months. And then we prefer to just give Plavix instead of aspirin, because they do have a high chance of having gastritis and esophagitis. As I said earlier, this procedure is approved by FDA. And obviously the experience is still limited. There are not that many procedures done around the country and around the world. So more and more data gathering is very important. Now, sometimes the flow is too much. You can see the shunting of the blood away into some of the branch of the vein beyond the stent graft. And that's very important to know, because if that is happening, then you're going to shunt blood away from the toes. And in those situations, you have to coil the vein. And generally, a 3 millimeter to 4 millimeter coil, those are plenty to coil these veins that just exit from the foot, from the lateral plantar vein. The close surveillance, both angiographically and by ultrasonography, is very important. One should be fully aware of how to perform, how to read these vascular studies. But the initial results are very promising. Of course, major limiting factor is the cost of this whole device. Although it can be done somewhat cheaper with off-the-shelf stent grafts, and instead of having a valvulotome, some people are using a 1.7 millimeter laser to cut the valves. So that can be done, and they have had good results with that. Still, the cost is high, but much less than when we use the proprietary stents. So I'll stop at that. If you have any questions, I'll be happy to answer them.
Thank you, sir. It was a wonderful case. Can I request Dr. Jacques, sir? Jacques Basquet, you are supposed to be here. Please, sir. Can you join us here? I also have, can we have some comment from Dr. Ramesh Dagubati, USA?
Yeah, thank you very much, actually, to Dr. Khanna and everyone for inviting us. And so, I mean, I think obviously these patients are very critical, and your critical limb ischemia and ongoing pain, and you said 0 to 60 days that's what you would like to see in the flow. But what if we do not see? What are the next steps that you would recommend? You would any role for any neoadjuvant gene therapies or whatever you're trying to do, stem cell therapies in that area?
So there's obviously no studies or trials suggesting that, or any results with that. Of course, the last-ditch effort, one can always try that, but so far I've not seen any study or any case reports suggesting injection of stem cells post lymph flow procedure. So I can't give you any particular answer. Having said that, at that point, the last-ditch effort, whatever can work, you can try. You should try, I should say.
Dr. Chuksi, you said you would use the valvulotome to knock off the valves before.
Correct.
Do you, after that, do you confirm by any arterial angiogram before taking the stent graft, or you take it for granted and just take the stent graft and place it across?
No, we take it for granted. Basically, we do an arteriogram, but arteriogram is limited because most of the tibial vessels are occluded below a certain level and not going into the foot. So arteriogram will only help us as far as where to connect the artery to the vein. We do venogram to kind of know where the valves are, but even that doesn't help us that much as far as valvulotomy is concerned, because we just run it from just beyond the AV connection all the way down into the foot. So, and it's a forward-cutting valvulotome. Pretty aggressive on the calcaneus, on the ankle, I should say, pretty aggressive, because that's where the bend is. And in fact, in my image, I wanted to point that out. If you look at the stent just above the ankle, it's not fully expanded despite us going to 20 atmospheres post-stenting and so initially post-ballooning, and then after stenting, we went to very high pressures, but we probably were not that aggressive doing the valvulotome. We made quite a few passes, I would say, at least in this particular procedure, but in this particular patient. But since then, we've used cutting balloon, a scoring balloon. If valvulotome alone, regular balloon angioplasty alone did not help us with complete expansion in that area. So yeah, we don't really take any, or not we, nobody takes any particular venogram or post-valvulotomy. So that is not necessary.
It's an excellent talk, Dr. Nishit. My question is, a patient has diffuse distal artery disease, leg arteries. This is excellent concept, and you're shown that is great salvage of the limb, and even healing of the wound is at the tune of more than 74%. My question is, if there is a long segment total occlusion, calcified, diffuse disease, and distal target arteries are good size, can we anastomose distally to the artery and bypass that graft here?
Yeah, but these are patients where all percutaneous or surgical options are not available. So there is no vessel in the foot. So connecting proximal vessel artery to the distal artery with no vessel going to the foot is not going to help us. Now, in the past, the surgeons did do in situ vein to artery anastomosis, but the results have not been that great. Dr. Ramaya may be able to tell us better about that, but that has been done for many decades and it has not worked out well. And therefore, this percutaneous connection between the artery and the vein with stent graft has been safe, effective, with less complications.
Thank you very much, Dr. Nishit Choksi. It was a wonderful live inbox.
A little better, but my apologies for that. But thank you for the invitation.
On behalf of the chair, we thank Dr. N. Khanna. We move on to the next session.
The topic for this session is ISEVS at Apvic. The expert panelists for this session are Jacques Bousquet, N. Khanna, Vijay Trehan, Ramesh Dattopati, and Rajiv Loche. The topic for this session is ISEVS at Apvic. The expert panelists for this session are Jacques Bousquet, N. Khanna, Vijay Trehan, Ramesh Dattopati, and Rajiv Loche.
Now we move on to IACVS at Apvic session. This has been a very constant session, and it signifies the camaraderie of IACVS and Asia Pacific Vascular Society. We have these sessions where we have speakers from both US and the Asia Pacific region, and usually it is sort of it used to be focused on the aortic diseases, but this time we have a different and a wider focus. Dr. Jacques Bousquet, who is an international ambassador both of Asia Pacific Vascular Society and International Society of Endovascular Specialists, is here to conduct this program. And we have 5 topics here. And I would invite Dr. Ramesh Daggubati, who's just arrived from US, to give his talk.
Thank you very much, Dr. Khanna, for giving me the kind invitation. Thanks, Dr. Jacques and Dr. Trehan for being on the expert panels. And thanks to our audience who are patiently listening in the early morning here. So I'll be talking actually, I mean, even though it says large bore access, it is actually TAVI complications and due to vascular disease. Okay. Sorry. Okay. So the vascular complications, the spectrum is actually wide, and it can involve mild dissection, perforations, thrombosis, avulsion, and closure device failure or pseudoaneurysms. And during TAVI, these complications can present at any time, and usually evident at the end of the procedure when large bore sheath is being removed. And meticulous attention to access site selection, obtaining vascular access, and also trying to understand vascular closure devices may prevent many complications. And obviously have to have high index of suspicion for certain vascular complications. So whenever a patient has any hypotension during the procedure, think about a vascular complication. Okay? Because these major vascular complications can increase mortality after TAVR. As you can see, about if a major vascular complication occurs, death is imminent in about 48% of the patients versus actually 26% of the patients in 12 months. And so, in whether cohort B, the partner, and cohort A, who are actually, that means the intermediate and low risk patients, still 30% death due to vascular complication at the end of 12 months, and which is really important to understand that we are taking a low and intermediate risk patients and giving them a mortality of 30%. So how does it matter the sheath and artery size? Actually, you need to understand that a sheath to femoral arterial size cannot be more than 1.05. So if it is an 8 millimeter vessel, that means the sheath cannot grow more than 8 millimeters, maybe 8.05. So this has been a predictor by VARC, which is a Vascular Academic Research Consortium, major vascular complications and 30-day mortality. Sorry, VALVE, Academic Research Consortium. So let's look at actually what we understand when people tell us about this is the 14 French sheath. So look at the inline sheets for Evolute platform. When we say that all of you probably are getting used to doing towers, and when we say 14 French equivalent, doesn't mean it's actually 14 French size. The outer diameter is 18 French. And when we say for the 34 millimeter self-expandable valves, we are using a 16 French inline sheath. That actually outer diameter is 20 French. Similarly, we talk about expandable sheaths, and 14 French E sheaths for Edwards balloon expandable valve grows into, when it expands, it grows to 24 French outer diameter. So OD is very important. So if it is 16 for the 29 millimeter balloon expandable valve, which is in US, it is our Edward Sapien. Here it is my valve. It is growing to 27 French outer diameter. I mean, we are actually very good. Recently, the clinical trial first in man has been completed, and so early feasibility study has been completed, and now we're going to start a clinical trial in the United States, which is actually going to go through 8 French sheath. But 8 French, it expands to 14 French. Okay, so truly 14 French that will be actually a revolutionary in the next few years. So prevention of vascular complications, I think, begins with ideal access. You need to understand the anatomic landmarks and review prior angiograms if they're available, review the CT scan, understand if there's a calcification. And just because there's no calcification in the anterior part of the artery doesn't mean that you will not end up with a complication afterwards. Even if it's posterior calcification, please be aware, not just at the point where you're going to stick, but even proximal to it. High bifurcation and the location of branches. And usually we recommend ultrasound guidance. We also use a micropuncture. And actually, when you advance the micropuncture wire, you need to visualize that under fluoroscopy, whether it is going into an inferior epigastric artery or actually it is going through the iliac artery. So because it can go easily into the branches. And consider alternative accesses, actually, which I think is something that we are pushing a lot at our institution. So step one, avoid blind femoral arterial stick, mandatory use of either ultrasound, and as I said, that inject contrast through the micropuncture sheath, which is 4 or 5 French sheath, and then only actually try to see if you can go with a larger sheath. And before you insert the large bore sheath, some people actually put in a safety wire. The safety wire can be from opposite side, up and over, and actually some institution they put a safety wire through the same ipsilateral. So two sheets are inserted, micropuncture sheets. The below one, actually they'll put a 7 French sheath and a V18 wire, and the more proximal one will going to be used for the large bore access. And then you deploy per close, whether you want to do 2 per closes or 1 per close, that is still debatable. But I think single per close for 14 French sheets have been okay for us. And if you go larger, like a 16 French or a 18 French sheets, then we go for 2 per closes. And the sheath removal is the final point, and after that you reverse with heparin with protamine, deploy the per close, and then additional per closes if need be. And if there is no bleeding, remove wire and hold pressure. And completion angiogram is a mandatory one. It has to be done. Even some people say we can just do ultrasound, and that's not actually enough. You need to do it on the DSA, digital subtraction angiography, and this completion angiogram is a must, even though ultrasound is good. So the feasibility of, at UPMC, which is very close to us, they looked at single per close femoral closure and post-TAVR after reversing with heparin and holding pressure, and completion angiogram was done. And these actually, for 14 French sheath sizes, we were able to show that single per close is good enough. And the mortality is for 14 French, so the delivery systems, most of them are 14 French for the single per close, but mortality is zero. And but the vascular complication interventions are still required in about 7% of the patients. So you have to understand that 7% complication rates or doing some other intervention is required. So let's talk about some case examples, because nothing is fun without showing my own dreaded complications. So here is a patient, and I did it in India, and 7.9 and 8 millimeters, 5.9 and 7 millimeters here, and in the iliac artery, and in the common iliac 7.4, 9.4. So we thought, okay, it's not bad, no calcium, not much, and so we should be able to introduce a sheath. And at that time, it was a 24 French sheath that was available for the my valve. So balloon expandable valve was, I don't know why it's not playing, was placed, so you can see that it went well. And post-implant, there was extreme resistance in sheath removal, which suddenly gave way, and finally sheath came out, but no later than the blood pressure showed immediate drop. And this is actually the dreaded complication that you don't want to see, iliac artery or femoral artery on a stick. So the entire artery came out. Okay. So after this, the obviously covered stents, balloon tamponade while we are trying to get the covered stents, and 2 covered stents later, and then actually I think it's there's patient actually had thrombosis requiring surgical cut down now, and had to have this kind of scar tissue, and but the patient survived after 2 months, okay, and skin grafting. So this is a patient in the US long time ago, 2014, I think. And actually, a patient is a relative of my research nurse, and Sapien XT was just approved at that time for valve in valves. And so we tried ballooning it, and balloon went well. And then we were implanting the balloon expandable valve. And as you can see, probably if you pay attention to the right side of the screen, the balloon suddenly deflates, and it is because the balloon ruptured. So I noticed that, and we knew what actually has happened. So balloon ruptured, and I said, okay, let's stop, pull back the balloon into the ascending aorta, and what do we do? Call your friends and find out what can be done. And they said, no, just it's okay, pull it out, and I pulled it out, and this is probably it'll show that entire aorta and iliac artery got just denuded, completely scraped. So after this mistake, I call a friend. If you call me, I'll tell you, do not pull the balloon back, because nobody knows how the balloon transects. This is the patient's balloon that actually transected like an umbrella. And so when you're pulling down, the umbrella is actually like open umbrella, and you're dragging the entire aorta and iliac. So this patient, we opened up her, a vascular surgeon was in the room, cardiac surgeon was in the room. We opened up her abdomen, trying to fix it, but unfortunately she died on the table. So after this, actually one more time it happened. We just actually pulled it into the ascending aorta, opened up the chest. Okay. These complications, such as similar, so another rupture and aortic occlusion balloon is implanted, then actually stented that iliac and femoral, and the patient was fine. So this is a patient with a large AAA, 7.5 centimeter aneurysm. We actually were enrolling this patient in Partner 2A trial, and they said, please don't enroll this patient with such a large aneurysm. So we did actually a EVAR first, and then after, immediately on the same time, after EVAR, we were trying to push the TAVR valve, and this is a Sapien XT valve, which we were struggling, and it's still, and after rotating the device, it went through. And so then after that, there was an endo leak. So, be careful when we push these devices through freshly placed. And but anyway, another stent graft was placed, and that was okay. So completion angiograms are very important. So when you see this type of calcification, I think you can actually do a balloon, POBAs everywhere, and then actually advance the sheath. I think that would be okay. and shock waves are actually have IVL become really good in these patients as well. Okay. So, but best to have more than one option is actually use alternate access. Now this was in the beginning we chose subclavian access, and after TAVR everything looks good. But probably now I would go for a transcarotid access is my favorite alternate access nowadays, and the right transcarotid looks good. So you prevent vascular complications with, I think, prolonged balloon inflation or a covered stent, and you can seal them with the vascular closure devices, but sometimes they may not be complete sealing. Okay. And ultimate temporary bailout, sometimes if everything fails, a coda balloon or aortic occlusion balloon is a mandatory for us to have in the cath lab for TAVI centers. Manta closure devices, obviously these are large bore, can go up to 22 French punctures, and they have entered into India as well. We have a lot of experience. Any vessel that is 8 millimeters and no calcium at all, Manta works beautifully. Okay, large vessels without calcium, I think is very good. So I told you about. So lessons learned, many complications may be prevented by strict patient selection and procedural planning, correct evaluation of the peripheral vasculature, calcification and extension of peripheral arterial disease important, and correct prosthesis for this patient, for that patient sizing of the devices also is important. And be friends with your colleagues, vascular colleagues, as well as cardiac surgeons. And so thank you very much. Mike.
Keep it open, please, during the whole session. Don't close it. Thank you very much for this very good appreciation of complication and prevention. You have to get everything on board during the procedure. Do you do that by yourself, or is it a team approach with a surgeon, or what?
So all patients should be discussed in a multidisciplinary team. So that about nearly all the cardiac surgeons, all interventional and general cardiologists will be in the room to discuss about that patient. So once that is approved, then we actually go and discuss again with the vascular surgeon, anesthesiology, and the structural cardiologist and cardiac surgeon separately, just a day before the procedure. So even though we have reviewed once, we'll review again one more time. And that is actually, we usually do at 4 p.m. for the next morning or next week patients. And so go over everything. And so the vascular surgeon, if anyone says no, we actually don't go through that route. Don't push the envelope. I mean, if it's heavily calcified, we can do it. We can do POVAs, dilators, shock wave, and do the procedure from the groin and femoral artery. But right carotid, I actually asked the vascular surgeons or cardiac surgeons just to put in a small incision. It's so smooth. It's no complications at all in our experience.
Thank you very much.
Thank you.
The next paper.
Ramesh, I have a question to you.
You have a question, you go.
Yeah. We have very little experience with Manta, and as you said that if it's 8 millimeter vessel and no calcium, Manta does an excellent job. Recently, I was handling a patient, and the vessel was close to 8 millimeter only, no calcium. So pre-procedure, I think we were quite fine to handle Manta. And we were doing a trial valve, an on-cria valve, which is self-expanding valve. And the first time they had come in India with a largest valve, which was 29, which required a 22 ID sheath, which is kind of 25 OD. So we were just pushing the envelope because Manta is good till 22, maybe a little beyond that is not so good. So we did close with Manta, and good hemostasis was achieved, but the vessel also closed.
Yeah.
So what is your take on?
Yeah. So that's one of the unfortunate risks of MANTA is actually that the foot plate is very big. And the way that you deploy also is slightly different than angioseal. We all are trained in angioseal. We pull it at 45-degree angle, and that's not the same way that we have to close with MANTA. You have to be almost 60 to 90 degree. The foot plate has to be parallel. And if there is plaque or calcium proximal to the site of puncture, it'll open, it'll drag that plaque. So that's why it closes. And
So we handled it by passing a bar, taking a guide, just mild inflation of the balloon, but it was a horrific experience. Same thing. The Manta was being pulled at 45, not at 60, 70. It was not parallel to that. And there was a little plaque just proximal to the puncture site. And it dragged and it closed the vessel. So that part also has to be kept in mind. Manta is an excellent device, but be careful if there is a slightest plaque and if your angulation is like 45, which you do with angioseal. In fact, the fellow who's come with Manta device is the same who described angioseal.
Thank you, sir. We are 20 minutes
Can I
late.
ask a question?
Who?
Venkatesh?
Who is speaking?
Dr. Ramaya.
Yes, but very short because we are late and you are going to give a lecture in a few minutes.
So,
Frozen.
is you lose your wire.
Can you repeat your question? You were frozen in Phoenix.
Dr. Ramaya. Frozen again.
It's frozen.
So I think what he's trying to say is never lose your wire.
Never.
Yeah, never lose your wire. As I mentioned, either crossover safety wire or if lateral safety wire, it's better to keep that.
Thank you, sir. So, if you are not frozen, Venki, this is your turn. Branch graft and radiation protection. Do you hear me?
Lose your wire.
Finish. This is your presentation now. No more questions. Can you give your lecture, Venki? You have a lecture, branch graft and radiation protection during 12 minutes. Can you keep on time? No sound. There is no sound. Can you, technician,
Can you hear me now? Can you hear me?
Yeah, just now.
Okay. So let me quickly go. My topic is basically treatment of complex aortic veins with branched and fenestrated grafts. Not only is the treatment complex, but also the challenges with radiation exposure. And that's what I want to highlight in this particular talk. Not sign on again.
Yeah, you can do that.
Okay, should we go with your talk, Joe, in the meantime?
Why don't you go to the next one? I can do it now. Can you see now?
Yeah, it's coming up.
Can you see it?
If you can click on a display state settings upside and swap screen. Yeah, click on that.
Can you see it now?
Swap presenter view and a slideshow. First option, sir.
Yeah.
Click on the display settings again.
Annotate, show meeting.
No,
Do I
so
share?
Venk, we are seeing two screens right now. So can you on the display settings? No, don't close it. Okay, open that and on the display settings, swap on the presenter view. You had it clicked before, right?
Okay, share screen here. Got it? Can you see it?
You go to slide presentation.
Slideshow.
Slide control.
Make it a slideshow, sir.
Yeah, here.
Yes.
Can you see it now?
That's fine. Go on the.
Okay. Yeah, click on the first option, sir. Yeah, correct.
That's fine.
Which one?
Yeah, fine. You can continue, sir. Now it's fine.
Okay. Okay, sorry guys. So my topic today is the treatment of complex aortic aneurysms with branched and fenestrated grafts, but more importantly is the amount of radiation we get exposed to and what do we do with this radiation exposure. As Jacques knows, I work with Dr. Dietrich, who unfortunately passed away, probably from radiation and secondary to a brain tumor. In the United States, for infrarenal abdominal aneurysms, we have 5 stent grafts, but these are infrarenal, and within the IFUs, you can treat patients with a neck of 7 millimeters and higher. But then, for complex aneurysms such as juxtarenal, paravisceral, type 4 descending thoracic aneurysms, you need complex anatomy and morphology that do not accommodate to the currently available infrarenal devices. In the United States, we have 2 devices, the Cook Zenith customized stent graft, and recently the TAMBI by Gore. We've done almost 15 to 20 TAMBI cases so far. This is very complex aneurysmal disease, and I think sometimes you have to be very careful. So what you need to know is that these complex cases have to be preoperatively determined, and the plan of action has to be taken very carefully because a lot of the work is done in the preoperative stages. And so imaging systems, 3D reconstructions, and then measuring and how you're going to deploy these grafts. So if you have TAMBI, it's a custom-made graft, it's off the shelf. But sometimes a lot of these patients do not fit the criteria for either TAMBI or the Cook fenestrated graft. And nowadays we are doing what's known as PMAGs, or physician-modified endografts. And for that, you need these 5 points to be considered. Very careful preoperative planning and also consent. Because if you do not have a single center IDE and it's not approved by the IRB of your institution, you can get into trouble. So the consent has to be very, very carefully taken from the patient, saying that this is a modified stent graft and the risks and benefits have to be explained to the patient. Second, you need to choose the kind of graft you want to use to modify. And so it's among all the available devices, you can choose anyone you want, but you've got to be very understanding of the anatomy, morphology, and the construction of the stent graft so that you get the best optimal results. Then you have the intraoperative challenges, and there you need intraoperative image-guided therapy, ways to cannulate fenestrations, different catheters, wires, steerable sheets, and things like that. Number 4 is obviously radiation protection. You got to be extremely careful about the amount of radiation that you get when you do these cases. And then finally, you need to follow up these patients. So preoperative planning, extremely important. I don't know what you use, but you can use different modalities. You can use even SIDAR imaging mapping, but eventually you need to know exactly how these aneurysms are going to look under the fluoroscopy screen. This is a classic example of SIDAR preoperative imaging, and you can adjust this accordingly to the cases that you have, but this is done preoperatively. And of course, intraoperatively, you also have enough monitoring. Second, of course, like I said, of all the FDA devices, I've started to use the Terumo stent graft for most of my physician modified stent grafts, because the reason is it's got a long body, and so therefore you can adjust the fenestrations very nicely and carefully, and also the length of the bifurcation is much longer. Plus, it has a good proximal fixation. It is a modular device, and it also has Dacron, which is a better fabric to fenestrate so that it does not tear and things like that. And it's a very controlled deployment, and you can actually rotate the device very nicely so that you can adjust the fenestrations accordingly. The long body is definitely an advantage. It has dual active fixation because you have suprarenal and infrarenal fixation, and you have the ceiling overlaps that are connected. The limbs are completely locked into the picture, and so there is no disruption of the connecting limbs at all. So this is an example to prevent limb discussion. So once you've modified your graft, once you've got all of these images preoperatively, we use a little scaffold where we mark off the positions of the stent of the fenestrations, and these fenestrations are then performed and then oversewn with a radio opaque marker, as you can see over here. The most challenging thing in doing PMAGs is basically how to reload these devices. And you can see we had multiple, like the Edwards valve, the fenestrator, you can crush these devices, you can do them. But recently, working with Terumo and Dr. Ben Starnes, you will see now we've created what's a very easy way to reload these devices. Dr. Benjamin Starnes from Washington has been working with Terumo, and you can see how easily it is now to reload these stent grafts without putting those suturing ties and things like that, or even rubber tubings. And you can clearly see now, this is how we make these much easier to reload, so you don't waste time while the patient is under anesthesia, and these stent grafts are now easily loaded without any difficulty, without any struggle, without twisting or rotating the devices in. And you can clearly see how the device is now being reloaded completely, very easily too. So there's a lot of advances, when you're dealing with these complex aneurysms. You not only need to have the experience, but you also need to know how to manipulate these devices, how to reload them. And you see now the device is very quickly loaded within a few seconds. So that's one thing. The second thing is that in the operating room, you need to have visualization. You can spend tons and tons of time and radiation to cannulate these branches. We use what is known as the fiber optic rail shape, which is basically light guided catheters. So basically what you're doing is, as you can see here in this video, you have the background of the image completely 3D reconstructed, and you're now fluoro. You don't use any dye. And these catheters and wires are manipulated through light guided stimulation. And so you can see now the wires are going without any fluoroscopy, without any use of dye, and you've cannulated the left and the right renal without any contrast or dye being used. Then we have what's known as radiation protection systems. In the United States right now, you have 4 radiation protection systems. One is the EGNEST, which we have in all of our hybrid ORs. The second is RadiAction. The third is Protego, and the fourth is Rampart. So these give you additional protection of the amount of radiation that you use during these complex cases. EGNEST is something that we use. So let's go quickly through a case. 81-year-old, severe pararenal abdominal aneurysm, high-risk patient, prohibitive risk for open surgery. And you can see this aneurysm is pretty complex. It involves both the renals. So here's an example. If you look at that, you see the renals are coming off the aneurysm, and this is a really complex case. Conservative treatment was also discussed. Leave alone was discussed, but eventually the patient presented with symptoms. And so you need to have all of these in your armamentarium to basically get good results. So here's the patient. We did a PMEG device. We then had the angiograms done. We then deployed the stent graft, as you can see here. And then using light-guided or force image-guided therapy, we were able to cannulate the renal. We were able to cannulate the SMA and stent it. We then cannulated the renals, which were extremely tricky. We could have spent hours of radiation contrast, but with light-guided therapy, you can actually spend your time without any. When your large aneurysm actually presented with systematic abdominal pain, and she had a previous endograft that had already completely migrated. Again, you need to have these 4 things. You need to have PMEG, which is how you make your physician-modified graft. You need to have image-guided therapy, and you need to have radiation protection. And then you need to have all the tools that will help you to cannulate these. So here's an example of the graft that we made. Here's the old Anurex 10 graft that migrated. This device is no longer on the market, but it was one of the first devices in the United States to be FDA approved. And then we basically cannulated the SMA, the renals, and then, of course, we used force to get this. And here's a classic example of how the aneurysm regressed from 6.1 centimeters to 4.1 centimeters. And you can clearly see those fenestrations opening up. Both renals are lighting really well, and there's good flow going down both iliac vessels. So let's look at radiation protection, because these complex cases, you do them, you're being exposed. You're allowed, the maximum allowable limit is about 5,000 millirem per year. That is the whole body for radiation workers. And so you got to be very careful. So now we have not only force, but also egg medical in our hybrid ORs. And the problem is, it protects everybody in the room. Here's a classic example. We're collecting all of this data now. We got egg medical, I think, about 6 months ago. You are subject to almost 8,678 millisieverts, microsieverts. Otherwise, you get only about 533, and my assistant and my other people in the room get even less. Here's another classic example. If you did not use egg nest, this is the radiation you get, but with egg nest shielding, which is in green, it's cut down to almost 98 to 97%. So in our data so far, we see that we get protection not only to the operating physician, which is 98%, the anesthesiologist gets 97%, the patient himself gets 87% protection, and everybody in the room is up to 97% protection for everybody in the room with egg nest protection. And in addition to using, take an example, this case, and you can see I was getting without the egg nest, I would have got 8,678. Now I'm getting basically almost zero radiation in terms of protection. So you can see the radiation protection systems have become so available right now. I think it'll become almost medical legal if the hospitals do not get these systems into the operating room or into the hybrid ORs. And I think there's a beautiful documentary called Scattered Denial, which you should look into, because it features also Dr. Dietrich, and it also features the work that Dr. Reisig, who actually was at the Arizona Heart Institute, has done. And this is actually published. The documentary is called Scattered Denial. You should look into it. So again, you see, you have to have these images. And also, even for people who are basically doing radial access, these egg disposables will also cut down your radiation completely to 0.5 protection. And so there is really no excuse anymore for people not to use radiation protection, image-guided therapy, steerable sheaths, and background and big imaging systems to cut down your radiation level by 98%. So it doesn't mean that you can shed the lead. A lot of people of these companies are actually quoting saying shed the lead, because you can get back pain, you can get cervical pain, all of these things at the same time wearing heavy lead. But if this turns out to be as good as it is, then there may be a day when we can actually shed the lead gowns that we keep wearing all the time. The other last thing is follow-up compliance. If you look at compliance follow-up of all of these patients, it is extremely poor across the board. The FDA mandates that you should follow these patients for the rest of the patient's life or the life of the device. And right now, if you look across the board, even in the best of institutions, you will notice that there is only about a 48% follow-up of these patients. And so we need better devices or better technology with AI. So we started an implant tracking company called MedTrack, which allows software to allow you to capture these. And if you increase the compliance rate of follow-up for these patients from 48 to even 60%, 70%, you will catch those endoleaks and those ruptures and those migrated grafts much earlier, and you can protect ruptures and treat these patients much better. In fact, even if you do research studies and you've enrolled 500 patients, by the time the study is completed at 5 years, of those 500 patients, you only follow 250 patients. Whatever happened to those other 50 patients? I mean, 50% of your patients, did they die because of your device? So the compliance rate for follow-up is something the FDA also wants to improve, and this is one way of doing that. And then finally, we host a TED Congress, which is basically named after Dr. Ted Dietrich. And this has been going on. He used to host one of the biggest meetings, and Jacques can talk about it for a long time. He was the founder and co-founder. Jacques was involved in the ISEVS Foundation, the creation of that whole society. And I set the journal, the research department, and the meeting. And we're trying to revive this as much as we can. And I would love to see all of y'all at TED 2026. Thank you so much. I'll take any questions.
Thank you very much, Venki. It was very interesting, your topic. I really appreciate three things. First, the funnel to reload. It's a very nice and innovative things to do. It's very simple, but second, you are dealing with a catheterization without any dye, and I really appreciate that. But maybe it's a surplus of cost, I don't know exactly. And third, thank you and congratulations for the protection you give to yourself, to the patient, and to the people working with you. It's probably also an extra cost, but that's the price to pay. Some comment, please.
Oh, thanks, Jacques. So yes, there is always a price to pay. The image-guided therapy called FORCE system is relatively expensive, but it's a learning curve. There are only like 5 sites in the United States that have FORCE for image-guided therapy. The second thing is the radiation protection systems like Egg Medical, Rampart, Protego, and Radiaction. They're not very expensive, at least for large hospital systems. The average cost is anywhere from $150,000 to $200,000, which is nothing for a big hospital institution. And so, with that kind of cost, hybrid ORs, even in cardiac catheterization labs, all of the data that Dr. Reisig has published in the scattered denial was done for cardiac catheterizations. And those are actually, not that much radiation. But when you're doing complex aortic surgery, these things can take 6 hours, 7 hours, 8 hours, and sometimes we do them in a staged fashion. So these radiation protection systems are not too expensive. And I think eventually hospitals will have to embrace this and have every hybrid radiation room protected with these radiation protection systems.
Thank you. You have to stay online, and we go on with the presentation. And in fact, it's mine. Do you confirm?
Thank you, Jacques. Thank you, guys. I'll be on.
May we now request Dr. Jacques Bousquet to come on stage and deliver their presentation.
Please. Thank you. So it's a pleasure to succeed to Venki Ramaya. It's a very good friend. We were together in Phoenix during many, many years behind Dr. Dietrich, and he succeeded to him with much quality, technology, and expertise. Thank you, Venki, and see you next. The ISIS is the International Society of Endovascular Specialists, and we are proud to sponsor this session. This is the SAC management during and after EVAR, which are the option, challenge, and outcome. I have two mentors, Dr. Dietrich, that I met in 1988 in Phoenix, Arizona, and I was trained in Bordeaux by Professor Francis Fontan, well known for congenital surgery for baby in cardiac pathology. As you know, AAA can be treated and have to be treated immediately because of the risk of rupture. I think everybody knows that. The EVAR technology went very early from Dr. Parodi 35 years ago, and it's still going on. What is the EVAR? It's a minimally invasive treatment for AAA in order to prevent rupture by excluding the sac from circulation. There is a big issue. The sac may still enlarge or rupture post-EVAR. This is a question, and this is the topic. Look to this example. This person starts an aneurysm at 56 millimeter in diameter. And few years ago, after the exclusion by endovascular therapy, the sac enlarged to 78 millimeter. So for sure there is a problem, but you need to control this patient every 6 months by a CT scan. It's mandatory. The sac has to be managed very carefully. The expected outcome is the sac shrinkage over time. If not shrinkage, there is a problem. The complication could be a persistent endoleak or, even worse, a sac expansion. The key monitoring tool is a serial imaging with duplex scan or better CT scan. All of you know the classification of endoleak, type 1 proximal, type 2 distal globally. The type 2 endoleak after EVAR, it's a revascularization from outside the sac by the lumbar or the lumbar of the mesenteric artery. You can have a preventive embolization or after the implantation, cilioscopic clip ligation or embolization. It's a potential solution. So during the operation, you can do a direct sac embolization via translumbar access. You can use also adjunctive device like endo-anchor. But the sac management during EVAR have a benefit to be treated by a sponge-like design of chip memory polymer product that you put inside the sac to control this external endoleak. So it's improved aneurysm sac regression following EVAR. The study is in progress. So what the way to do CTA follow-up, 1, 6, 12 months, then annually, delay sac embolization with onyx glue or coil, and sometimes you have to open the sac when you have no solution in some refractory cases. This is a surgical conversion, and sometimes you see serum inside the sac. So this is a literature review for the youngest of you. And in conclusion, the sac management is crucial for long-term EVAR success. Not all endoleaks need intervention, so you have to monitor the sac size. And the future is risk stratification with tool and advanced embolics. So then I thank you. If there is no question, we go on.
I think there is one.
You have a question. Two questions.
I have a comment.
Comment.
Yes. I did this procedure without the covered stent graft 30 years ago. I used the two stents, one over the other, and then on the side I put some multiple coils and just put the mandrel of the guide wire out and put it there, and it sealed and thrombosed it. I think it's something what you're describing is a new technique. It's probably the more advanced system of the same thing. So the trial is still on. It's not proved yet.
It's done by an American company, and it will be probably on the market next year. It's like a sponge, and it could be interesting.
Looks like quite good a device.
Question?
Yeah, this is like most of the hydrogel which you have nowadays on towers, and they prevent the endo leaks from the tower in form of paraprosthetic leak. I think the basic and simplest thing is that you detect most of these AAAs by an ultrasound, and the simplest way to follow these patients up is by ultrasound. If the size remains the same, that means you have done something, placed something inside, probably it's not done great thing. If the size is regressing, despite the fact, even if you have some endoleak, I think it's of no big clinical significance. On the contrary, if the size is growing and the patient has some chest pain, I think you have to resort to all measures which are trying to feed into it. And finally, if everything fails, you have to do a surgical secotomy and handle it.
Dear colleague, can you introduce the next speaker?
May we now request Dr. Sharif Sultan to come on stage and deliver their presentation.
He's not on stage, he's live and remote.
Mr. Chairman, ladies and gentlemen, aortic endografting and hemodynamic fallout, how TIVAR, EVAR, and BVAR alter cardiovascular physiology, why it matters, and what we can do to resolve the damage. Currently, we use a lot of 4D imaging. We must use a 4D therapy. A 4D MRI for cardiovascular hemodynamics and arterial compliance and tissue function, but still deploying a 35 years old technology that haven't changed that much over the past 3.5 decades. Prosthetic aortic replacement causes aortic remodeling with circumferential strain, which lead to progressive distal aortic dilatation, dissection, and aneurysmal formation. All existing stent graft material decreases wall compliance with higher wall resistance. Aortic stiffness is a strong predictor of future cardiovascular events and all-cause mortality. Reducing profile of delivery system to make technology more amenable to percutaneous access, thereby expanding customer base to other interventionalists, compromise fundamental science behind the design of a good endograft, and jeopardize long-term durability with negative cardiovascular consequences. We do a very complex EVAR, even if we have a big 11 centimeter aneurysm rupture in the inferior vena cava. We put an EVAR into the aorta and a VVAR into the inferior vena cava. And we use a lot of BVARs, and we learn about the type O endoleak. You don't need to do anything. It will disappear over the 90 days. The reason for that, you don't have wall-to-wall opposition, and because of the area around the BVAR and the inner tunnel, there's a lot of space need to be filled with clot before that disappears totally. However, if you have a complex aorta 10 millimeter conical neck, the best way to do that in a case like this is to build a neck yourself. And the best way to do it is using the gold graft with 3 stents in telescoping it, and this will allow you to seal it completely with no evidence of any leak. Remember, the difference between success and failure is persistence. Avoid any chimney, avoid any endo anchors. All of them are distant to total failure. The chimney allows type 1 endoleak. You can resolve it except if you're going to put a proximal BVAR, and this idea of putting endo anchor and putting holes into the polyester or the PTFE is invitation for disaster, because it's a very hostile environment. You cannot put holes in it, regardless whatever the company going to tell you. Now, that's Shivar isn't a good idea at all, and this is a patient came in with the right renal coming out of the aortic sac. We put a As you can see over there, the BVAR came with a massive endoleak, and we have to put an Artivian BVAR Neo in it in order to seal it. And we don't do anymore Shivar. It's criminalized totally in our practice. Aortic geometry, wall stiffness, blood pressure, and longitudinal systolic aortic stretching and oscillation affect peak wave velocity, contributing to the biggest impact on wall stress, and all commercially available endovascular devices increase wall stress and lower aortic wall compliance after implantation. This is the same paper from Jason Lee from Stanford, the same almost author, in a striking contradiction to the 2021 claim that FIVAR is a perfect approach. Stanford has since revealed that FIVAR critically impairs renal perfusion, labeling it a criminal act again, while affirming BIVAR is a superior option for preserving and improving renal perfusion over time in complex AAA repair, highlighting how the truth about patient outcome ultimately serves. Because when I used to give talks about FIVAR and its impact on the renal function, they used to mock me. Now the truth is out. Again, this is a big comparison between Professor John Boyle versus Rao, a friend from Liverpool. In long term, FIVAR has twice the risk of dying over open repair. At 3 years, open repair has significantly better outcome than FIVAR. Long term, all-cause mortality is significantly better for open repair, as reintervention rates are higher for FIVAR. So don't do FIVAR. If it's failed that common and a lot of renal dissection, a lot of renal thrombosis, why are you doing it? It's because you love cook. The commitment failure of FIVAR, SHIVAR, and PVAR, we must stop doing the right approach on emergency basis. And we have to understand that these patients have retired from continental Europe or from the UK and came to the west of Ireland. And what I do in the middle of the night, I have to extract them and redesign the whole thing again. So be a little bit careful when you do stuff that sometimes doesn't last that long, because this patient doesn't understand. And they arrive to us, look at it as if, it's not their problem. I know. Then the chronic fabric fatigue failure, that's endologic, that's Zenith Cook, and that's the endurance. All of them fail because this graft didn't design to last more than 10 years. However, these patients are living 15, 20 years post-intervention. And what happened that the microfabric of the polyester graft or of the PTFE fails. And this is create havoc for us because we need to explant this patient and put a proper graft. And this is our museum from all the cases. That's a Cook graft over there. That's a lot of endo anchors. You can see that they destroyed the graft totally. And this is our friend, the Nelix, with all its disaster. I never implanted the Nelix in my life, but I explanted 3 of them. And to understand, it's a nightmare to deal with this case because a lot of people try to do a lot of stuff. And that Omnex done by the radiologist for type 2 endolic do not deal with type 2 endolic. You don't require to do anything for it. But please be careful about all these cases because they do badly and the complication rate from them is horrendous. And what we call a tail or stroke abdominal aortic aneurysm life-altering event, this is post FIVAR, SHIVAR, and physician modified. And you could see yourself that we have to do it, and the bowel and the kidney and long-term hemodialysis and a colostomy, ileostomy, and burst abdomen, you name it. So be careful when you offer this surgery for this patient because you understand that somebody else will look after this patient and it takes a lot of time to get them over the line. Heart stroke, abdominal aortic aneurysm, life-altering events, which still occurs if aortic diameter is more than 65, or the use of SHIVAR, shielding snorkel periscope, FIVAR, physician-modified. Surveillance is associated with an increased rate of reintervention without any improved survival, and secondary procedure when performed for visceral vessel had highest mortality rate. FIVAR, SHIVAR, and physician-modified outcome is questionable. We need better solutions. This is one of the most important slides in this talk to show you that the perioperative mortality between 20%, major adverse effect, clinical event 52%, SMA shuttering 50%, 43%, again, major adverse clinical event, 33% FIVAR graft failure, 69% MACE. Contrary to the lecture, FIVAR, SHIVAR, and physician-modified are associated with the higher procedure mortality, and SHIVAR should not be used in any elective setting, and physician-modified should be abandoned totally because you're not covered, and any problem, it will end in a disaster. Again, the 3 criminals. FIVAR, SHIVAR, a physician-modified in high-score group had more implanted-related complication, carries greater re-intervention risk than open surgical repair, with implication for cost effectiveness, and patient who underwent a secondary intervention for type 2 endoleak, which done by a lot of radiologists, is wrong, done worse, and it reinforces the need for conservative treatment of type 2 endoleak. If you have an overzealous radiologist, tie his hand before he do anything for type 2 endoleak. So we conveyed long-term outcome of more than 1,500 patients done by vascular surgeon equally professional in both open and EVAR, using precision medicine with adaptation of graft type configuration and post-operative surveillance to maximize individual patient care. And we applied general AI to see the recurring pattern, the machine matching human cognitive capacity. First thing is diagnosis of the problem. So the 4-phase contrast enhanced CTA have diagnosed the problem 3.4. However, when we done a prone contrast enhanced computer tomography and endoleak device in all patients with prone protocol, it increased the endoleak detection rate and informed treatment option by utilizing gravity as 4-dimension. And then we created the Arafat, the EVAR Gore salvage fabric technique, where we rebuild the graft from the inside, and this is abolish all the micro leaks that you cannot deal it with anything. Onyx cannot treat it, coils cannot treat it. You have to realign the whole graft, and this is your best way. Our incentive was ignited by the knowledge that existing realignment techniques, in particular venous vein cook or aortic iliac metronic, both are associated with distal migration with resultant type 1A endoleak due to pathological flow patterns. PASH and Arafat are a fully functional protocol to overcome apparent challenge in accurate diagnosis and subsequent concealed endoleak management in high-risk patients. Moreover, the AI machine learning has shown that large AAA have higher all-cause mortality, complication, radiation index, and reintervention than those with smaller aneurysm, questioning the wait-and-see policy to 5.5. I'm just telling you, do not wait to reach 5.5. That's crazy. This has been done on only 11 aneurysms in the early 1980. Doesn't mean anything. Please, if you have a small aneurysm, 4.5, 4.7, do it now endovascular before you lose the endovascular edge and end in a disaster as time goes by. High-risk patients have poor long-term survival with 15% mortality within 3 years, doubling up with each comorbidity. Moreover, 1-year mortality exceeds annual rupture risk, and female have worse outcome due to anatomical and physiological challenges, making any intervention futile. Limited benefit despite high cost, FIVAR offer short-term survival gain with long-term losses as high-risk patient dies before benefiting. Early intervention should be prioritized over costly low-yield surgery. Spending on repeated FIVAR for frail, elderly, sarcopenic patient is physically irresponsible, and healthcare funds shouldn't sustain futile intervention in patients living on borrowed time. So we went to Super AI, where we have machine super passing its cognitive capacity using the AI machine learning. What we find that a 36mm proximal diameter aortic cuff with more than 4 modular components with limb size above 23 had a higher chance of graft fabric failure, hygromas, and complication. Reduction in profile of polyester graft to reduce 10 graft profile had caused long-term sequelae of chronic fabric failure, hygroma, augmented with DUAC, potent antiplatelet, and thrombolysis. Rapidly increasing AAA sac more than 75mm associated with severe abdominal and low back pain with a documented Huntsville less than 25 in the setting of an implanted polyester-based EVAR is an aortic hygroma. Do not do any injection to it. Do not put onyx. Do not put coils. Open the patient. Remove that hygroma under tension. Otherwise, it's rupture and the patient will die. A sustained gradual increase in the aortic size that exceeds more than 7.5 centimeter is an indication for obliterating endoaneurysm free with EVAR preservation by evacuation of the hygroma and double breasting of aortic sac because of fear rupture. And this hygroma happened in excluder, Incraft, and Medtronic. And it doesn't spare anybody because the amount of medication that the patient is on is crazy now. Now go to the adverse hemodynamic alteration post-FIVAR, SHIVAR, and physician modified is a major concern. Best solution in the short term is to reduce the stenting length of the aorta, while in the longer term, encourage continuous improvement in stent graft material and design. So this patient had a TIVAR or FIVAR, and he had chest pain, interscapular pain, and elevated troponin. With the coronary angiogram is normal. All coronary angiogram were normal in spite of an elevated troponin with left ventricular adaptive hypertrophy and diastolic dysfunction. The reason for that, we replaced the descending aorta and the main infrarenal aorta with a stent. So the aorta have lost its elastic recoil. There's no filling in the coronaries. That was happening for these patients. TIVAR patients have significantly higher postoperative peak wave velocity than those undergoing open aortic aneurysm repair due to loss of aortic wave propagation and plasticity, increasing cardiovascular major adverse clinical event. TIVAR and physician-modified induce acute aortic stiffness. Multinational must consider impact of graft stiffness mismatch, particularly with emerging role of TAVI and harsh BVAR. Increasing cardiovascular mortality in patients managed with petticoat, stabilized, flared, FIVAR, candy plug, knickerbocker due to increased arterial stiffness, increased left ventricular afterload, and systolic hypertension. Decreasing standing length of the aorta by Tiger protocol, and I could give another talk about that next year if you wish, is the only existing solution until new advanced compliant graft become available. Polyester-based aortic endograft caused a 3-fold increase in pulse wave velocity compared to PTFE-based platform, with alarming negative cardiovascular consequences. Regardless of number of stents used, there was a linear association between morbidity and mortality and stent number. Mortality had shifted from aortic pathology related to cardiac-related mortality due to systolic hypertension, left ventricular strain, myocardial ischemia with graft-induced congestive cardiac failure. FIVAR, and physician-modified have highest intervention rate due to complication arising from any infradiaphragmatic visceral artery stenting or aortic and iliac segment manipulation. Best outcome is female patient with a AAA repair at 45 millimeter and male at 50 millimeter, non-smoker and on metformin. You were asking about solution. We have to do a smart endoprosthesis. A radially expandable mesoporous silica nanoparticle as a nanocarrier for a self-healing, self-repairing, and self-assembly system. It's more robust and fault-tolerant with transverse and longitudinal crimping that expand in systole and contract in diastole. This nanolight expandable layer of impervious silicone prevents tissue ingrowth, which averts stiffness and rigidity. This paradigm shift towards building a smart endoprosthesis that possess self-capabilities of advanced self-healing to repair themselves during EVAR functional life. Smart endoprosthesis will lengthen product lifetime and abolish need for follow-up or re-intervention. Mr. Chairman, ladies and gentlemen, performing costly complex AAA intervention on frail, high-risk patients, especially female, with complex anatomy wastes taxpayer money. FIVAR offer better short-term survival, but long-term durability is inferior to open surgical repair. Financial and clinical burden far outweigh the short-term benefit, as FIVAR leads to repeated intervention, high long-term cost, and poor surgical outcome. Aorta is a function organ that should be respected, preserved, and not eliminated, as regional aortic bioarchitecture varies considerably, with implication for tissue function as device lack compliance and induce cardiac vascular dysfunction. Next generation device must restore aortic compliance to reduce cardiovascular negative hemodynamic morbidity and mortality. AI and machine learning recommend strongly to repair AAA at 50 millimeter or lower to avoid losing the simple endo solution, but it enhances long-term outcome and avoids SACA of FIVAR, SHIVAR, and physician-modified failure. You go to meetings and you'll find this, the red color discover and SHIVAR. So they put a SHIVAR, and then because of the problem, you put endo anchor. They're just mucking the water. Don't listen to them, because I get them out of the patient belly. Please don't do it. It's crazy. You can't. The SHIVAR is wrong, and the endo anchor is crazy. You cannot put holes in the graft. Already the graft cannot sustain more than 10 years. Can you imagine that you putting holes in it and then you don't allow wall-to-wall apposition by putting this SHIVAR? I don't know how Medtronic thinking, but that's wrong. Back to the future. We're doing a lot of open conversion because of that. Please be sensible. Do it at a smaller diameter. They'll do very well. They'll have no problem. And the simpler EVAR you do, the better for the patient. Doing complex FIVAR with shattering effect on the renal and the SMA is crazy. BIVAR is a solution. SHIVAR is a criminal act. And this endo anchor have to be abandoned completely because it allows rapid failure of the graft. Thank you so much for the opportunity to present today.
Dr. Busquet speaking. This terrible presentation should need comments. I know very well Dr. Sheriff. He's a very good doctor from Galway in Ireland, and he knows very well what he's speaking about. He's extreme in his presentation. It's the extremity of what you can have in a nightmare, but he's right in a way. And I don't blame him. Even I support him. And my conclusion for the youngest, try to work with prudence. Try to work with expertise. Try to respect some good indication. Don't go too far. Don't be pushed by the company, because some of them are push. I see them push for money. The life has no price. So be prudent. Work in a team with people that can control you or support you or explain things to you, and respect IFU, respect indication, and in your team you need a person with open surgical expertise who can do the work. I mean, to extract the graft, and it's difficult. Anesthesiologist and intensive care doctor to do transfusion, to do post-op care, because it's a very long intervention. But you have to have somebody in your team. If you have not this person, you take the risk to do your big things with a commercial support. When there is a problem, there is no more commercial support. You need a surgical support. So it's an extreme presentation, but in a way, is right. My dear colleague and friend.
I think you have nicely summarized, and I'll quite agree with you that it was, in a way, an extreme presentation, but I think for most of us, it was really charismatic and paying an obituary to the standard terms like VWAR, CVAR, and PMVAR. I think he's cautioned that you should use the taxpayers' money very, very cautiously, and wait for an aneurysm to be like little over 5.5, because then only you're likely to have good results. And your excellent results are going to be if your proximal collar is not more than 3.5 centimeters, and future is for super AI.
Dr. Khanna, can you close the session with the management of mycotic aneurysm? Thank you very much for your presence.
So, as we are running about 10 minutes late in this session, let me be brief. And this is a very controversial topic again, and it is now getting into more and more used to save these patients who have mycotic aneurysms, which are likely to rupture and are very and extremely high risk for endovascular management. If you look at the concept building, mycotic aneurysm word was coined by Sir William Osler in 1885. It's a misnomer of infection. A lot of us think that it is a fungal infection. It is usually not a fungal infection. It is usually a bacterial infection, and this is as a result of degradation of the aortic wall with a bacterial infection through vasa vasorum in the arterial wall or aortic wall, and this leads to a necrosis there and aneurysm formation there. It's a rare but a very life-threatening disease. The incidence is about 0.6 to 2%, and it carries a very poor prognosis. And as we have the surgeons here, infected mycotic aneurysm, especially in thoracic positions are a nightmare for surgeons, and usually they don't want to operate. The common organisms are staph, salmonella, and streptococcus, and the spread is usually hematogenous. It could come from anywhere, and in India, it could also come from tubercular lymph nodes around the aorta. So it is usually a result of either a contagious spread or a hematogenous spread, which is contagious and infects the vasa vasorum. Now, these are the different studies, and we have seen where it is normally present. So it can be present both in thoracic and abdominal aorta. And usually, a patient is very sick and the patient has an aneurysm, and the patient's inflammatory indexes are high. And on the CT, we have a lot of signs which actually tell us that it is probably a mycotic aneurysm. The CT findings of infected mycotic aneurysms are saccular aneurysms, irregular aneurysmal wall, gas within the aortic valve, absence of calcification, perianeurysmal gas, encasing or contagious mass, and associated para-aortic mycotic aortic aneurysms, European multicentric study. This was published in Circulation in 2014, and most of the data which we quote is derived from this. I'll just give you the essential or the home carrying points from this paper. The TUR is an essential part of the management. Once the diagnosis of infected aneurysm is made, what we do is we start broad spectrum antibiotics and send blood cultures and wait for the exact aneurysms and their culture sensitivities to come, and then we change these antibiotics. The antibiotics are always given parenterally, and they are given almost up to 6 to 8 weeks. And if you have time, it is better to treat them with antibiotics at least 2 days prior to an EVAR procedure for better outcomes. And the duration of antibiotics, I have already told you, it's 6 to 8 weeks. And the study showed that many of these patients would have recurrent sepsis, stent graft infections, and some of them can actually be cured. At least 30% to 50% can be cured. So this is the largest study which is, published by European Multicentric Study Group. And this is on endovascular treatment, including the risk of late reinfection. The main findings of this study are good short-term result. The 30-day mortality is only 9%. There are 19% of these would have fatal infection-related complications. It has a relatively good long-term outcome with 55% survival at 5 years, with few serious late infection-related complications. Adverse long-term outcomes were among non-salmonella infections. So if you have a salmonella infection, which is the most common, it is easy to treat, and other infections which are non-salmonella are very resistant to treat. So there has been more research, and more people have actually started using this. And Stanley et al. Have reported antibiotic soaking of stent graft prior to implanting. I don't know whether it really works, but many of us actually do this in no-option patients. So I'm not going to go to the detail how we do it, but it is endovascular treatment is a feasible option in patients who have mycotic aneurysms, are surgical turn-down patients, and the patients are very sick. It is usually a salvage option or a bridge option. Later on, if the patients improve, they can go for a definite surgery, corrective surgery, and some patients actually improve and they do not require surgery and they do well in long term. I'll end with one of our cases. This was also presented in one of our Apvic meetings. So this patient had a stent graft done in a hospital, not in Apollo, but in a different hospital. And somebody, if you look at this picture, put a stent graft and was not done properly. Actually, the stent graft was put into the aneurysmal sac rather than covering the neck. And it was not probably because of the septic environment, or because of whatever, the patient developed a mycotic aneurysm. So he came to us 1 month after the procedure with fever, with shock, and you can see the CT shows there is a mycotic aneurysm in the mediastinum, in the periaortic wall, with the gas formation. And this was the PET scan, which shows high FDG uptake in the periaortic tissues near the aorta and also in the mediastinum. And this patient had an aortoesophageal fistula. And when we did an angio, you can see the stent graft had migrated into the aneurysm and was not, there was a big endo leak in this patient. This is an endoscopic picture which shows that because of the aortoenteric fistula, we could actually see the stent studs while we were doing an upper GI endoscopy. And this patient was referred to all the surgeons in the city and in the country, and everybody said, just leave it to God. Nothing probably can be done in such a situation with aortoenteric fistula, which is mycotic. So this patient came to us and he was put on broad spectrum antibiotics and 4-drug anti-tubercular treatment. We put a percutaneous feeding jejunostomy in this patient, and then the patient started improving a little because we bypassed the mycotic aneurysm and aortoesophageal fistula, and then and there was a feeding directly through the feeding jejunostomy. This is the feeding jejunostomy tube. And on follow-up, the patient gained some weight, became better. The hematemesis continued, but was less. And then once the patient was better, after a few months, we did endovascular revision, endovascular grafting. At this time, the blood cultures were negative, and the PET scan showed markedly reduced activity in the mediastinum. So we completed, and we sort of corrected the previous endo leak, and did a stent graft with a chimney repair. And then we closed. The patient was fine, but he was fed up with the feeding jejunostomy for a long time. So he came again, and we tried to close the aortoesophageal fistula from the esophageal side. So we used clips, but it didn't work. And then finally, what we did was we banded with a dedicated band, and we closed this opening. This opening was sterile. We took cultures earlier, and there was no pus coming out. We can see the stent studs here, and the patient actually improved. And this is gastrograph in swallow, which shows there is no leak, and the stent graft is fine. So we this patient had a prolonged procedure and hospital stay, had multiple admissions almost for a year. And subsequently, in the last 3 or 4 years, we have got many patients of myocardic aneurysms in a similar situation. They are both thoracic and abdominal, both with aortoesophageal fistula and also aortoenteric fistula. So our number of patients were 19. We did thoracic aneurysm stent graft in 15 and abdominal in 4. Procedural wise, there's no problem. You can always put in a stent graft. The mortality at 1 year was almost like 2 out of 19, which is almost 10%. And the antibiotic duration was 8 weeks. And we tended to give a pre-op antibiotic in most of these patients if we had a chance. So this is in general where we stand today in terms of treating mycotic aneurysms as a salvage therapy, and maybe also as one of the therapies to continue as a standalone treatment in these patients who are surgically turned down, and they are critically ill and almost at the verge of losing their life. Thank you.
Thank you, Dr. Khanna. We have no time for discussion because we have 25-minute delay, but I have just a word and a comment. Beside the endovascular technique, that could be a salvage, the most important, in my view, is the antibiotherapy and the culture of the bacteriology, identification of the germ. This is, besides the endovascular technique, the most important. The most important. Do you agree? So we have to move to the next session. We are late, and please stick to the time because it's not good. We have a dinner tonight at 8:30, and probably we won't be on time. So if you want to eat, hurry up. So now Ironman competition of the rarest of the rare case with the expert panel. So I call Rajiv, Vijay, Ashka Bali, Venkatesh, Venki, Natesh, and Azokan. Please come to the podium. This is a very important session for the young people.
So can I invite Dr. Asokan, Dr. H.K. Bali?
This session are Jas Hussain, Rajiv Lotan, Vijay Rehan, H.A. Bali, N.M. Khanna, Venkatesh Ramaya, P.H. Natesh, and P.K. Asoka.
Where is Batya?
Sometimes you just gotta be a cowboy, you know? Ready? 1, 2, 3. Feel that little thing wiggling around the board coming your way? Okay, that's a carotid artery. Your finger is now the only patient that matters like.
the world. I put in harm's way.
Last long Angus, you're gonna do the chest. How many you doing? Me? Yes.
What is happening, please? Where will the draft?
Batya, you are the first speaker to become the Iron Man, but you have to give a good presentation before. 6 minutes, you stick on time with 2-minute presentation. You can finish sooner if you want.
Sure, sir. So, good morning to all my colleagues, and thanks for the opportunity for presenting this rare negotiate the bend, but nothing was working at that point of time. And we had our vascular surgeon, and he was of the opinion that we may take flow open. So we tried various measures like pulling, pushing, opening, but for about 45 minutes, nothing worked. Finally, a sir or my mentor came up with an idea that we have to dismantle the device head, and he dismantled the device head, and basically we physically unsheathed the proximal stent. So this you can see that the picture shows the broken head using an artery forceps, and then we have unsheathed the device. And then we have immediately taken a check aortogram to see everything is fine or not. And then we have completed the procedure by overlapping it with the Williams stent graft, just by deploying the distal portion above the celiac artery. Then because there was so much of movement, we have optimized the graft with an OX balloon all over the stent graft. And then the left subclavian artery stenting was done with the Bentley B graft. So the final result was good with no complications. And a CT aortogram was taken just to confirm where everything is fine. We can see that there is adequate expansion of all the stents, including the subclavian, and there is no endoleak. So conclusion was that on-site modification can lead to malfunctioning of the delivery system, and we have to be familiar not only with our hardware but also the device, what we are using to basically deploy, because that can be a difference between failure and success. So the message is resilience pulls us to crisis. Right? Thank you.
Thank you very much. You were good at the end, but the problem was the delivery system. Is it a problem of the graph itself from the company? What the problem exactly?
I feel that modification of, once we have unsheathed the device and modification of the device basically, and again resheathing it, probably that has disturbed the delivery system at some point of time. That can be one of the factors in this particular case. And probably we were very lucky that sir had a cool mind on his head that we can unsheath it manually also. Otherwise, we would have been stuck.
Second question, why did you call your surgeon?
Sir, for all such cases, we have a vascular surgeon. Our CTVS team and vascular surgeon are always there near the lab for any untoward events.
And what did he do?
During those terrible 45 minutes, we had the OT ready. The backup of the OT was ready. We were prepared to take up the patient for an what you can say open.
He back up you.
Yes, he was ready.
He look at you.
No.
Was a question. They were lucky. They were lucky.
We were lucky.
If no question, we can go.
I wish
we are late.
I wish Air India 171 who got a fuel switch got stuck had some mentor like this who could have avoided a big crash.
True, sir.
Thank you, Bhatia.
Thank you.
The next is Logesh. Please do your presentation in 6 minutes, because if you have a good timing, it's better for the final score.
Good afternoon, everyone. I thank the organizers for the opportunity. I'm going to present a case of post-pental equivalent with ascending aortic pseudoaneurysm treated by total arch TIVA. Our patient is a 35-year-old female with a case of Takayasu arteritis 2A with severe aortic regurgitation with dilated ascending aorta. In April 2023, she underwent aortic valve replacement for severe aortic regurgitation. 1 year later, there was a rapid rise in the size of her ascending aorta, for which she had to undergo prosthetic valve sparing, root replacement, plus hemi-arch repair at a different center. 3 months follow-up after the redo surgery, a CT aortogram was done, which showed a anastomotic site leak, and there was a huge ascending aortic pseudoaneurysm, which was measuring around 6 centimeters. In the same center, they attempted a transcatheter closure of the leak. They tried doing a glue embolization or Barkile embolization. They were able to get into the aneurysm with the help of a thermovire. However, the catheter could not cross. So despite multiple attempts, they failed. Since patient was asymptomatic then, they advised conservative therapy for advised to follow up after 3 months. Unfortunately, she presented to our emergency department with features of impending ascending aortic rupture. She presented with history of retrosternal intractable chest pain of 3 days duration. Her inflammatory markers were elevated, suggesting very active disease. Her aneurysm was looking massive and threatened to rupture anytime. Emergency thoracic surgery consultation was obtained. Surgeons rushed in and said, "We are not doing it because it's a third redo surgery." And with the active disease and considering the morbidity and mortality, they said no. And since an earlier attempt to do a coagulation has failed in her, we decided to do a total arch TIVA in her case. While planning the case, we had multiple challenges. You can see from the first picture. So the leak is very close to the innominate. It's just 8 millimeters from its origin. So what strategy we should employ to improve the seal to minimize the chances of endoleak in this case was the first major challenge. Second, in this case, we had to use a 34 endograft, which has a 24 French delivery system. That means 8 millimeters outer diameter, which is too big for her iliacs, which were measuring only 5.5 millimeters. So what major axis was the second challenge? Third, she's a case of Takayasu arteritis. She had long segment bilateral occlusions. So no retrograde axis for cannulating the fenestration. Sick patient, complex situation, no access, how to do a total arch. With these challenges, we went ahead, we did the arch planning. The first picture shows the arch vessel's ostial relationship to the superior 12 o'clock line. We did the planning, we transposed the plan onto a valiant endograft. Figure of 8 radiopeg marker was fixed, which denoted our 12 o'clock line. With respect to this, 3 circular fenestrations for the arch vessels were made. You can see that the innominate and the carotid being very close to the pathology, we have attached mini cups to both the fenestrations to improve the seal and to minimize the chances of endoleak. We also have placed a roadrunner via loop that passed through the subclavian and the carotid fenestrations, which will help us in cannulating the fenestrations. On the day of the procedure, first thing we did was to recanalize both her long segment subclavian occlusions with the help of a knuckled stiff thermowire. This was primarily done to create a retrograde axis for cannulating the innominate and the left subclavian fenestrations. Once we created retrograde axes, we went ahead to create a major axis. Since our iliacs were less than 6 millimeters in diameter, we had decided to go transcable in this case. With the help of an electrified ON4 astato wire, we crossed from IVZ into the aorta. This wire was later snared into the TTA, which was later exchanged to a stiffer wire, over which an 18 French sheath was placed in the transcable axis. So this is the pre-itogram. We can see that the leak is massive and it's very close to the innominate origin. Here comes the 24 French fenestrated endograft crossing from IVZ into the aorta over a stiff curved Lindequist wire. In the arch, with the help of this carotid radial wire loop and the figure of 8 radiopeg marker, so we oriented the fenestration to their respective target vessels, and with the help of rapid RV pacing, the fenestrated endograft was deployed. Post-deployment, systemic pressures were identical in the innominate GI catheter, left carotid, and left radial sheaths, suggesting that our fenestrations have landed appropriately. Next, we hunted to cannulate our fenestrations with the help of the roadrunner wire loop. We railroaded a 6 French GI catheter over the roadrunner wire loop, and through that, a parallel thermo wire was sent, which exited the subclavian fenestration and entered the subclavian artery, which was later snared out of the radial axis, creating a radial femoral wire loop that passed through the subclavian fenestration. A similar technique was used to cannulate the left carotid fenestration as well, creating a carotid femoral wire loop. The innominate fenestration was cannulated from the right brachial axis using a thermo wire, which was later exteriorized of the right femoral axis. So we had 3 independent glide wire loops over which 3 fenestrations were stented sequentially with the help of a self-expanding fluency covered stents. So this is the final iotogram picture we were able to achieve within 24 hours of admission in such a sick patient. The endograft is opposed well. There was no endoleak. The aneurysm was completely excluded. And more importantly, all the arch vessels were preserved. And finally, the transcaval axis was closed with a ADO device. The largest arterial access we had in this case was just 6 French sheaths in the femoral. She came for follow-up at 6 months, and the endograft had excellent posterior remodeling. The leak was completely excluded, and all the arch branches were patent at 6 months.
You are
Coming to
over
the
time.
Done, sir. Coming to the learning points, physician-modified endografts are the choice in such acute situations. Total arch endovascular aortic repair is feasible in patients with such compromised access vessel. Proper case planning is crucial for procedural success in such patients. Thank you.
Thank you. Please try to be on time because the score will be bad.
Sorry, sir.
Anyway, do you have any comments, sirs?
You were not able to enter the aneurysm.
What was the stent graft you used?
So Valiant 34, 30, 150.
Okay.
You were not able to enter the aneurysm. You tried to wire it.
Yes.
Had you been able to
sir,
enter the aneurysm,
So
what would you have done?
interventional radiology team, the different center, they attempted. But then they were able to get into the aneurysm with the help of a thermo wire. But then the catheter could not cross. So they were not able to get into the aneurysm. Despite around 2.5 hours of struggle, they realized that they may not be able to do it.
Because the pathology in aortoarteritis is much different from pathology which is there in the atherosclerotic aortic aneurysms or mycotic aneurysms. Here the margins are very, very tough. They're very supportive. There was a huge aneurysm, very narrow neck, 8 millimeter as you'd seen, and the size of aorta is also very big. It could have very easily accommodated a small ASD device to the tune of about 12 to 14 millimeter, which would have just obviated the need of all these complex procedures. And not to be able to get into an aneurysm with a wire already in, I think has a lot of tricks which could have been there, which could have landed you into the aneurysm.
Are you a surgeon?
No, sir, cardiologist.
No problem. So next, Seung-Won Ra. Seung-Won Ra.
Hello?
Yeah.
Can you hear me?
Yeah.
Okay.
You have 6 minutes.
Nice to meet you. Yeah. Thank you for your invitation. Due to delayed programs, I'm simultaneously working on another Korean TAVI meeting. So later I could not start the next session in Korea. So I will try to hurry up for my presentation given tight from the committee, acute closure following EVA in hostile leg. So this patient, 84 years elderly, hypertensive and dyslipidemia patients, normal LV function. As you can see, based on the CT aortography, a huge acute angle, hostile leg, and shorter neck, and a very huge aneurysm extended into both common iliac artery. You can see the lateral view very huge. So I wanted to make it straight to prevent type 1 embolic using the kilt technique, 26 millimeter device I used for the SNG stent graft from Korea. So initial setup planning was I will show this acute angle. So diverse methods we can choose, including the Medtronic and endo anchor or any other. However, stent graft, balloon expandable, many options. However, I want to a little bit less complicated. There's one internal leg is not so prominent, but another one is more big. So I wanted to save this one for the patient's quality of life. So we designed, because the SNG, they can provide the customized device. So initial plan was to see the make an angle more straight by the thoracic graft to make it straight, kilt technique, then standard EVA starting, and the IBD, customized IBD to save the right internal iliac, and then connecting the main ipsilateral body and the contralateral body, and do the rest of another contralateral body. This was the initial plan. But the plan was not like our discussion. So you can see the huge triple with the hostile leg. So started as we scheduled, the relatively tortuous iliac force, and this left internal iliac also not so bad, but no definite aneurysm formation over there. So this approach is not easy. however, sequentially right femoral approach, but I could not do this. We decided to do embolization, the left side. So at least one right side we have to make it alive. And this contralateral approach and 8 French multipurpose guiding, we implanted 2 vascular plug. And then this tortuosity was one of the obstacles, very tortuous iliac course and huge aorta, and the outflow was very short. So we started with after delivery bigoshes and the Lundquist wire to make it straight, but it was not easy. As you can see, many tortuosity to overcome. So even the stent graft delivery, stent graft cannot go straight course like this way. It was very difficult because huge aneurysm and this angulated neck also going to the distal port was not easy. However, the many effort we tried, then elevate center this guiding sheets longer to deliver, make it straight, and as we planned, the tilt stent first, and then a little bit improved. Then the main body to make it more straight in the proximal position, main body deploy, and this is a right interiliac bifurcation. So bigger interiliac artery here. So we did this fenestration is customized entry. This bifurcated stent graft to the left internal. This also needs the contralateral approach to cannulate this lumen and the angiocatheter supported wiring, then deliver the A French uncell check flow to deliver the stent graft, and we nicely placed the additional stent graft here. Then IBD was nicely done, but to overcome the all other next procedure was not easy. So during manipulation, during pulling back, the IVD olivity was disconnected and removal. It took time. However, so complex situation, immediate olivity was removed, and then this free floating we have to rewiring to the additional ipsilateral and contralateral limb. So sequentially, we ipsilateral limb deployed, and the contralateral limb deployed along with the previous main body. So after this is the overall graft contour, looks very complex. However, after full adjuvant valvular reliant, this is a fine angiography. No definite 1A embolic, and the perfusion looks good. Bifurcation graft also good. But at the time, there was the starting point of Korean medical crisis, medical political conflict. So there was no residency. All residency internal medicine escaped from the hospital. So no hospitalists, no one to stay to take care of patient. So patient, there was something ongoing trouble, but could not catch. So this patient, the sudden total occlusion and limb ischemia developed. We did the supportive care with try to re-intervention, but finally patient got multiple organ failure. And from this case, we sometimes did very, very intensive, difficult, complex procedure in high surgical risk patient, but too much complex procedure is not good for patient. This patient maybe I would have chosen better if without the IVD device, just a simple kilt technique and finish the procedure and stage procedure for the interiliac if needed. This is my presentation. Thank you for your attention.
Thank you. You were a little bit over time. My personal opinion as a surgeon involved in the endovascular techniques since many years, your case was a surgical case because an angulation of the neck is not hostile. It's a contraindication. You didn't respect the instruction for use. So it's normal to have problem. So it's my opinion. Other, monsieur, you have something to say? Very short. I told you what I think. Do you agree with me?
We agree, sir. We agree.
Thank you. You will be welcome. So, sir, we go on. We go on to the next. Thank you anyway. Colambe.
This,
Col-
this is really the best option is to do surgery.
Sorry, it's over. Colambe, you have 6 minutes, and we hear you.
I check. Am I audible? Yeah. Good afternoon, everyone. I'm Dr. Girish. I'll be presenting on recanalization and stenting of middle hepatic vein across IVC stents using electrosurgery in a case of primary Apla syndrome with Budd-Chiari syndrome. So, coming to case history, she is a 36-year-old female housewife with primary Apla syndrome and Budd-Chiari syndrome since 2015. She presented in 2020 with rapidly progressive ascites and abdominal pain. On evaluation, she had complete occlusion of infrahepatic inferior vena cava with thrombotic occlusion of right and left hepatic vein at their confluence, which was treated with IVC stenting with a 22 into 70 millimeter self-expanding bare metal stent, which was done in elsewhere. Then after 2 years, he had recurrence of symptoms, which was again found to have a subtotal occlusion of IVC stent. Then followed by another IVC wall stent was put, overlapping with the previous stent with 22 into 45 millimeter wall stent across the hepatic vein confluence, which was also done outside. After 1 year, she had again IVC stent ISR, which was treated with the balloon angioplasty with Jomiva balloon. It was 22 by 40 balloon. Then she came to CMC Vellore 2024 April with a progressive abdominal distension and pedal edema since 2 months. On examination, she has ascites, dense abdomen, grade 3 pedal edema. So first procedure we did IVC venogram, which showed distal edge of IVC stent 18 to 90% stenosis. So we did balloon dilatation serially with 8 12 and 16 balloon. This is the final result, which is showing good flow across the IVC stent, but hepatic veins were not flowing because the stent was across the hepatic venous confluence. So we thought of seeing the hepatic venous outflow. So we did transhepatic CO2 angiogram. This is the transhepatic angiogram. Here we can see this middle hepatic vein is large and it is filling through collaterals, and it is occluded across the confluence, across the IVC stent. And below here you can see the portal vein, so which is intact. So what was the uniqueness? There was total occlusion of the middle hepatic vein confluence across two IVC stents. And what should we plan? Whether should we send her for TIPS or hepatic venous recanalization? So TIPS was associated with its own complication, and guidelines also recommend hepatic veins outflow recanalization is always preferred before above TIPS. So we planned our case as recanalization of middle hepatic vein across the stents using electrosurgery technique with the guidance of transhepatic CO2 angiography to visualize the hepatic veins. So we did the transhepatic CO2 angiogram. Here we use 20 gauge Chiba needle. We 15 ml of CO2 was injected, which showed a large hepatic vein and middle hepatic vein and left hepatic vein, but it was occluded across the IVC stent. This is the hepatic venous pressure, which was elevated, but there is no pressure tracings seen in this. So first with the help of Chiba needle, we canalized the middle hepatic vein with a micropuncture, and the wire was sent into the left hepatic vein. And over that micropuncture, we changed it to 4 French sheath, and over the stiff glide wire. So this was the technique. This was the article in JACC published in 2023. In that they use this technique they use for transcaval access. So 014 guide wire they use. inside a microcatheter 1.8 French, which was placed in a 035 microcatheter. And the technique was like a 4 French cut JR with a straight tip was placed at the hepatic venous side of the occlusion, and 014 wire was loaded in the coaxial system composed of 1.8 French fine cross microcatheter, and this was loaded in 4 French JR. Then back end of the 014 wires stripped off the insulation using a scalpel, which was to enable the electric conduction, and clamped to electrosurgical pencil using forceps. The JR was positioned towards the IVC stand by alternating between orthogonal LEO and REO view. So with the JR pointed at the IVC stand, the guide wire touching the IVC stand, the electrosurgery was set at cut mode and a brief electrification was given for 2 to 3 seconds, and guide wire was advanced, which transfers the hepatic end of IVC stand, and the IVC end of the stato wire was caught with a snare, and wire was snare out of right internal jugular vein sheath. So here you can see the orthogonal views, LAO and RAO, and the second image is showing the electrification given to the stato wire, which crossed the when IVC end of the stent. Then after externalizing through the right internal jugular sheath, we dilated with the 014 coronary balloons 2.4 4 mm. Then 6 French JR was torqued from right internal jugular vein sheath into the middle hepatic vein, and a parallel ASS wire was sent. Over the ASS wire, we have dilated with Mustang balloon 6 mm, 8 mm, and 10 mm conquest balloon. So after that, we have recanalized the IVC stent, and it was dilated with 8 mm and followed by 18 mm Atlas stent. Then we did kissing balloon dilatation of middle hepatic vein balloon and IVC balloon. After that, we have stented middle hepatic vein from right internal jugular vein sheath with a 14 by 19 Bentley aortic B graft. So, and then kissing balloon were dilatation with a stent balloon and Atlas balloon. This is the final result showing very good flow at middle hepatic vein and IVC. And the pressure tracings were seen in the hepatic vein, and pressure was still slightly elevated. And the transhepatic tract of sheath was closed with the embolization coil. She came to follow up after 6 months. Her edema, abdominal distension all subsided. She lost 8 to 10 kg weight. Her hepatic vein stent and IVC stent were patent on Doppler. So conclusion, this case demonstrates the feasibility of recanalization of terminally occluded hepatic vein in presence of jailed IVC stents. Correct direction of electrified wire is important and should be directed by fluoroscopy and in orthogonal views. First ever case of middle hepatic vein recanalization across IVC stents in using electrosurgery. Thank you.
For the next person, try to keep on time.
Thank you.
It's very important.
Yes, sir.
In order to keep on time, you put off 1 or 2 slides which are not useful, and you stay on time.
Yes.
Question?
You had a patient with a antiphospholipid syndrome.
Yes, sir.
With a thrombotic tendency, and we now have multiple stents. We have stent grafts across. You think this is going to last in the long term, and what anticoagulation you use in this patient?
We use warfarin, sir, for APLA only. Warfarin, and we have kept her on aspirin also. So, and she is doing well after almost 6 months now.
Thank you, Kolab.
You have a significant part of your stent graft into the IVC. In a patient with APLA, I think it should be a concern. One. Second is, I think a biplane cath lab would have been handy in this case to get into the IVC.
Yes.
Third, an angled microcatheter would have been far, far better than your standard microcatheter to electrify your stato wire. Fourth, and it's of great importance to use an intravascular ultrasound. You had a big excess. Once you are in the liver, 7, 6, 8, 9 French is not an issue because finally you are going to close with a coil. So I think these are important things which could have been kept in mind, and surely a stent graft would have been avoided.
Thank you, sir. We have to go on. Thank
Yeah,
you.
thank you,
Thank
sir.
you.
Thank
The next is Mohan. 6 minutes. Please.
Good afternoon.
I'll just share one of the life-threatening scenario in whole gambit of pulmonary embolism. It's a 57-year-old male Canadian citizen who had a fall in Canada 2 weeks back, subdural hematoma. He came here for some family function, and he had a sudden onset breathlessness, desaturation, hypotension. He was living nearby our town of our hospital. When he came, he was on inotropes, very narrow pulse pressure, tachycardia, typical look like of a pulmonary embolism. Counts were, he had a thrombocytopenia, he had an altered echo texture. We thought that it is probably CLD or something else. His OTPT, the things were raised, and we can see that it's a very, very high risk scenario. Typical ECG of pulmonary embolism S1Q3T3. And this was the echo. Something very scary for all of us in our clinical cardiology practice. Multiple thrombi, which looks same echogenicity, looks like an intransient fresh RV dysfunction, and it was going into pulmonary artery. So the crisis was there, patient was very sick. So management options were discussed like surgery, thrombolysis, low dose thrombolysis, thrombosuction with heparin. Surgery, we all know that it is very, very high risk. Our surgeon said that he is not going to touch, and our past experience with similar surgery was not very good. Thrombolysis, again, we know that thrombocytopenia, multiple thrombi in transient, so outcome is looks very, it's a try. So we have done in the past, and literature is there, but no definite data on this. So thrombosuction with heparin, we had our own experience of right-sided cardiac thrombi with a variable uh, response to thrombolysis and other measures. And mechanical suction, yes, we have done, or there is a literature to suck directly with small catheters, but these are huge thrombus burden. So it was a challenge. So we thought of this new system Indigo, which we haven't used in the past with the lightning technology. Luckily, it was available. So we took the patient and we thought this is the best choice for this patient. So we took obviously the shot from the femoral when we saw that there is a thrombus in the RVC. So obviously we have to suck that thrombus and go up. So we took just half a 30 seconds. So we used an echo to be there so that we can precisely put this catheter, Indigo catheter. And just to watch, there were different views. Yeah, now you can see that the catheter is there at the thrombus. It has sucked. It is sucking. Yeah, it's gone inside the thrombus. This is a large thrombus. This was the ECG. This was the echo. This was 7 days after that. Obviously, patient responded hemodynamically. So we have seen these cases in our lifetime, and every time we were struck, there is no guideline, hit and trial. So patient came from all the way from Canada for different things. So I would say it's a surprise catastrophe. But I think whenever this innovation meets intervention with some slice of luck, the positive outcome is likely. Thank you very much, sir.
Thank you, sir. This is a very clean case, and that I appreciate. Comments?
So as far as your pulmonary embolus is concerned, your drugs worked there because you did work in the heart itself, not in the pulmonary artery.
No,
so that
we sucked RV thrombus, and then there was some slice. Then we went inside.
large task was done in the heart itself.
Yeah.
And PA pressures are decreased over a week's period of time. I think is because of the drugs.
Yes.
Second is an IVC gram in such cases. I think balloon inclusion of the IVC at the IVCRA junction and then shooting the dye is the best method because pushing dye in these cases, one can push the thrombus up.
It's a very soft.
Second is a thrombus. If you look at the flow rate, your flow rate of your pigtail is never so high, so you can have a false impression of a thrombus also. So IVC gram with a balloon occlusion at the IVCRA junction and shooting a dye is the best method to show the presence of a thrombus.
Thank you for your comment, and thank you, sir. We have to move on. We have half an hour late. So the next is Magela. You have 6 minutes.
Respected judges, respected seniors, and dear friends, I'm presenting a series of cases wherein the rare cases of RSOV device closure, we look into all these aspects, the sinus, the size of aneurysm, chamber of rupture, the certain situations which really pose challenges where inadvertent cannulation of the RCA, residual shunt, transient LV dysfunction, hemolysis. We always go by the transthoracic echo followed by the transesophageal echo, but in certain cases, it could not be done. We do the LV angiogram and then the aortic root angiogram. I'll go into the V size both fluoroscopically as well as TE. Here is a case where we had an inadvertent RCA cannulation while crossing the defect, and you are able to see the patient went into sudden RCA occlusion, which was corrected with oxygen, intracoronary NTG, and by removing the catheter. So we form the loop in any of the SPC, IVC or the aorta. There is a lot of difficulty in getting the delivery sheet, especially in young kids. Here is one patient which was the youngest in the world reported, a 12-year-old female. We are able to see that the device has slipped into the aneurysm. The ideal is it should be in the aortic root. In this patient, it slipped into the aneurysm. But this child is under follow-up for almost 9 years and the baby is doing well. Another one is the oldest case, which I've already described. It's 73-year-old, 72-year-old. That day was his birthday. So with the acute right heart failure, with the congestive hepatitis, acute liver dysfunction, DIC, acute infarct of the frontal lobe, with a platelet count of 48,000, referred from one of the larger quaternary centers, with RSOV, with NCC into RA. We didn't do the TE. We were about to deploy the device wherein there was a small injury in the RV. Patient developed tamponade. We immediately drained the tamponade with the pigtail in situ, then deployed the device. It was a marathon, almost 12 hours post. Then the patient stabilized. Device was well deployed, no residual shunt, with normal LV function. And this is one of the large, huge aneurysmal sacs, almost 15 millimeter. Prafula Karkasar, who has one of the maximum number of series, has told that up to 12 millimeters ideal. But this patient was during the COVID pandemic. The surgeons were not willing to take up a huge aneurysmal sac measuring 15 millimeter from the RCC into the RVOT. So we took in ADO1 device 1416 with a retention skirt of 22, but we were able to deploy the device. But once deploying, we found that it was impinging. There was a slight impingement on the RCA. Then we realigned the disc, we repositioned so that the RCA is not involved. Usually, it is a theoretical possibility that it involves the coronaries. It's very, very rare. But when choosing, especially in RCC into RVOT, when choosing larger devices, it is very essential. We need to cannulate the RCA also and see if there is occluded or if there is an impingement, and realign the device and then deployed it successfully. Then there was no residual shunt. This is and the coronaries flow. Once again, acquired aneurysm RSOV is very rare. This is a 16-year-old student who has been closed for perimembranous VSG, comfortable 6 months, then now developed a RSOV. How to differentiate from a VSG? It's quite simple. Many thought it is a VSG, but once they refer to us, there was a continuous murmur, a simple auscultation, a continuous jet, which shows now this is a very small defect. It was only 2 to 3 millimeters of which device we plan for an ADO2. Normally we deploy via the antegrade route the device. All cases we are done via the antegrade route, but this case we went through the retrograde route using a talk sheet, and we placed. It was very tough, but we could deploy an ADO2 in this acquired RSOV, and the residual, there was no residual shunt. And during the COVID pandemic, it was very unusual. We saw these cases with like a fistulous tract, not like an aneurysm. 3 cases, very young, one 18-year-old female, then 21-year-old male, and a 23-year-old female. But while doing this, there was this one of the complications that while exteriorizing the loop, it went into one of the chordae, so this should not be done. So we redid the procedure and then finally closed the snared it from the SVC and closed it successfully. These tunnels, 3 tunnels were closed successfully and they are on follow-up. All these patients present with class 4 failure, they're very sick to manipulate in them in such patients. And finally, this is my last case, a double RSOV. It's been very rarely reported, both 2 entry and 2 exit sites. So I planned for a single device 1416. You're able to see that once the device is being deployed, there is still a residual shunt across. Then once again, what I did is I realigned the disc and I realigned the disc, and there was no residual flow. We are able to see it was a bicuspid aortic valve with complete occlusion of both the defects. And I thank one and all. We have encountered 3 cases of LV dysfunction post-device closure, 1 case of hemolysis which was successfully managed, a total number of 29 cases, the youngest, the oldest, one of the largest, and multiple defects, 5 to 15 millimeter, which was accepted in the European Heart Journal. A large series, 3 cases underwent pregnancy. They are doing well. So all cases of RSOV can be closed if it is planned very efficiently and managed. Associated factors. Thank you.
Thank you very much. It was a nice case. You did well on the 3 series. There are computation. You have because you comment very well.
I think nice panorama of collection of RSOBs starting from kids to the elderly. Few points. First case which you showed you, the catheter inadvertently entered the RCA and patient arrested. Word of caution, always have a wire leading it. Thin PTC wire leading over this can prevent all this. Second is your patient arrested because you had air there. Air went into the right cornea. Last case, your catheter got an intercaudal space, and that's why you had a problem in advancing a sheath. It is always preferable that in such a situation, use a balloon tip catheter like Swanganj catheter. Third, the biggest device I have used is 24 millimeter from Chinese, so not 12 millimeters. You can go higher up.
Yes.
And as far as coronary is concerned, coronary may be involved in some cases if the aortic root is not dilated. Typically, if you have a associated bicuspid aortic valve, which is not an uncommon thing, other associated things are VSD and AR. If you have bicuspid aortic valve, then the aortic sinus is large enough. Then the coronaries are usually not involved.
A short comment, the others?
Thank you, sir. The first case also, she recovered, sir. There was an arrest, but immediately we resuscitated, gave an IV fluids, NTG, removed the catheter, and we deployed the device for that.
That was too far deep, almost into the PD.
Yes, sir.
Thank you,
Thank
madam.
you, sir. Thank you.
Thank you very much. The last case is Sharon. Sivasai Sharon. Come on, 6 minutes.
A very good afternoon to one and all. My name is Dr. Sivasai Chiran. I'm from Narayana Institute of Cardiac Sciences. Today I shall be discussing about an interesting case we did at our hospital, led by Dr. Sanjay Mehrotra, sir. This is a case of a 63-year-old male who had presented to us with complaints of retrosternal chest pain, sweating, and dizziness, and who was in a critical condition. Both hemodynamically and biochemical parameters showed signs of shock with severe metabolic acidosis, deranged biochemical parameters such as deranged liver function and coagulopathy, signs of visceral malperfusion syndrome. And routine evaluation suggested that LV function was 45%, and CT angiogram suggests of Stanford type A aortic dissection. There was a moderate aortic regurgitation and mild to moderate pericardial effusion. Considering the critical condition and a very diffuse aortic dissection, the surgeons refused to operate on this person in view of increased morbidity and mortality. So we plan to do an abdominal aortic stenting in this case to expand the true lumen. I'll show you the CT aortogram now. This is planned to improve the visceral perfusion so as to stabilize the patient condition. So initially we planned, the CT aortogram was done, which showed Stanford type A aortic dissection, the entry point being in the aortic root and flap is extending up to the abdominal aortic bifurcation, and osteoproximal segments of the bilateral common iliac arteries were also involved. As you can see, the true lumen has been compromised, which is very small in caliber, and it was compressed by a large false lumen. And the dissected flap is extending up to the right common carotid artery also, showing complete occlusion to the visible extent. However, the femoral vessels are normal in course and caliber, and left iliac artery was formed mainly by false lumen. The further assessment of the CT showed that vessel arteries are being supplied by the true lumen, that is celiac artery, superior mesenteric, and inferior mesenteric arteries. And we also have evidence that there is good, the vessels are supplied by true lumen, but there is severe, significant narrowing of the true lumen. So for the procedure, we took bilateral femoral artery access, which was obtained under ultrasound and fluoroscopic guidance. As we can see on the CT, the flap was extending till the bilateral common iliac arteries, but femoral vessels were all normal in caliber and course. But with the aortogram, we were not very sure if we were in true lumen or false lumen. Injections were done via the right femoral artery using a diagnostic catheter, were suggestive of that it might be in a false lumen. This is again because there was significant compression of the true lumen, which was noticed on the CT aortogram, which caused difficulty in accessing the true lumen. So further, we were able to cannulate the RCA. Again, we were hopeful that it was in true lumen, but when we took a non-selective shot and a pigtail injection, it showed that we were obviously in the false lumen. So how to approach the visceral arteries? In the CT arteriogram, as we discussed, the celiac, superior mesenteric, and inferior mesenteric arteries were arising from the true lumen. So we tried multiple times again trying to cannulate these arteries via femoral arteries. It was not possible. And further, we took a right radial axis in the hope that we'll be in true lumen. Again, we ended up being in the false lumen. So we went back and reassessed the CT, which showed that the left subclavian artery was found to be arising from true lumen. So we further took a left radial artery axis, and via the left subclavian artery, we advanced that into the descending aorta. And we were successfully be able to manage to cannulate the celiac artery via left radial artery. Later, passed a thermo wire, which is parked in the descending aorta and was snared externally from the left femoral artery. Following which, we took a catheter over the left femoral artery, and further injections shows that we were in true lumen. Initially, a 24 into 45 mm wall stent was deployed over a Lunderquist wire. And over that, a bare metal stent mounted over a Z-med balloon was positioned in descending abdominal aorta proximal to the previous stent and deployed. However, this further improved the flow across the mesenteric arteries. But the proximal flow was obviously not very good because of the collapse of the true lumen. So we further deployed a third stent, a self-expandable wall stent over the Lunderquist wire in the descending thoracic aorta overlapping the previous stent. The final angiogram showed us that though the true lumen is still compromised, the visceral artery perfusion has improved. Post-procedure, however, the general condition more or less remained same, but biochemical parameters and metabolic acidosis has improved. But over 12 hours later, patient developed massive pericardial effusion and eventually succumbed to this underlying condition. So the take-home message being a high-quality CT diagram usually helps us to plan these procedures, and understanding the vascular anatomy in detail will help us to personalize the treatment and anticipate challenges and improve the outcomes. Thank you.
Thank you. Did you have an idea before you started that you are going to get into this problem, or it is only
Yes, sir.
while
We
you
anticipated
were doing
this.
it that you got into this?
No, we anticipated we'll have trouble because the true lumens were very much compromised. But since we had no other options, we thought we should try to bail him out.
Okay. Thank you.
Thank you, sir.
I believe Dr. Ramaya was also with us from US on Zoom. Is Dr. We're just going to
Yeah, I'm here.
Okay, I hope we are just collating the results, so maybe you can WhatsApp to me the number 1, number 2, and number 3 as per your assessment. I hope you like the cases.
Here. I'll send it to you.
Okay. So before, Can we have the Iron Man movie playing again by the time they are collating the results? And we will soon start with the announcement of the result.
Did you get it, Dr. Khanna?
Probably 8 minutes for presentation. I think 6 minutes is little too small for extensive cases. Just a session.
ठीक है ना सब लोग मतलब हाँ कंसेंसस कोलंबे हाँ well number 2 is this lower वाला without the sound ये last is
So, I mean, we've collated the results. The first runner-up is Dr. Cecily Mary Magella from Chennai. So, you can come up to the stage. The second runner-up is Dr. Logesh MR. Is he here? And the winner of the Ironman is Dr. Girish Kolambe from CMC Vellore. I'll request all of you to come up, and also all the people who participated and were qualifiers in the Ironman competition. And this was a series of almost 70 cases which we received, and we selected these 7 cases for presentation. So all of you should come up, and I'll request Dr. Busquet and the jury to actually give the plaques to them. Can I have the plaques? I'll announce. So, nahin, baad mein. So first, let me give it to the qualifiers for the Ironman. Dr. Bishop Mohan from DMC Ludhiana. Dr. Bishop Mohan. Dr. Shiva Charan from Bangalore. Dr. Ra is, of course, in Korea, so he can't be here. Dr. Himanshu Bhatia from Hyderabad. Please join us for the award ceremony.
Can you give him the mic now? Give him the mic now. Mic. You can hold it for him. Jury.
Jaldi lao yaar. We have an award for the jury as well. Let me ask give it first to Dr. Busquet, being the esteemed member of the jury. Dr. Rajiv Lochan from Dubai. Dr. Vijay Trehan.
He's a star.
Dr. H.K. Bali from Chandigarh. Sorry. Dr. Natesh from Jayadeva Institute of Cardiology, Bangalore.
But it was almost consensus. Everybody was there.
Great.
Dr. P.K. Asokan from Kozhikode.
And finally, for the best person, Dr. N.N. Khanna.
Great work. All the credit goes to Dr. N.N. Khanna. Wonderful conference.
So thank you all very much. And to catch up with the time, let's go on to the next part of the program, which is a very important session, Professor M.N. Khanna oration. And this year we have been very lucky to have Dr. Upendra Kaul to give this oration. And the title is very, very interesting: From Coronary Angiography to Present Day Coronary Intervention, an Experience of 45 Years. Dr. Kaul has been the teacher and the inspiration of all of us when we were doing our DMs. Almost the entire country has learned from him, and he's one of the pioneers who started coronary angioplasty and interventions in the country. And he is also one of the directors of the India Live meeting, which is the biggest interventional meeting in India. Dr. Kaul, please.
Good afternoon, friends. It's really a matter of great honor that Professor Khanna has given me the opportunity to share my experience, experience of this generation, the last 4 decades. And the oration is in the name of Professor M.N. Khanna, who has been a great visionary, a great cardiac surgeon who has, been known in this region for many decades. So what I thought that I would share some nostalgic experiences, nostalgic for those who belong to this my era, and some training to younger people who would see how we have reached this stage. So the topic as I selected is coronary angiography to present day coronary interventions. Well, we all know the idea of doing something to the heart came long, long back. It came in 17th century when Hales put in catheters inside a horse, and those catheters were made of brass pipes, glass tubes, and a water column to see that there is something called a pressure in the arteries. And then the first time somebody dared to put in a catheter inside his heart was a surgical resident who thought that the best way of delivering a drug would be to give it in the heart, and he put in a catheter. I think it was a urology catheter, and put it inside, and nobody agreed. So he put it on himself and rushed to the X-ray department to take this picture, and a very unique picture for those days. And then he, along with 2 other pioneers, Cournard and Rickards, got a Nobel Prize because they worked on this. They worked on how to measure pressures, and cardiovascular physiology started. And 1958, it was again an accident when the first coronary angiography was done. The catheter inadvertently slipped into the coronary artery. It was basically, he was doing an aortic root angio, aortic regurgitation. And that day, coronary angiography started. The idea of doing something to the vessels came to Charles' daughter, who started making catheters, stents, and started retrieving foreign bodies from the heart, from the stomach, using those catheters. And we also know something called daughtering. So the name comes from him. And then came surgery, coronary artery bypass surgery. And the name actually is given to Favallaro from South America, but actually, who put in a graft, but actually it was first done by a Russian in long back in 1964. And, Russia being a different, continent, and nobody took recognition. And then Michael DeBakey also had done it, but we know that coronary artery bypass surgery started. But it was this gentleman, whom all of us know, Andreas Grunzig, who for the first time showed that you can get into the coronary artery in a living person, talking to the person, and perform procedures. And it all started, there were no catheters available that time, so he started making some catheters, prototypes in his kitchen. And then, first time he presented an animal study in 1976 in American Heart Association meeting. And the big time cardiologist thought it is just, playing around and what is this? He's talking nonsense. But he went on, he was a great teacher, he always taught. Any technique cannot become popular unless it is distributed to all, and he was one of those persons, and all of us sitting here who do angioplasty because of that training which started that time. And the first coronary angioplasty he did, everybody knows, on 14th of September 77, and 10 years later that artery was still patent. It was just a balloon angioplasty, and the gentleman in the center is still living. He's 80 years of age, Adolf Bachmann. And then the first paper on angioplasty of 50 patients with a bypass surgery rate of 10% and 3 patients developing MI. He had the courage to do it and also publish it. And then the balloon era continued till 1995. The choice of lesions used to be very critical. It was confined to 1 or 2 vessel disease. Results were unpredictable. We always used to have a surgeon sitting not to start his first case of surgery. And I was in All India Institute those days, till I tell him I have done the procedure. And there was high rate of restenosis. We published, this was the first published report from this part of the world in 1989. And then we also talked about restenosis. We're not shy of that, so we talked about restenosis and published it in 1990. And then started the measures how to reduce this restenosis. Came in drugs, ACE inhibitors, fish oils. Large doses of drugs had to be given because if you want to inhibit the cells, they won't get inhibited by 5 milligrams or 10 milligrams. And then we did some work with fish oil supplements, published it. It didn't work. It was a negative study. We did work with 40 milligrams of enalapril. Didn't work, but published it. And then came directional atherectomy. Why don't we take out the atheroma? It doesn't work. We must take out the atheroma. And directional atherectomy, some of you might have heard of it, is no longer there. And then came the rotational atherectomy, where you put in a diamond bar and rotate it at very, very rapid rates and make a smooth lumen, especially for calcified lesions. And it has, we know, a differential cutting principle. And we know calcified lesions now have many other ways of handling. We have the shock wave, we have the other kinds of angioplasty like orbital atherectomy, all being done. So the calcified lesion treatment is no longer that difficult now if you have the tools and if you have the technique. And then came high-risk angioplasty. How do you do angioplasty in poor LV functions? And here my friend from Washington, Dr. Shaw, and me joined because he couldn't do anything there because of FDA. So we created something in the cath lab. We took a cardiopulmonary bypass machine and put percutaneously and did some cases together and published them in high-risk patients. And that seemed to be not a very user-friendly technique, but we showed that it can be done. Cath lab can be, used as an operating room where a perfusionist needs to be coming. And now today we have short, support systems. We have the Impella, which can, actively pump blood from the heart through a pump, and we have the ECMO. And then now that it's become routine in many big centers, and we also have expert consensus for the country, what are the centralized algorithms to do this procedure. Then came the era when it was thought that how to handle diffuse coronary artery disease. Surgeons started doing, transmyocardial revascularization. So we thought, why should we not do it in the cath lab? Why should we send it to the surgeons? And came the era of PTMR, we called it percutaneous, myocardial revascularization using a laser system. And did it once again with Dr. Shaw. He came here and we had this machine, borrowed it, and finally made the hospital buy it also. They're still cursing me that you're not using it anymore. and we published some papers, and there were positive results. We felt that patients are running after this procedure. Till the time a randomized study came from US, Marty Leon and others, who showed that it was just a sham. It was because they had a sham controlled trial and it was a negative trial. So we have to have a comparative in evidence-based medicine to prove a technique. This is a classical example of that. And then it was all balloon angioplasty, and this is Spencer King. I don't know whether you recognize him, young Spencer King singing balloon angioplasty blues, but that gentleman next to him is sitting his son. And the third gentleman there is Patrick Sarayas, who is laughing because he always felt balloon is not going to last. A stent has to come in, some scaffold has to come in. And then came the intravascular stents, and Sigwart started and Jack Puel started it. And then it was seen that not only do the stents make the balloon angioplasty procedure safer, predictable, but also reduce restenosis. And the two trials from two sides, of Atlantic, American trial, the stress, and the European trial, the Benistant, showed that stents work. They reduced restenosis. And by 1999, 90% of the angioplasties were stented. And there again, we published our data using Parma-shared stents in a significant number of patients with good results. Then there was a problem. Can we be putting stent inside a thrombustic lesion? So how can you, there's a thrombus, it will all clot. And then we should, along with my, student and Rajiv Agarwal, we did a study and showed that in a thrombus containing lesion, you can easily put in a stent and get away with it. And then came the era of primary stenting. Primary stenting in acute myocardial infarction, we did for the first time in this part of the world in 1999 and showed that the results were better than balloon angioplasty. And after our results came the PAMI stent study from US. Many people don't recognize this. And so we were one of the pioneers in starting stenting in acute myocardial infarction long back. But then we saw restenosis, and there was a problem. And neointimal hypoplasia coming in, and drugs given orally were not working. And then it was seen that if you coat the stent with drugs like rapamycin and Sausa, and again Patrick Sarayas for the first time showed that you can have clean results after 6 months, a year. And came the RAVEL study, which said everything is zero restenosis, zero TLR, zero thrombosis. But then we need to test it in a more complex patient. And once again came two large trials for Cypher, which was a sirolimus eluting stent, and Texas, the paclitaxel eluting stents. And both of them worked. Then we had our own experience because we had the Texas available before it was available anywhere as an investigational stent. And we showed and presented at TCT that the restenosis rates were marginally better, lower in Cypher. And we also said that the restenosis which comes in a paclitaxel eluting stent is usually diffuse, whereas in a sirolimus stent, it is usually focused. And then it was felt that when the drug-eluting stents came, that we can stent anything, there's no problem. Till the time we started getting slowly the stents getting thrombosed. Initially, there were anecdotal cases reported both with Cypher and Texas. We also showed aneurysms in after drug-eluting stents. This we showed in 2005. We showed that these aneurysms could start leaking also. So it's not so easy. And then came this big furore in September 2006, when in fact it was shown that drug-eluting stents increase deaths. They're like ticking bombs sitting in the heart. They can explode anytime. And Salim Yusuf made a use of it. He said, all of you who have stents, drug-eluting have ticking bombs. It can blast anytime. And sensational headline came in the press. The stents, use of drug-eluting stents started coming down. Till the time it was found that we must look at it, and large meta-analysis was done by the Swiss National Science Foundation. It was shown that death and MI were not different in the first generation stents. it was basically thrombosis, which offset higher, in bare metal stents, the restenosis was higher, it was lower, but thrombosis was a problem. So we need to have safer drug-eluting stents. And then came these new generation stents, and we all know about that, everolimus, sirolimus eluting stents with good bioabsorbable polymers, and started the Zions, which has become one of the market leaders. Spirit studies and showed that they work, and their Zions is better than Texas. That means paclitaxel is not as good. And then came this impression that paclitaxel is as good as sirolimus or everolimus in diabetics, but not in non-diabetics. As you can see, non-diabetics, there's a huge difference, but in diabetics, not. And this kept on, and this is a meta-analysis by Gregory Stone. And then till the time we thought, why should we not? We're the diabetic capital of the world. Why should we not do? So we did a tuxedo study, and in which we compared everolimus eluting stent, Zions with Texas in 1,800 patients, and we showed it, and it was published in NEJM. It was a late-breaking trial, and that the stent thrombosis was higher, the TLR was higher, the TVF was higher with paclitaxel eluting stent, and that was the demise of paclitaxel eluting stents. After that study, everybody started discarding them, and Boston Scientific, who had sponsored this study, were the first ones to come back with PROMIS, everolimus eluting stent. And then came drug-eluting balloons. And then this was once again along with Martin Unroden, a German who had come here. And then we showed that whether drug-eluting balloons works. What we did two ways. One was to use a drug-eluting balloon first and put in a stent there. And then the other was put in a stent there and then use a drug-eluting balloon. Does it make any difference? And it was shown that it does not make any difference. Whether the drug-eluting balloon is first used or first a bare metal stent is used and then a drug-eluting stent, the late loss is the same. And this study was peptide 1. And after that, many peptides have come, and now today we have solid indications, drug-eluting stents for restenosis, small vessels, side branches of bifurcation, and now hybrid, proximally in a long lesion, put in a drug-eluting stent, and distally you go with a drug-eluting balloon because it's safer and less chance of thrombosis and other things. Then came the bioabsorbable scaffolds, which disappear, and that was a very good concept that within few years, nothing will remain there. It starts dissolving within a year, but the problem came, and long safety and efficacy had to be shown, and then started a very ambitious program from, Absorb. And then what happened is that Absorb 3 showed that results were equivalent. They were comparing it with Zions, but then we saw the longer term results of it. At 3 years, the Absorb 2 showed that the thrombosis rates were higher with bioabsorbable scaffolds. And with that, as you can see here, the thrombosis with the Zions was 0, where it was 3% at 2 years. And then you have to continue dual antiplatelet therapy for very long times. So the BVS promise is not fulfilled. Long-term results have been concerning, and stent thrombosis has been there. And Abbott finally withdrew it from the market. And then started the concept whether we should need thinner strut, BVS, magnesium stent. They are still making efforts, but the thrust is poor, and nobody is actually pursuing it because the bare metal stent with thinner struts have become so safe with shorter antiplatelet durations, 3 months, 6 months is enough. So I don't think they have any future. Then what about the Indian scene of coronary stents? And there was a price cap in the coronary stents, as you know. This came, and the coronary stents in 2017, the prices were slashed, and it was actually a boon, and it was felt that more people can never afford multivessel angioplasty, and it will also boost the domestic industry. But then a regulation had to come that the Indian stents were equivalent to imported stents, and then came this study, which me, Patrick Sarais, did talent study, in which an Indian stent, the Supraflex, was compared with Xience, and it was shown that the results were identical at 12 months. Some cohorts, the Indian stent was better, and the prices had been capped. The market competitiveness became very important, and Indian stents in India started, becoming very popular. And today, I think more than 70% of the stents used are Indian stents. But what about complex multivessel disease and diabetes? Can we compete against bypass surgery? Like in the Freedom trial, it had shown very clearly in 2012 that bypass surgery is the way to go because it improves the survival. And then can Indian stents match international market leaders? So we planned this study, the Tuxedo 2 study. And the enrollment of this study is over, in which we have two arms. One is comparing Supraflex with Xience, and the other arm is comparing the results of these two stents with the performance goal of Freedom study. The study enrollment is over, and the tertiary objective in this is to compare prasugrel with ticagrelor, because one of the German studies has shown that prasugrel is better. And this again is the tertiary objective. These results will be presented at TCT, hopefully in the next few months. So pharmacotherapy has changed, better, shorter antiplatelet therapy, radial route has become a way to go, and stricter OMT goals. We treat hypertension to goal, we treat diabetes to the goals, we have better drugs for the treatment of diabetes, and reduction of atherosclerotic disease is there. So if I have to conclude and give some messages from what we have learned in these 4 decades, we have come a long way since the days of Mason-Jones, who did coronary angiography. The non-surgical treatment of angioplasty, which made a humble beginning, has started competing with CABG, in fact, has surpassed CABG. And bare metal stents have changed into drug-eluting stents. Drug-eluting stents are here to stay, and they're better than the absorbable stents. And the absorbable stents, in fact, have been sort of discarded. And refinements in understanding of biology and improvements in technology will continue. Calcified lesions are very easy to handle. Hemodynamic support is possible in very sick patients. And simultaneous improvement in the adjunct therapies will make coronary intervention even more safe and more competitive to bypass surgery. Thank you very much.
Thank you very much, Dr. Cole. It's a fantastic review and overview with much elegance and precision. Just remind that in 1950, in Montreal, Arthur Weinberg, a cardiac surgeon Canadian, did an anastomosis between the left internal mammary and directly onto the ventricles, left ventricle. It was a sort of start. Maybe you can add that to your conference. Thank you.
Thank you, Dr. Call. It's been very enlightening. And may I just read out the citation and for Dr. Plug and for Dr. Call, and this plug would be given by Dr. Busquet to Dr. Call. It states that Apvic 2025, Apvic 17, Professor M.N. Khanna oration for the year 2025 has been conferred on Dr. Upendra Kaul from New Delhi, India, for the topic From Coronary Angiography to Present-Day Coronary Interventions and Experience of 45 Years at the 17th Asia Pacific Vascular Interventional Course held at New Delhi, India from 11 to 13 July 2025 for his distinguished contribution to the field. Asia Pacific Vascular Society wishes him many more years of good health, academic excellence, dated this 12th day of December, 12th day of July 2025. So may I request Dr. Buske to hand it over and give it to Dr. Kaul. ये भाई साहब गलत है दिसंबर के साथ सब में यही किया होगा इसलिए मैं कहता हूँ जल्दी So after this oration, we move on to the next ceremony, which is the inauguration ceremony. It's indeed an honor to actually have invite Dr. Sanjeev Mishra as a chief guest. Just to introduce you, ladies and gentlemen, it is my distinct honor and heartfelt privilege to introduce our chief guest, Dr. Sanjeev Mishra, a visionary leader, renowned surgical oncologist, and a stalwart in Indian medical education. Dr. Mishra currently serves as the Vice Chancellor of Atal Bihari Vajpayee University, which is a medical university, and it oversees academic and institutional development of more than 700 affiliated medical, dental, nursing, and paramedical colleges in the state of Uttar Pradesh. He is an alumni of King George's Medical University, Lucknow, where he stood first in his class, earning the Hewitt Medal and also an astounding 18 gold and silver medals during his MBBS career. He completed his MCH in surgical oncology from the prestigious Xvii Memorial Institute of Oncology at Bangalore. On a personal note, I am especially honored today because Dr. Mishra was my cadaver senior at KGMC, a time when his clinical sharpness, humility, and natural leadership already stood out and inspired many of us juniors. That early respect has not only deepened over years as we have witnessed his extraordinary journey. Dr. Mishra has held several key leadership roles, most notably as founder, director, and CEO of All India Institute of Medical Sciences at Jodhpur, where he played a pivotal role in establishing it as a center of excellence. He's also held additional charges of AIMS Rishikesh, AIMS Gorakhpur, and Rajkot, guiding the development of multiple AIMS campuses across India. His academic and professional achievements are remarkable. He has more than 200 peer-reviewed publications and has contributed to more than 30 book chapters. And prestigious fellowships like FRCS from England and Glasgow, FACS, FAMS, FNA, that means Fellow of National Academy of Science, and DSC are some of the degrees and fellowship to his to these feathers in his cap. He has already held visiting and academic position at globally renowned institutions like King's College London, Mayo Clinic, Johns Hopkins University, and University of Pittsburgh. Today, as he graces the 17th Asia Pacific Vascular Interventional course with his presence, we not only welcome a highly accomplished academic administrator, but also someone of us who had admire deeply, both professionally and personally. Ladies and gentlemen, please join me in extending a warm welcome to our chief guest, Dr. Professor Sanjeev Mishra, Honorable Vice Chancellor of Atal Bihari Medical University. So we move on to welcoming Dr. Jacques Bousquet, who is our International Ambassador of Asia Pacific Vascular Society, to be the part of the inauguration ceremony. And we would start the ceremony with a video as a homage to our guru and well-wisher of our society, followed by the lamp lighting.
60 years ago, in the holy city of Kashi during 1957, a young man spoke in Sanskrit over 9 days, quoting from the Vedas, Upanishads, Puranas, and other scriptures. India's esteemed body of 500 Vedic scholars, Kashi Vidvat Parishad, was left spellbound. Amazed by his mastery of all scriptures, they honored him with several titles, including Bhakti Yoga Rasadhana, distinction of divine love and bliss. He appeared in 1922 on the auspicious night of Sharad Purnima in Bangalore, India. Aged just 34, he also received the title of Jagadguru Dharma. Jagadguru, 1000 Swami Shri Kripaluji Maharaj. Fulfilling his vision for philanthropy that changes lives and enriches rural communities. Karma Yoga is the constant attachment of the mind to God while engaging the physical body in worldly duty. But the one who attaches the mind to the world and physically practices devotion to God is the greatest fool. Thousands of underprivileged people are beneficiaries of needs-based charitable initiatives. Three fully charitable educational institutes give hope to approximately 4,000 female students. School bags, stationery, uniforms, and even seasonal clothing is all 100% free. His greatest gift to humankind, Prem Mandir and Bhakti Mandir, glorify divine love and devotion. Three fully charitable hospitals in Pratapgarh, Varsana, and Vrindavan serve approximately 1,600 patients daily. Voluntary professionals use modern facilities to serve everyone with compassion, respect, and love. At just 10 years of age, Govind received his life-saving heart surgery absolutely free in 2016. He now goes to school and lives a normal life. The essence of all philosophy is to lovingly attach the mind to God and increase the desire to serve Him. This alone is the ultimate knowledge. Reverential salutations to the great master who dedicated his entire life to the service of humanity and who blessed Asia Pacific Vascular Society and APVIC.
And now we request Dr. Anand Khanna to welcome the chief guest with a bouquet and shawl. And Dr. Jacques Bousquet from France.
So we move on and we request Dr. Professor Sanjeev Mishra and Dr. Bousquet for the lamp lighting to inaugurate, formally inaugurate this Congress. So, may I request you to have your seat? We also, once we have our chief guest here, we also want to acknowledge one of our very senior colleagues, a doctor from Punjab, who has done exceptional work in the field of cardiology and bringing thrombolysis to the reach of common man in the state of Punjab. So on the occasion of this 17th Asia Pacific Vascular Interventional Meeting, it's an immense pleasure and personal pride that I welcome a dear friend, an outstanding clinician, a leader in public innovation, Dr. Professor Bishop Mohan, who is the head of cardiology at the Hero DMC Heart Institute at Ludhiana. His remarkable work in conceptualizing and driving Mission Amrit, which is acute myocardial infarction reperfusion in time, has redefined emergency cardiac care in the state of Punjab with Mission Amrit now functioning across 72 government health facilities and over 14,000 chest pain cases are registered already, with 583 lives saved through timely thrombolytic therapy. This initiative stands as a beacon of what is possible when clinical excellence meets system level vision. What sets Dr. Mohan's work apart is not just the scale of the statistics, but the method, deep structured engagement, supportive handholding, and training of more than 700 healthcare professionals across the state. This is how true changes take place, not through momentary interventions, but through sustainable, replicable models of care. Having known Dr. Bishop over years, I can say with certainty that this humility matches his achievements. From early stages of Mission Amrit, supported by the Indian Council of Medical Research in 2 districts, its current expansion to 21 districts, his clarity of purpose has been unwavering. Today, as Punjab becomes the fourth state in India to implement such a vital public health initiative, we recognize not just a cardiologist or an academic person, but also the visionary change maker of the state of Punjab and our own colleague, and who embodies what modern medicine must strive towards: timely care, equity, and impact at the scale. Dr. Bishop Mohan, it is a genuine honor to welcome you today, not just as a fellow professional, but as someone I admire deeply. Your work inspires many of us in this room, and I'm personally delighted to celebrate your achievements with you and the entire Asia Pacific Vascular Society. Thank you for being here, and a thank you for the work you continue to do. So, Dr. Bishop Mohan, can I ask you to please come up to the stage? So here's a plug which we would want our chief guest and guest of honor to bestow it on to Dr. Bishop Mohan.
I think it's a great honor. Uh, I think the whole basic elementary thought of serving people and the cardiology, the theme, very thought of joining cardiology in All India Institute. When in interview, director sir asked me that what you want to do. So in '96, I told him that I'll go back to Punjab and start preventive and other services and emergency care. Everyone around felt amused because that was an era of intervention. So he said कि ये कैसा लड़का है जो उल्टा सोच रहा है. But anyway, the support of the Department of Cardiology, my fellow colleagues, and mentor, and the whole society, I would say, we were able to achieve this thing because thrombolysis is nothing basically, but I would say it's a truly life saving, and now involving the whole state of Punjab, and Punjab being the fourth in the country, it's a proud moment for all of us from the Punjab. And I really feel I appreciate all the efforts of my colleagues, fellows, and especially the government sector, because government people, they're overworked, I would say, and resources are less, but they're able to do that. Thank you very much everyone for helping me and supporting me. Thank you, Dr. Khanna, for giving me this kind of appreciation which I never accept. It's a very, very pleasant surprise. Thank you everyone. Thank you very much.
So Bishop, you have a seat on the dais. And I would now request our guest of honor, Dr. Jacques Bousquet from France, to give his thoughts. And then we'll request Dr. Sanjeev Mishra to actually release the coffee book for Asia Pacific Vascular Society, followed by his address.
It's a great honor to be within this exceptional panel. I have a profound respect to Dr. Khanna that I know since 15 years. It was a long way of fidelity and trust. He advised me, I advise him, we work together, and the result is you today, a good attendance with the old guard in the front, and the young people in the back, and one day you will be in front, because you learn a lot with Dr. Khanna. He's a very well-known worldwide. He's well-known in the East Country, is well-known in the British country, is well-known in America, is well-known in Morocco, for instance. So I leave tonight, but I bring back to Paris a strong memory of all of you and the homage that you just gave me. And we just prepare next year meeting, and we will reserve some good surprise and good novelties that will be brought to you. Thank you very much.
So let me request Professor Sanjeev Mishra and Dr. Buske to release our coffee book for this year. Dr. Sanjeev, please. Can I get the copy? May I request Professor Sandeep Mishra, our chief guest, to give his thoughts and the guest lecture.
Good afternoon, everyone. Professor N. Khanna, Professor Buske, all the distinguished faculty and delegates attending the Asia Pacific Vascular Intervention course. It's a matter of honor and privilege to be here. I'm not a cardiologist, I'm not a cardiac surgeon. When we joined the medical school, we all dreamt to be a cardiac surgeon. But I think down the line, we thought that cardiology, cardiac surgery, it's more taxing, so we took the soft path. Became a surgical oncologist, where you don't have to deal with much of emergency work, much of work which is so taxing that when you reach your hospital, you don't know whether what time you're going to reach home, you're going to reach home at all that or not. When Dr. Khanna asked me to be coming for this meeting, I said, I'll be the very odd person out there. He says, no, we want somebody who's odd. I said, fine. So I'm here. And the beginning, I must thank Dr. Khanna. Is a remarkable person. I've known him from his undergrad days, as he mentioned. His brother was a year senior to me, and he was a year junior to me in the medical school. And he's an exceptional person who's an excellent doctor, excellent cardiologist, intervention work and also gets time to do so many other things. He's involved in philanthropic work. Every month he goes to Pratapgarh, to this hospital there where he does voluntary work there. So I think doing these multiple things requires a lot of time and effort. I must congratulate you, Naren, for taking out time for everything. Just not being in the mad rush of things in a big city like Delhi, where one just gets carried away and doesn't get time for other things. I was sitting and listening to the presentation that I heard Professor Call heard the other people, speakers, especially those rare case challenges. I remember the times we were studying in our school, we had said that when you get the chapter in Bailey and Love on vascular problems, that you don't have vascular problem in India. This is a thing of the Western world. So we used to land up skipping that कि इसमें से तो कोई पूछेगा नहीं, इसको कम पढ़ो, and it was there. But over time you realize that yes, they are so common, and people dedicated and involved with treating vascular problems are still few as far as our country goes. The size of it, the population. The coronary work always takes a precedence over the other vascular work, but I think that's equally important. And during our medical school days and afterwards, as I said about that vascular work, there, I think among general doctors, it's important to emphasize and make them sensitive and sensitize them about, especially creating an awareness about vascular disorders, that yes, it's a thing for our country also, and there are solutions available. And it's not only the big cities. Slowly with time, I think it will also get down to smaller cities. So I think an awareness is important when we talk of vascular work. More centers are needed. So when we talk of more centers, we need to have more trained people and people who are dedicated for vascular work. And I'm sure this sort of meetings do inspire youngsters, a lot of them to take up the specialty. And people like you who are the faculty or the torchbearers will definitely be an inspiration for a lot of youngsters getting into the vascular work. They're very complex procedures, they're expensive, the stents are expensive, but I think with time, cost of things will come down. And somewhere, as Professor Kaul, we heard in his that about the Indian-made stents, which was there when the trial was equivalent to the Western. The government did put a capping also on the stents. That has made a difference on things. The Ayushman Bharat program came from the government, which has made a lot of healthcare affordable. Always issues remain about the cost and the reimbursements, which is there, that it should be more. But yes, it's a beginning which has been there. I'm sure that refinements can always be done in that. And it's one thing more very important. I think that's one thing is a proper referral. I think what we lack in our country is a proper referral from a primary to a secondary to a tertiary care. I think that's something which we have to work so that if someone has a problem, he reaches to the right place at the right time so that a particular intervention or a procedure and advice can be given. I think that's something which is very, very important, and that's something which is in the public health domain that we have to look at it, whether it's a government setup we are working or a private setup. I think creating awareness for a proper referral is extremely important. And when you refer, you never lose a patient, you gain a patient, because whenever he or she gets treatment, they come back to you. I think that's important. And I'm sure that with the proceedings of this meeting and the fantastic talks, if I had a choice to go back, I would go back and start learning vascular surgery. But I think it's too late, I feel. But I'm sure the younger generation will definitely gain from the experts here, their expertise, and definitely will take up this branch and this area where more and more people are involved in it and make a difference to all of it. Again, I thank Dr. Khanna for inviting me. It's really been a privilege and honor to be here, and really honored to be the chief guest for this conference, to inaugurate the conference. And
Thank you all very much. Now we come to the end of the inauguration ceremony. We move on to the next session. Can I have the announcement for the panelists to come up to the stage?
The topic for this session is panel discussion. The expert panelists for this session are Jas Bose, N.N. Khanna, Nitish Naik, Dilip D. Shah, Yash Gulati, Tapish Sahu, Surbhi M. Patreta, Raju Vaishya, and T. N. Range. The topic for this session is panel discussion. The expert panelists for this session are Jas Bose, N.N. Khanna, Nitish Naik, Dilip D. Shah, Yash Gulati, Tapish Sahu, Surbhi M. Patreta, Raju Vaishya, and T. N. Range.
No problem. So we have a very eminent panel here. Dr. Jacques Bousquet from France. Dr. Nitish Nayak, has he come? He's on the way. He's from All India Institute of Medical Sciences. Dr. Dilip Shah, who's a very accomplished orthopedic surgeon from Mumbai. Dr. Yash Gulati, who would be joining us online. He had an emergency surgery from Apollo. He's an orthopedic surgeon. Dr. Tapish Sahu, who's a vascular surgeon and also the secretary of the Vascular Society. Dr. Surabhi M. Athreja, who is an interventional cardiologist from United States of America, Dr. Raju Vaishya, who would be joining this panel discussion. Now, if you look at the problem of the lower limb peripheral arterial disease, there are a lot of overlaps. We are going to be discussing about it, but there is also a lot of overlap between the symptoms. And many a times we get into a problem where the patient has pain in the legs. We have difficulty in sort of recognizing whether it's a vasculogenic claudication or a neurogenic claudication. And it's often a physician's dilemma. And that is why we have kept this panel discussion for the youngsters to actually understand the role and how to diagnose patients with this sort of an overlapping symptoms. Also, what is very important, in a lot of patients in India now have TKRs and total hip replacements also. And many a times they end up with, a deep vein thrombosis, pulmonary embolism. What are the recommendations? There seems to be no consensus between, the different orthopedic surgeons, whether to go for anticoagulation, which drug to use, when to use, and for how long to use. So these are the two topics we are going to be discussing. At the start, I must thank Integrace for its continued, support to this sort of activity. It is, and they have been very, patiently and with a lot of effort. They've been, advocating and helping education for peripheral vascular disease, its diagnosis, its treatment, and they were also helpful in disseminating the knowledge about and understanding the Indian consensus statement for managing lower limb arterial disease. So Integrace has actually done a lot of work and helped us out to, propagate the consensus statement for lower limb arterial disease. We actually came out with this consensus because there was no guidelines or statement available in Indian context for last almost 5 decades. And this is the only document which people refer to for authentic published document which people refer to for managing lower limb arterial disease. We have also had a lot of master classes across the country, again with the help of Integrace, where physicians have actually gathered into a program where we have experts from Delhi and we have local experts from each state. And for many weeks, we have actually trained them and made them understand this consensus statement. Now, this consensus statement was jointly drafted, and it took about 6 months of intensive brainstorming to get to this level. We had a combination of cardiologists who specialize into vascular interventions, cardiac surgeons, vascular surgeons, endocrinologists, podiatrists, and also some AI experts who contributed to this, and the lipid experts. So these were the people, myself, Dr. Vinay Krishnan, who is also here. He was the director of one of the biggest institutes of cardiology at LPS Institute of Cardiology at Kanpur, which has, I think, the third largest program of interventional cardiology and cardiac care in India. Dr. C.N. Manjunath, then director of the Jayadeva Institute of Medical Sciences, which is the biggest center for cardiovascular intervention. Professor Sanjay Tyagi from GB Pant Hospital, Dr. Raval Jindal, vascular surgeon from Chandigarh, Dr. Manoj Chadha, endocrinologist from Mumbai, Dr. B.H. Natesh, who is here from Jayadeva Institute of Cardiology, Dr. Girish Varavadikar, accomplished interventional radiologist from Mumbai, Dr. Wangnu, who is a very eminent endocrinologist from New Delhi, Dr. H.K. Chopra, the previous president of Cardiological Society of India, Dr. Priya Jagia, who's a professor and head who attended the meeting yesterday from All India Institute of Medical Sciences. She heads the Department of Radiology. Dr. Rajiv Bagarata, who was then the director professor of SMS Medical College in Jaipur. Dr. APS Suri, who's a AI expert. Dr. Asokan, who is also here, the Vice President of the Cardiological Society of India, Dr. Rajesh Vijayvargiya from PGI Chandigarh, Dr. Raman Puri, who's been the President of the Lipid Association of India, Dr. P.C. Gupta, vascular surgeon from Hyderabad, Dr. Vimal Mehta, Professor of Cardiology at GB Pant Hospital. So with this sort of panel, we actually wrote this consensus statement, and all what we are discussing is a part of the same consensus statement. Now, today for the panel discussion, I have Professor Jacques Bosquet from France. He's a co-founder of International Society of Endovascular Specialists. He's a big name in the field of vascular surgery internationally. We also have Dr. D.D. Shah, who is an honorary orthopedic surgeon at Saifi Hospital and Nanavati Hospital, and Elizabeth and Kambala Hill Hospitals, all famous big hospitals at Mumbai. We have Dr. Yash Gulati joining from Apollo Hospital, New Delhi, and Professor Nitish Nayak, who is an interventional cardiologist and also the editor of the Journal of Cardiological Society of India. So let's start with the first problem, differentiating vascular pain from neuropathic pain. The way we are going to do is I'm going to be giving you a little concept, and then we'll go ahead with the audience interaction and questions and answers to understand this properly. But please be careful about time so that we finish in time. We are almost 25 minutes late, and we have to catch up with time during the lunch. So what is the importance of differentiating pain types? So it's very important to ensure whether the patient has a neurogenic pain or a claudication or a vasculogenic pain, because the approach for both these patients are very different. It also affects the prognosis of the patient and long-term outcomes of the patient, and that is why it's very important. So a closer look at the risk factors for vasculogenic claudication. You have common risk factors like hypertension, diabetes, dyslipidemia. What is very particular and specific for the Indian population is the age. So more you age, you have an inherent risk of developing peripheral vascular disease. Also, homocysteine levels, their levels are usually more genetically in Indians, and that's a risk factor for recurrent thrombosis, use of tobacco. These are all the shared risk factors which we also have in coronary artery disease. Also, presence of diabetic neuropathy is also a very important risk factor for these patients. And also we have entrapment neuropathy. So often these three things are common: the vascular problem and the neurogenic problem. The neurogenic issue can come from root compression or can also come from the neuropathy, and they would present almost in a similar fashion. Now, we will be discussing about the definition of vascular pain, causes in diabetic patients, and what are the symptoms and what are the symptoms of neurogenic pain. But in general, if you see in vascular pain, the vascular claudication typically affects muscles in the calf, thigh, and buttocks. So, and it's one level below. So if you have a block in the iliac vessel, you will have a buttock claudication. If you have a block in the superficial femoral artery, you will have pain in the calf. And if you have blocks in the below knee vessels, you will have claudication in the foot. While a neurogenic pain is a stabbing, radiating nerve sort of pain around the buttocks and the lower limb. And the vascular pain is actually relieved by stress, while the neuropathic pain may improve with movement and specific positions, especially if you have radiculopathy. So if you look at the patient, if you have reduced pulses, you have more chances of having vascular claudication. And if you have positive straight leg glazing test, then you have more chances of having neurogenic claudication. What sort of differentiates is the MRI and CT scans, electromyography, and ankle brachial index. So it's not that if somebody has peripheral arterial disease, the claudication has to come from vascular cause, and vice versa is also not true. So that is why it's important to actually understand what is the cause of the symptoms. So again, we go with comprehensive history taking, physical examination, and diagnostic testing. We look at the symptom overlap and try to understand what is the cause of the symptoms and whether one or both causes are present in these situations. So solutions and mitigation strategies are integrated diagnostic approach, use of ABI and EMG, and multidisciplinary care for accurate diagnosis. And with this sort of a background, I'll directly go on to the questions for our panel. And I would want to be brief answers and specific answers, and the audience can also pitch in with their questions. So the first question is, what are the key clinical features that help distinguish between vasculogenic and neurogenic pain in lower extremities during patient evaluations? I'll put this question to Dr. Shah, who is a orthopedic surgeon, a very renowned surgeon from Mumbai.
Thank you very much. Without wasting much time, I'll start answering quickly, but I must compliment there are so many young people. So I'll go to the idea that if you want to evaluate, vasculogenic pain is because of intermittent claudication. Pain occurs during walking or exercise and is relieved by rest. Pain location is also very important, typically affects the calf, thigh, and buttock muscles. Pain characteristics is cramping, aching, and heavy feeling. Worsening factors are exertion, walking uphill, or increased physical activity, and relieving factors are rest or if they stand still. Physical examination, there is decreased or absent pulses, cool sign, hair loss, and trophic changes. Whereas in neurogenic pain, it is a radicular pain in the nerves sciatic distribution. Pain characteristic is very sharp, shooting, burning, or electric shock-like pain. Versions by certain positions, coughing, laughing, or maybe straining for those who are constipated. Relieving factors are rest, position change, and physical examination. You have decreased sensation or EHL, EDL weakness, or maybe ankle jerks are lost. So these are the key distinguishing factors. And pain pattern, vasculogenic pain typically follows a more diffuse and muscle-related pattern, while neurogenic pain follows a specific nerve or dermatome distribution. Triggering factors are vasculogenic pain is often triggered by exertion, and relieving factors are vasculogenic by rest and neurogenic by change of position. As you say that, I try to be very brief and to the point, so you can go ahead with the next question.
So let me put the next one to Dr. Tapish, who is now the Secretary of Vascular Society of India. How reliable are symptom-based algorithms for differentiating between two types of pain or claudication, especially when both may coexist? It's not uncommon to have both etiologies together.
Great, sir. So essentially, this is a problem with diabetics, not with smokers mainly, because we are dealing with two things here: a central cause, like in the spine, a peripheral cause, which is the peripheral neuropathy, and a vascular cause, which is actually the vasculopathy, neuropathy may coexist. And in these patients, actually, the tests are also not very reliable because of the vessel calcification. The ABI may be dubiously abnormal, not essentially low as you may expect. So if you, the basic thing as you had contemplated in your algorithm, that it has to be a good history taking. You have to start from whether you're differentiating a claudication or a rest pain. Rest pain, typically neuropathy and ischemic pain, the onset has to be seen along with the clinical features, whether it's a year-long pain, gradually progressive, or it has just started, along with certain features of, if there is a wound, no problem. You can say that there is a wound, there is a gangrene with this pain, that is definitely having ischemic component. But when there is no wound and the patient is saying constant burning, maximum procedures that we see today are actually, the ABI is less, you have no pulse, you do a procedure, but the pain is not relieved because it was neurogenic. So it's not actually that reliable, but a good history, a good clinical examination. And one more thing I would recommend is doing a good Doppler yourself to see for the flows is very essential to clinch the diagnosis, whether this patient will be relieved by vascular causes or you have to give some neurogenic medications for that.
So another question to you, how do you counsel patients regarding the prognosis and expected outcomes? when both pain etiologies are present?
Yeah. So most of the times when we are working these patients, when we are taking the history, that the claudication starts as soon as he starts to walk, or when he's generally in the femoral or the below knee segments, we tend not to operate initially. The dictum is let them want the procedure. Iliac and aortas we definitely offer, but then the level of claudication where it's happening, as sir was saying, that it's one level below the level of occlusion. So the dilemma is in the rest pain category, where peripheral neuropathy, generally patient says numbness, tingling, some paresthesias along with that. So we counsel them that this will not go. We are trying to save your foot. If we are doing some vascular procedures, this is not going to relieve your diabetes related, uncontrolled diabetes related problems. So you have to control your sugars, you have to be on certain neurogenic medicines. Further on also, this is not one stop solution. This is just to save your limb and to relieve that component of pain which is vasculogenic. That has to be explained upfront, otherwise the expectation is completely different, that I'll start to run as soon as this procedure is done. So proper counseling before the procedure is very important in these cases.
So now let me ask Dr. Surubi, how do you prioritize treatment when both vasculogenic and neurogenic sources are identified in the same patient? And what's the practice in United States of America?
So that's very important question, in a sense that if you do, even if when you go the imaging route, most of the patients at elderly age do have some degree of neurogenic component on MRI or CT. So it's not really one test you would point your finger on, okay, you have these nerves compressed, so definitely you have neurogenic pain or a vasculogenic pain. However, we try to focus that patient understands that for vasculogenic pain, if it is only coming from exercise induced ischemia or it's critical limb ischemia. So if it is exercise induced ischemia, exercise therapy can increase the claudication distance. But if it's critical limb ischemia, and then it depends on the level of the blockage, that if at all you are offering a therapy for AX or SFA, that makes sense. Lower below the knee, restenosis rate is very high. So, you counsel the patient accordingly that it is only for ulcer recovery. Neurogenic pain has a correlation in that, because in diabetes, both etiologies are present. So we also counsel the patient for obviously better diabetes control and to protect the foot as best as possible. So hyperbaric chambers, foot care, and working very closely with endocrinology is the key.
Okay, so question to Dr. Buske. Again, how do you counsel your patients if they have both etiologies or, overlapping etiologies, especially in your clinic in France? How do you counsel your patients regarding prognosis and expected outcomes?
There is a difference between etiology, between the ischemic pain that the patient is affected of, that's the Fontaine stage 2 and 3, because stage 4 it's the ulcer and gangrene. So you must consider that some risk factor like alcohol give alcoholic polynephritis. And you can have both of them, because alcoholic patients are often smokers. Smokers got a spasm, distal spasm in the artery, but they got also polynephritis. So you must consider your patient possibly to have both pathology. For me, the first thing to do is to explore the arteries. This is the first thing to do. echo Doppler scan, CT scan, or arteriography, especially to consider the distal bed, the distal runoff on the legs, on the calf, on the feet. I don't know if you consider the possibility in India to do a sympathectomy, a lumbar sympathectomy. Some of us, maybe more traditional than the youngest, tend to do a sympathectomy, lumbar sympathectomy when needed. It can open the runoff of the distal bed, especially when you do a distal bypass. This morning, we've seen that some people do arteriovenous fistula to increase the pressure of circulation. Sympathectomy could be sometime a good answer to that sort of distal arteriopathy. Polyneurosis is neurologic pain. It's something different. It's more chronic. It's come in second, and for sure you have to your disposition the painkiller, but be careful to addiction. But you must stop smoking. This is the most important, even in neurogenic pain. And electromyography for sure. And if the patient accepts and his family, rehabilitation, kinesiotherapy, walking, but not going fast because fast is impossible, and change your habitus of life.
Thank you, Dr. Buske. So let me move on to the second aspect, role of anticoagulant therapy in pre and post replacement surgeries in orthopedic practice, new versus time-tested approaches. So this will be a very practical discussion. And again, we have the same panel. Has Dr. Nitish joined us? So let's talk about VTE prevention after arthroplasty. We have talked about the arterial component. So when it's very important that while we are doing knee surgeries or replacements or hip surgeries and replacements, VTE is a common complication. That means venous thromboembolic embolism, which could be DVT or DVT leading to pulmonary embolism. And many times, not once or twice, I've come across, different orthopedic surgeons, patients being referred to us for acute pulmonary embolism. And many of these times, these patients were not on anticoagulant therapy and probably were not even investigated or had a Doppler prior to surgery for venous, thrombus or a risk for thrombotic component. Now, there are different early methods for DVT prevention in such patients. Most of the surgeons would give compression stockings and also intermittent pneumatic compressions. These are widely used standard of care for DVT prophylaxis after surgery or even in patients who are admitted with prolonged immobilization. The use of anticoagulants like heparin or vitamin K antagonist or NOACs have become a standard of practice despite their limitations in administering and monitoring. And the NOACs, anticoagulants have actually come in a big way because here we don't have to actually worry about drug interaction or drug food interaction. And also we don't have to worry and monitor the PTs and INRs and maintain an optimal level. And the therapeutic window is not that narrow in these use of NOACs. Now, again, if you look at it, the DVT in patients who are going total knee replacements is to the tune of 0.5 to 4%, and in symptomatic patients, while in asymptomatic patients, it may range from 20 to 40%. So there is a very important need of giving this anticoagulant therapy to these patients. And again, as most of the surgeons do, they want to mobilize the patient as early as possible. That has become a standard of care, but comorbidities, surgical risk factors, coagulant, hypercoagulable states, these are some things, and maybe occult malignancy. These are some situations where this is missed out, and the patients come with DVT and pulmonary embolism. Now let's talk about the specific approach in anticoagulant therapy. We have parenteral administration of heparin. We also have, but here again, there is unpredictable plasma level, and the patients have poor compliance in this treatment. From that, we moved to low molecular weight heparin, and then moved on to vitamin K antagonist, and then moved to factor A inhibitors, which are direct acting oral anticoagulants. So we have three which are available in the country: the apixaban, rivaroxaban, and dabigatran. And there are a lot of studies with rivaroxaban and some with apixaban in actually controlling and preventing these DVTs and VTEs. It has a definite advantage, which I told you. It doesn't require monitoring. It is easy to give, and there are no drug-drug or drug-diet interactions. So I'm not going to go to the details of the studies, but this is what it is. Dr. Shah probably may be talking about it, or Dr. Gulati. But as I told you, different studies have actually quoted a very high incidence. And in TKR patients, in symptomatic patients, it could be to the tune of 2.5 to 4%. In asymptomatic patients, it could be to the tune of 20 to 40%. Now, if you look at the safety profile of NOACs and rivaroxaban, if you look at the bleeding incidences, there's no increased incidence of bleeding where in patients with rivaroxaban as compared to low molecular weight heparin, especially the enoxaparin. So there is higher bleeding risk from not, from comparing to the patients who did not receive any anticoagulants. But when you compare the bleeding risk of enoxaparin versus NOACs, there is no statistical difference in the bleeding risk. The wound infection rates also remain unaffected, and overall safety outcomes with rivaroxaban are quite good. It is safer than traditional anticoagulant therapy in the context of DVT prophylaxis. So it effectively reduces the incidence of DVT. Oral administration is important, and the compliance is much better than frequent injections which are taken if you give heparin therapy. It is a convenient form of therapy. You have consistent plasma levels with rivaroxaban, and it has minimal bleeding risk. And it is being adapted by more and more orthopedic surgeons and neurosurgeons for their patients. Patient education and adherence is an important issue, and cost effectiveness also is an important issue. And for effective DVT prevention, if you can do that, you can reduce the mortality and mortality and enhance the overall quality of life. Long-term safety studies are available. Comparative studies are also available. And a lot of people have their own experience with the use of these medicines in their own patients and in their clinical practice. So with this background, let me start with the question directly to Dr. Gulati, if he is online. Is Dr. Gulati online? Okay, so let me move.
Hello?
Yes, Dr. Gulati, welcome. We can see you.
Hello?
We can see you on the stage. We can also
Yeah.
hear you. Sorry, you had to do an emergency surgery,
Yeah.
so we are not going to delay you much. But with this,
Well, I'm still, the patient is on table because this whole schedule has got, twisted. Anyway.
okay,
Yeah,
so
please tell me how can I contribute?
okay, so let me start with a question to you. Based on the current evidence, how does rivaroxaban compare with traditional agents like low molecular weight heparin, especially enoxaparin, in reducing the incidence of VTE and DVT in your patients, especially after TKR and...
As a matter of fact, yeah. As a matter of fact, there is no evidence right now to say whether either of them should be used in orthopedic practice. It's all very controversial. In fact, there are so many problems associated with anticoagulant therapy that there are many people who strongly advocate not to give any chemoprophylaxis at all, or give at the most just ecosprin or aspirin tablet. And there is no evidence that this is any way inferior to all other chemoprophylaxis. If we are following the other dictums that you just mentioned in your speech, that early mobilization, compression stockings, not compression pump. In fact, I don't even use compression stockings because sometimes they roll down and they cause pressures. So I've not used compression stockings for years now. So we use compression pump and at the most aspirin, except those cases which are high risk patients, like previous history of embolism or previous history of thrombosis, or very fat patients or heavy smokers or severe diabetics. So otherwise we use only aspirin, and early mobilization, compression pump, and I don't use tourniquet. So all these combined, I think in today's day there is enough evidence to say that nothing more is required.
Okay, so we have another accomplished orthopedic surgeon in the panel here, Dr. Shah from DD Shah from Mumbai. What are your comments on this, Professor Shah?
There are two things to be seen. Unless you have a very serious complication and if somebody dies, then you realize the importance of giving anticoagulants. And I have burnt my fingers, and that's why I am quite cautious about it. So pre-operatively, I get the study of ultrasonography to make sure that this patient has a problem or not a problem. He's vulnerable for VTE. Besides, D-dimer studies are also very essential. And as we talked about your first question, that compare between the old-timer anticoagulants to the newer ones. The old-timer also worked very well, but only problem is when you give them, there is no specificity. On the contrary, when you give oral rivaroxaban, it works very well. There is a little extra tendency towards bleeding, and that bleeding cannot be combated by protamine sulfate, but you have to give vitamin K. And there is one specific anti-XSA, that agent you can give. But definitely, you should use anticoagulants in the patients who are more vulnerable, or you feel that they will undergo some kind of VTE, or they had previous episodes like Dr. Gulati said that they had some kind of thromboembolism or VTE, or maybe they are likely to have a problem later on. Rather than to be sorry, it's better to do prophylaxis. And of course, the pneumatic calf compression is very important, and early mobilization, so that you can eliminate either giving anticoagulants, or if at all you have to give for a shorter period. Thank you.
Dr. Surubi, may I ask you what is the practice in United States? Because this is a very controversial subject. I'm sure you must be seeing patients there too who end up with VTE and many a times fatal or a very massive or submassive pulmonary embolism, only to be sort of concerned that had the prophylaxis been given, the patient wouldn't have ended up with this sort of an emergency. And at the other part, many of the orthopedic surgeons do say that if you give oral anticoagulants or enoxaparin, they have a lot of bleeding, especially at the wound site, and they really hate bleeding in the operated site. So we have to strike a balance. I don't know how to strike a balance because we are at the receiving end. When the patient gets into a problem, that is when we are called for. But what is the practice in United States?
So this is a very controversial topic per se, because there are like lots of meta-analysis done on this subject and a paper in an EGM as well that has, initially it was aspirin only, and then rivaroxaban came in, and then meta-analysis came in, where efficacy of aspirin is close to, other DOACs, given the rate is very low. But then when you talk about an individual patient who has, let's say, prior DVT, as the panel is alluding, that if you have a high-risk patient in front of you, but now the question comes that high-risk patient, how do you define? I mean, if you're doing routinely ultrasound and you're finding a, chronic VTE, that's a different issue altogether. But all these patients are not going for routine ultrasounds, so then you have to come up with like an algorithm in your mind which is not standardized, right? Which includes the get up and go score, that patient, how far the patient can go. So initial baseline mobility, how bad or good it is, that patient would be post surgery would be at risk of immobilization or not. That plays an important role, that get up and go kind of test. And then all the other features you guys alluded to, that history of malignancy or history of lupus or history of any background history which could be more thrombogenic. But there is no clear-cut consensus on this topic, unfortunately, and you have to individualize the risk based on one particular patient.
Tapish, I mean, you work in a different part of the city and also a different side, we are interventional cardiologists who get into, who are called into situations where there is a problem. You being a vascular surgeon probably work more closely with orthopedic surgeon.
So there are two aspects I'd like to highlight here: antiplatelet, anticoagulant, prophylaxis, treatment. So antiplatelet drugs, well, JBJS has a good paper saying that, okay, this is the thing. But there is one more aspect that we are missing, is the medico-legal aspect. I would like to quote here. There is a orthopedic surgeon being a case is going in the court after TKR. The patient had a massive PE. The patient survived, but the case is still going on because there is a documented evidence of a prophylaxis that has to be given. Now you can't skip that. As Dilip sir was saying, it just takes one case to burn your hands, and then you kind of, you've been doing it. Great. But 52% is the reported incidence with a THR. That is the reported incidence without any prophylaxis. Well, we're adding, we're reducing by pneumatic compression or antiplatelet, we're reducing the incidence. But a MARI would be a prophylactic dose, not a full therapeutic dose. For some time, well, wound related complications are there. But what I'm trying to say is, if the patient has a clear cut history, he falls in the high risk category, Wells criteria, obesity, previous history of DVT, PTS, there is no question that has to be given. But a walking patient, they are all of old age. If there is a replacement being done, mostly patients will be geriatric age group. Well, they will be less mobile, and rather than taking a risk, after some time, wherever you feel that hemostasis has been achieved, it's always advisable in the prophylactic dose, not the therapeutic dose. A prophylactic dose is the way to go forward as per the current guidelines, what I would suggest.
I would sort of agree, and it reminds me the medical legal aspect. About few years back, a patient was referred to me. She was a pediatrician from Australia, came to India, had her knee surgery, and prophylaxis was not given, developed P, DVTP. By the time she came to us, she died. Apparently, her father was a lawyer, and he sued a very famous orthopedic surgeon in the city, and he's having a hard time defending himself. So these things do create a lot of issues if things go wrong. But on the other side, yes, if you have a lot of hematoma at the surgery site, that again creates a lot of issue and post-op infections and mobility issues. So there has to be a balance. Nobody knows the answer, but in terms of defensive medicine also, I think it has an important role that at an appropriate time, as you said, maybe when the risk of bleeding has come down in the joint, it's better to give prophylaxis because the risk actually remains for a few days or few weeks after surgery, even if you have a mobile patient.
It's not just mobility, it is the vein trauma that's happening.
Absolutely.
Because of the position intra-op, which causes the endothelial damage, and that will take some time to recover. It's not just the ambulation, it's not just stasis. Varco's triad is also talking about endothelial injury. So
True.
It's better to cover that.
And endothelial injury triggers the VTE, and that's why, once burned, twice spiteful. And
yeah, and we've seen a lot of patients do have May Thurners, we don't know. This becomes a provoking factor for DVT. And then you have DVT, especially on the left side, and you worry, why did it happen? And it happened because the patient had a Maytherner. And Maytherner is not uncommon in India or maybe all over the world. You just have to look for it. So finally, we'll close with Dr. Busquets' comment, and maybe we have a very senior vascular surgeon in the audience, Dr. Komudrai. Maybe let's have his opinion on whether to give
I agree
anticoagulant
with
prophylaxis,
I agree.
rivaroxaban prophylaxis.
I do agree with you all, especially you, Dr. Khanna. When you are a vascular surgeon or an interventionist, you have to see the patient as they are in terms of risk. For instance, when I do some vein surgery, varicose vein surgery, if my patient is a woman, if she's obese, if she smokes, if she take contraceptive pills, and if she got any kind of history of cancer, breast or uterus, as you can discover, you must be very careful. This person could be thrombogenic, and then you have to be preventive. No, not therapeutic, but you must be preventive. So identify the patient immediately by the way you speak with him. You analyze his body and so on. So have a look to your patients. It's what I recommend.
Thank you very much, and may I have the comments of Dr. Komudroy.
Well, thank you so very much. We are fortunate at Max that this now standard protocol, it is mandatory for all hip and knee replacements to give pharmacological prophylaxis. We leave it to a certain degree to the doctor concerned, as we have agreed. We don't want them to have any intraoperative hematomas and the things like that. So typically what they do is when the patient is admitted the previous day, one shot of Clexane is given. That gives them enough time, more than 12 hours, for a spinal anesthetic to be given. The anesthetist is comfortable. Similarly, once they are back home in the ward, sorry, not home, either the same evening or the next morning it is started. We can still justify that. But it is 100% compliance. And I think we are very fortunate that we have seen a case in Max for many years now. We have seen for other reasons, but my recommendation would be it's not too bad. And if you can't do that much, at least use venous pumps intraoperatively and postoperatively. That should be the bare minimum that should be done for these patients. Thank you.
Thank you very much. And I would want to close the session now. We had many more questions, but I'm really sorry to have kept you waiting for the lunch. What we are about 25 minutes late. What we are going to do is we are going to break out for lunch, and maybe after 15 minutes, people can still have lunch. We'll have a rolling lunch, and we'll come back and start the next session so that we have time to catch up and we finish in time, because we have the dinner in the night and we need to vacate this hall by 8:30.
Hi, Tavish. Good to see you. Thank you for the comment. And certain things can't be personalized. And that's the highest level of evidence.
Hello, check, test. Check. Shankanath. Check, check. Hey, test, mic test. One, one, two. Hello,
Hello.
test. Hello, hello, hello.
Hello. Hello. Hello. Hello. Hello.
Take, take. Hey, hello, hello, hello. Hello, check, test. Hey, mic check, test. Hey, check. Hello, check, test. Hey, hey, hello, check, 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 test. Hello. Hello, check.
Announcement ready.
For this session is ACE techniques and reviews by experts. Sixth best ACE competition semi-final. The expert panelists for this session are Vijay Rehan, Rakesh Yadav, Vishal Mohan, N.M. Khanna, V. Hariharan, V.T. Gupta, Neeraj Chaturvedi, and Lokesh Emma. The topic for this session is ACE techniques and reviews by experts, 6 best ACE competition semi-final. The expert panelists for this session are Vijay Trehan, Rakesh Yadav, Vishal Mohan, N.N. Khanna, V. Hariharan, Preeti Gupta, Neeraj Chaturvedi, and Lokesh Emma. The topic for this session is ACE techniques and reviews by experts, 6 best ACE competition semi-final. The expert panelists for this session are Vijay Trehan, Rakesh Yadav, Vishal Mohan, N.N. Khanna, P. Hariharan, Preeti Gupta, Neeraj Chaturvedi, and Yogesh Emma. May we now request Dr. Sharif Sultan to come on stage and deliver their presentation.
I'm Dr. Busquet, and I will share the station by myself. I share it with myself. And you, I replace somebody, they are just eating. And as you know, obesity is a risk factor. So better to be vegetarian or stop eating at noon, like you. So it's femoral, popliteal, below the knee vessel, case technique and review by expert. It's a sort of competition, semi-final. I will be alone to judge. So can we give Sherry Sultan a presentation, please? Oh, you sleep? So you give Sheriff Sultan, please. So we go to the second one, the Basis Panda. Are you the Basis Panda? So external iliac perforation. You have 10 minutes. No, you have 6 minutes. And please keep on time, because when I was out, the panel took a lot of delay. So I'm not happy of that. We have 1 hour delay. So keep on time.
EU of inversions in precaudal lists suggestive of ischemia, and 2D echo revealed anterval hypokinesia with severe moderate LV systolic dysfunction with ejection fraction around 35%. So considering his ECG and echo and left lower limb status, we both planned for CT angiography and also coronary angiography. So this is the coronary angiography. We can see a mid LED lesion, and we have L6 and RC was fine. So DES of 3.5 into 28 mm was put in mid LED. So here in the city, we can see the complete cutoff of left external iliac artery. It was a long segment lesion, and the reference vessel diameter was around 8. And right side, there was around 50 to 60% stenosis. So interdisciplinary heart team discussion was taken. Initially, the patient was given the choice of iliobifemoral bypass, but due to severe LV systolic dysfunction, the surgical team denied for bypass, so planned for left external iliac artery stenting. So here, access was taken through right femoral artery, and we can see the complete occlusion of left external iliac artery. So the lesion we have crossed with 0.035 terimo here, and we have dilated with 6 into 100 peripheral balloon. So after this, we are not satisfied with the post-dilatation lesion of the 6 into 100 balloon. So we have again upgraded to 1:1. That is, we have dilated with 8 is to 40 peripheral balloon. This dilatation, we can see some residual. We are not sure what is the residual lesion, whether dissection or thrombus. Actually, we did not have peripheral imaging that could have helped in that time. What is the lesion? But in benefit of doubt, 8 into 100 self-expanding stent was deployed in left external iliac artery, and we have post-dilated with 8 into 40 balloon. But immediately after post-dilatation, we can see external iliac artery perforation just at the origin. And then the patient suddenly went into hypotension, started on fluids and inotrope support, and we have done balloon tamponade. It was done to prevent further extravasation. And we have put a covered stent of 10 into 100 fluency vascular graft across the perforation. So the lesson was again post-dilated with 10 into 40 peripheral balloon, and we can see in the final DSA there is sealed perforation. The patient is doing well after 3 months follow-up, and there is good distal collaterals and good distal flow. So coming to take-home messages, vessel perforation is always a serious complication, particularly large vessel perforation during peripheral angioplasty, and vessels which a lot of calcification, tortuosity, angulation, they are more prone to such complications. So liberal pre-dilatation is recommended in such cases. Yeah, there is definitely role of intravascular imaging, and bed preparation is optimal, which are not available due to patient finances. They are critical, like use of atherectomy devices, use of peripheral IVL, use of peripheral balloons. So the typical management strategy will be mostly balloon tamponade, immediate balloon tamponade, then use of covered stent for large vessel. If there is micro vessel perforation, we can use embolization with coils. Early recognition is key to avoid such devastating complications. Thank you.
Thank you very much. I would like to give you a comment. We are short of time, so we have to be very synthetic. You did a mistake. You did a mistake to try to put this artery to 8 millimeter. When you have a calcified thrombosed iliac artery, you have to be very careful. Endovascular technique require softness, fineness, and prudence. You must not go too far. So your problem was to re-balloon with a superior diameter. You had to undersize your balloon and stay at 7 because it's a big calcified plaque. So you have to be careful next time. Okay? So we go next.
Thank you, sir.
Mr. Sumit Bhatnagar.
No, too late. We are too late. Oh, you go the next. Yeah, go.
Mr. Sumit Bhatnagar. Yes, sir.
Thank you, everyone. And sorry, I'll start doing, because in the view of shortage of time, we'll start with my presentation. So my topic is seeing beyond the block and an intervention, peripheral intervention under imaging guidance of OCT. So this is, first of all, I'll just optical coherence tomography in peripheral arterial disease. It's not which were documented. So what I am going to see in, it's not running. Why imaging? So obviously now we all know for coronary, this is class 1A indication. We have a much data with IVUS saying about imaging in peripheral vessels. We have some data, but we don't have data for OCT. So why my challenges and homework? So these are large size vessels, long lesions. I'll go directly with the case. So this was a clinical history, a 54-year male who has undergone a coronary angioplasty as well as having a peripheral arterial disease. And he was having a claudication pain. He was on walking 100 meters. And angio left assumed a CTO of left SFA. These were the hardware used. So these were the images. You can see a CTO of the left SFA, a small segment CTO, but there was this one and the patient was having intermittent claudication. So we went ahead with coronary wire of pilot 50, 014 wire. We crossed it with the microcatheter support. We ballooned it. Then we again exchanged it with the Rubicon catheter. The wire was changed to 035. And then this shoot was taken. The dissections was seen. So we thought, how are the dissections? So we took an OCT images, because we don't know exactly whether an OCT can show us peripheral vessels. We don't have data to say. So I tried to take an image of OCT image, and we can see the vessels, and we can see very well the spiral dissections of the whole SFA in between wherever we have done the ballooning. And it was like a spiral dissection which was seen. So these were the OCT images. So we can see very nice vessels, and we can see very well calibrated vessels. and we can see dissection also this coming up. So yeah, now we can see this is the dissection segment. You can see the dissected segment. We can see the adventitia. We can see the media and intima got ruptured. So then again we went, this is because since the catheter was a small segment, this is OCT coronary catheter, so we have to take multiple shoots. And then this was just to demonstrate the dissection segment. And this is just in the CTO, what is most important thing that you cross from a true lumen to true lumen. So just to confirm, it's a 3D view which tells us that I was from true lumen to true lumen in the vessel. And these are all the dissected segments with the thrombus. So this is the 3D view. I'll skip that. And then this patient was the DES of Boston Alluvia. DES was put. And this was the final result. And then post stenting, so again did the OCT, and we saw nicely expanded stent. And there was a plaque, but where this was a stent was expanded, and then this was a good clear image of SFA. So this is again to see how this one is there, and then again a 3D view to show how the stents were looking. So just to basically my case, just to summarize that OCT imaging, this is the pre-PCI, post-PCI image, and this was, and I come to my second case of triple threat, which was neutralized by, again then with OCT guided. So this was a 70-year-old male with progressive claudication in the left lower limb, pain worsened to the point of discomfort, chronic smoker. So I'll go, there was occlusion from ostium of iliac, and then there was a long segment CTO of SFA, then popliteal. So we started with management strategy. We started into two stages because patient was having iliac CTO also and recanalization of SA also needed. So we started with iliac intervention first. Then this was the hardware used, and these were the images, angiographical DSA images. Then again we took an OCT to see what exactly after doing the ballooning. So again we could able to see some images of iliac. Yeah, see this one is the iliac vessels from where we can see the lesions and we can see a thrombotic plaque. So again, these were the images of iliac and going into CFA and then further. This was again the patient lesion was dilated with balloon, stent was put, and this was the final result. So now the next challenge was to open up the CTO of SFA. Then again, this one we tried second stage. Then initial attempt with 035 was failed. So we started with CTO techniques of pilot 50 and pilot 150, 014 with microcatheter and balloon supports, wire exchange, stenting, and adjuvant therapy was given. This was the balloon wire was crossed, and then again to see the OCT was taken, and this is just to demonstrate the OCT images of SFA, how vessels can be visualized. So we can see a long segment plaque, we can see atherosclerotic plaque, we can see some lipidic plaque. And then this is post-stenting image of SFA. I'll go ahead, and this is the final result. So we can see a whole vessel was opened up till ankle, and the arch was formed. So outcome, patient was discharged on DMPT, 6 months follow-up, patient is having no sense of restenosis or symptom. OCT enables precise visualization of complex PAD. Coronary CTO techniques can be effective, endovascular techniques, and if some time give me 1 minute, then I can just show some more interventions of femoral and BTK just to show the images. These are the OCT images of femoral and below knee vessels of OCT images just to highlight the intervention of OCT, how imaging can help us in demonstrating the visualization of these vessels. And this is one below the knee vessels of OCT images of below the knee vessel of PTA, posterior tibial artery. In which we can see all the vessels, we can see nicely the medial layer, we can see all the intima. So this is all like a normal segment, but this vessel was on angiographically was looking like a diffuse disease. And this vessel, which was looking like a diffuse disease, just has a small fibrotic lesion at this mid segment. So if we could just ballooning it and then done
Finish.
it. Yes, sir. I will do it. Finish.
You
This
finish.
is iliac ISR. Okay,
Please,
I finish
you
it off.
finish.
Yes, sir. I finish it.
You
This was the syringes which were used.
You
Okay.
finish.
Sure, sir. Thank you.
This time we stop at 6.
Okay, sir.
So I have some comment.
OCT.
I have some comment.
Sure.
You did well, but on the first case, you were right to put Eluvia. You have to tell us what is Eluvia.
Sorry, sir. It's a drug-eluting stent.
We know what it is, but you have to tell it. It's a drug-eluting stent
Sorry, sir. Yes,
by
sir.
Boston Scientific.
Yes,
So you have to tell that. And
Sorry.
you did right. On the second case, you are a risky person. We don't like to do two stage at the same time because you double the risk.
I didn't do it on the same time. We did in the 2 sittings.
No, you did in a row.
No, sir,
You did that in a row.
No, sir. I did in 2 sittings. Images I showed in that way, but I did in 2 sittings.
Oh, so okay. What type of stent did you put in the iliac?
Yes, sir.
What type of stent
So I
did
put
you
it a
put in the
BMS,
iliac?
bare metal stent only, sir. 8 and 200.
A bare metal stent, but self-expanding
Yeah,
or
self-expanding bare metal stent.
which kind?
It's for Lifestar from Lifestar. I think so. Lifestar.
Okay. So, okay. You have something to say, madam?
Without opening,
We have
yeah.
15 seconds.
Without opening the SFA, you had stented the iliac.
Ma'am, because yeah, so that's what my plan of, because initially iliac was totally occluded, so I have to go from the retrograde approach because I do not have any approach from that side. So initially I have to cross the iliac first, and I thought because I would do an iliac first, give some time 1 or 2 days to the patient, then I do a SFA.
You have to work slow.
Initially, yeah, I told them.
You have to work slow and you have to work prudent. Don't put your stent everywhere. Don't put your guide everywhere. Consider that everything you do could be a problem, especially in very calcified. I think you young people, you want to do everything, but you have to be more prudent. Don't be, no, but you have to be prudent and don't jump on the patient. Sometimes one patient doesn't need anything, just need care and medication. So it's not a finality to be an interventionist. It's just a way to work and to treat patient. Be very careful. Next.
Mr. Prabhat Kumar Singh.
Can you announce?
Yes, sir. Angiojet thrombectomy case in ALI. Prabhat Kumar Singh.
No, it's savior of a catastrophe. Yeah.
Good afternoon, respected faculty and dear colleague. Today I'm going to share a case in which Angiojet has given a very nice result. So we had 40-year-old male, known case of CAD, and PTCA was done in 2017, but he was non-compliant to medication and still continuing with addiction, tobacco and alcohol. He came to us with the complaint of sudden onset of left lower limb swelling and pain, followed by right limb swelling and pain for last 3 days. The symptom of left lower limb was worse than right one. On clinical examination, left lower limb distal pulses were absent, although the right side pulses were present. The baseline investigation, CBC, TLC, platelets, LFT, KFT, all were within normal limit. LDL was slightly raised, around 89. INR was also in normal limit. Transthoracic echo, as expected, showed ICMP with EF of 45%. Lupus anticoagulant weakly positive, not so significant. First time he was detected to have HBS positive. ANA, ENA profile negative. Serum homocysteine was also borderline raised. So the venous Doppler and CT angiography of both lower limb artery and the vein done, and the significant finding was that there was complete thrombosis of left distal superficial femoral artery. The patient was taken to cath lab, and this is the baseline angiogram of the patient. There was complete cutoff of left SFA. The right SFA has not been shown in this scene. So Thermowire was crossed along across the lesion first, then streptokinase were injected 1.5 lakh into the thrombus using the power pulse spray technique, and then we waited for 30 minutes. So this is the scene showing the wire crossing and then the STK injection. Then we waited for 30 minutes and the angiojet mode was switched into thrombectomy mode, and the thrombus was aspirated for a total of 3 minutes for at least 10 cycle. 500 ml of blood with thrombus was aspirated. So this is the ongoing angiojet which has been shown here. And after this thrombosuction, thrombus aspiration, the lesion was also dilated with 4 into 40 peripheral balloon. And this was the final scene in which a nice flow was achieved. The patient was shifted out of the cath lab, and within 24 hours, there was a good result. The temperature was now warmer than the pre-procedure. The peripheral pulses were now palpable, and the swelling and other symptoms also reduced. The patient was discharged on antiplatelet and anticoagulant. So we all know that anticoagulant therapy cannot dissolve thrombus or restore function. It prevents the further increment in that thrombus size. The angiojet can effectively remove the thrombus both mechanically and rheologically and perform rheolytic thrombectomy by delivering thrombolytic drug to the thrombus area. Additionally, as streptokinase or urokinase dosage which are used during angiojet are lower in dose, so it reduces the risk of bleeding. So if it uses with precisely, it will be very safeful for the patient. Thank you for the patient's listening.
Thank you. Thank you. You probably realize that your patient of 40 years was a very thrombogenic patient with tobacco, with alcohol, maybe other risk. So it's a multivascular patient, hyperthrombogenic. So what you did was normal to be done. But I think these patients have to be taken care globally. Probably before putting streptokinase, you can do infusion of heparin intravenous during 1 or 2 days. And then have you've seen that you had venous and arterial thrombosis. I think the control, the circulation seems to be very slow, low down. So you put him at home very early. So be careful to such a patient. It's really. Did you tell him to stop tobacco?
Sir, yes, sir.
Did you tell him?
We also counsel and psychiatric reference was also done.
So
Based on
these
that psychiatric-
patients are very difficult to treat. Madam, do you have a comment?
Sir, how about using other thrombectomy devices like CAT8 or?
Ma'am, there is no head-to-head comparison or any trial as such. But angiojet is as it is the FDA approved now, so we use it. But there is nothing to claim that FDA is better than other suction mechanism.
But result was good.
Sir.
Thank you. So.
Okay, thank you. We go next.
Thank you.
So advancing vascular care, precise stent graft repair of large profunda femoris pseudoaneurysm via endovascular route. Vikas Kumar Maurya.
It was my turn. You have 6 minutes. Can you stick on time?
Good afternoon,
Sir,
everyone.
can you respect the time? Please.
I'm going to present a case of precise stent graft repair of large profunda femoris pseudoaneurysm by endovascular route. Coming to the case, my case was a 70-year-old gentleman with no significant medical history, had a domestic fall in 2023, which leading to the intertrochanteric fracture of the right femur, for which he underwent dynamic hip screwing on the following day. Following surgery, he noticed a pulsatile swelling in the groin. On examination, the vitals was normal, but an ill-defined pulsatile bulge on medial side of the right thigh was seen. On auscultation of the swelling, there was a systolic bruit was heard without any signs of inflammation, no venous stasis, without any neurological or vascular compromise of distal extremity. The picture on left is showing ill-defined pulsatile bulge on medial aspect of right thigh. The X-ray of the patient
hip joint shows that there was a thick walled calcified lesion along the medial aspect of the right femur. We can also see the implant in situ. Now coming to the further investigation, the color Doppler was done, which shows classical yin-yang sign within the lesion, which represent the swelling motion within the lesion. On the right side, we can see axial section of non-contrast CT of bilateral upper thigh, which reveals a isodense lesion in anteromedial aspects of right femur, which was of size 7.6 into 8 into 7 centimeter. So the diagnosis of a large profunda femoris artery pseudoaneurysm was made. As the pseudoaneurysm was large, so we only had left with two treatment options, that is either surgical repair or endovascular repair. As the patient uh, as patient was very worried about his second major open surgery. So after patient after shared decision making, we decided to go for endovascular repair. For endovascular repair, we obtained an access via contralateral femoral artery with a 5 French sheath. Then we advanced the thermo guide wire and Judkins right diagnostic catheter over it, and then we take cine angiogram and DSA of the profunda femoris artery to precisely locate the leak, and to also look for flow beyond it. Now further we exchange the thermo guide wire with Amplatzer J-tip guide wire, and 5 French sheath was exchanged with Balkin's 8 French guiding sheath, into which a well prepared stent were introduced over the wire. Further, we deployed the self-expanding fluency stent graft of size 6 into 20 mm. Um, and the post dilatation of peripheral post dilatation of stent was done with peripheral balloon of size 6 into 40 mm at 8 atmosphere for 2 minutes. And now coming to the results, this is the final angiogram. This is the final angiogram showing no further extravasation. And the video on right side is showing well opposed stent graft on peripheral IVUS. Post procedure color Doppler was done, which shows that there was no visible flow within the aneurysm, and some thrombus is seen within the pseudoaneurysm, and the flow within the vessel, native vessel was normal. The right video is showing 3D reconstruction of the stent, where we can see the well opposed stent. This is the color Doppler comparison of pre and post procedure. We can see yin yang sign, and on the right side we cannot see any turbulence into the lesion, and so finally, that our take-home message is understanding the anatomy of lower extremity is crucial for managing femoral artery pseudoaneurysm. We require a high index of clinical suspicion, and have to confirm with color Doppler or CT angiography. The DSA is the gold standard for both diagnosis and therapeutic intervention. Timely diagnosis and intervention is
Finish. You have to finish. I told you to finish. So, thank you. This case is really borderline for surgery because maybe you have no surgeon on call, but this is a typical case for surgeon. Why? Because he will repair the femoral profunda, and also he will put off the clot, the hematoma. The hematoma is maybe 1 liter. So your patient is going well on the image, but probably it will take 1 month or 2 months to resolve this hematoma. Second thing, I would like to see your hands. Show me your hands. So you have a lot of radiation. Be very careful. You can have a cancer, as I had, a spinocellular. You expose your hands during the whole procedure. And by the way, the bladder was full of contrast. So you have to reformat your technique and call the surgeon. You won't be in a problem, especially legally. Question, monsieur? You have a comment? You, because you are surgeon, I need support as you. I need some support. I feel very lonely today.
I dare not disagree with the chairperson, and more so because I have seen both ends of the spectrum, both as a surgeon, as an endovascular therapist. What we do in these cases, it can be a real mess if you go in an acute situation. And the control over profunda, surprisingly, is not very easy. Even if you take control of CFA, it tends to bleed a lot. So what we do in these cases sometimes is, after putting the covered stent, make a nick, remove the hematoma as you have suggested, so that the recovery is much faster. Surprisingly, and I noticed your stent was barely touch and go. I would have liked if it was a little longer. And, the chances of stent migration are also not there.
Another point. Did you inform the orthopedic surgeon?
Did you tell him about the complication?
Did you inform the orthopedic surgeon? Because he was the cause of that. So you have to call him. The case was recent. When was this case?
2024 July.
So you can call him. You can call him, but a little bit late. Thank you very much.
Next case is by Shrikala Padmanabhan, EIA and SFA CTO PTA in critical limb ischemia.
Good afternoon, respected chairpersons and my dear friends. Today I would like to share with you a case of a long segment left external iliac artery and SFA CTO in a patient with critical limb ischemia. So my patient is a 67-year-old male. He presented with complaint of left buttock and left lower limb claudication since 6 years, with recent aggravation of claudication symptoms since 5 months, and rest claudication in upper thigh, disturbing his daily activities and sleep since 1 month. He was visiting so many orthopedic surgeons, and sorry to tell, so many surgeons have seen this patient, and recently he was referred for Doppler evaluation. He has a history of coronary heart disease, and PCI to LPD and circumflex was done in 2023, and diabetic hypertensive since 12 years on treatment. So his routine investigations, he had a creatinine of 1.8 and elevated total cholesterol, LDL, and triglycerides. And a peripheral angiogram was done, which revealed proximal right discrete 80% disease, calcified. And sorry, on the left side, there was a long segment. Okay, so on the left side, there was a long segment external iliac artery disease and mid SFA total occlusion. And this was the lower limb angiogram. And we planned for a left EIA and SFA CTU, and biggest challenge was to put the crossover sheath from right SFA. I'm not sure whether you were able to see the angiogram, because I took the left angiogram from the right side itself, so it was not very clear. And the right PTA was planned with balloon only approach, and he had good relief of claudication post procedure. And if the left PTA was planned in the retrograde from the right side, and if planned, a left transbrachial approach was also planned. So a crossover sheath was inserted and over or dilated. Now you can see I am inserting the crossover sheath from the right side by putting a peripheral balloon, or by keeping it over the external iliac and dilating it, and over the dilated balloon we were able to track the crossover sheath. And then the procedure was simple. We were cannulated, wired the osteoproximal left SFA, and you can see there's a long segment mid-SFA occlusion, which was gradually pre-dilated with multiple balloons and 5 into 40 millimeter balloon. And now the mid-SFA was stented with a 5 into 200 Apvic stent and post-dilated with a 6 into 40 millimeter balloon. Now a long 7 into 200 stent was placed across the hip joint, covering the entire lesion in external iliac artery, and post-dilated with a 7 into 60 millimeter balloon. And this was the final angiographic result with good flow in the popliteal as well as the infrapopliteal vessels. And this relieved his claudication symptoms, and he is able to do all his work and daily activities without claudication. And the crossover sheath insertion from the right side was the main challenge in this patient because of the high bifurcation and the tight external iliac artery lesion. So there was no support for putting the crossover sheath. It was almost an ostial external iliac disease. And he was discharged on dual antiplatelets and started on long-term insulin also. Thank you for the patient listening.
Thank you very much. It was a good presentation. We can go on. Thank you.
Thank you, sir.
Now I call Amit Jain for erectile dysfunction. 6 minutes.
Good afternoon, everyone. Today I'll be discussing erectile dysfunction is medicine the only hope. Presenting a case of 47 years male with history of hypertension, non-diabetic. He is a chronic smoker and alcoholic. His echocardiogram was normal, and he presented with chief complaints of difficulty in walking, lower limb weakness, along with numbness. And yes, erectile dysfunction was there for the last 1 month. Before that, he was not having any erectile dysfunction. CT angiogram pictures I don't have, but CT angiogram was done. We showed distal aorta 100% occluded. So angiogram was done through right femoral artery, although they were feeble, but we managed to puncture the right femoral artery, and it showed distal abdominal aorta was 100% occluded, and there was almost no involvement of the iliacs. The lesion was crossed with thermo J-tape wire, and pre-dilatation was done with 6 into 60 millimeter Mustang balloon. And pigtail was used to mark the renal arteries to assess the size of the stent. And stent was taken and positioned. It was Andra stent 57 into 16 millimeter, and it was deployed at 6 atmosphere. And this is the picture after the stent that is fully deployed. And this is the post-stent scene. So the take-home message from this is peripheral pulses must be checked in almost every patient who presents with lower limb weakness and numbness. Pathological causes of new onset erectile dysfunction should be looked for in every patient who comes to you with erectile dysfunction. Erectile dysfunction can be cured if treated in a timely fashion. And yes, you must be good friends with urologist and your sexologist friends. And not every erectile dysfunction needs sildenafil or tadalafil. Thank you very much.
Thank you, sir. Probably your patient was in a burnout or something to lost his virility recently, but you probably help him. I didn't see any apogastric feeling on both sides, and I think he will stay impotent. But you give up to him anyway. We go on next. Thank you.
Thank you.
Next is by Dr. Tarun Grover, Regenerator Key to CLI Management Stem Cell Therapy. Not there. Then we go to next, tips and tricks of vascular cannulation for ECMO, Varun Bansal.
Tarun Grover, the organizers requested me to talk about it, and please do not consider it as a competition case. I'm a little young
What
for
is
that.
the subject of your presentation, sir?
Same subject, sir.
So what it is?
It is the key to CLI management stem cell therapy. Same subject, sir.
You know Dr. Grover?
Yes.
It's not you.
That's not me.
Where is he? Is he around?
I think he's somewhere abroad.
He's abroad?
Yes.
Alone?
Maybe with his girlfriend. So
You replace him. Thank
yeah.
you.
So Tarun Grover, for those who don't know him, is a leading vascular surgeon. He's the president-elect of the Vascular Society of India, and I, sir, was the president 20 years ago. So I will, this is something I used to do 30 years ago, not anymore. And yesterday, my dear friend, Dr. N.N. Khanna, in his introduction, talked about it, and this was meant more as a course material rather than as a case presentation. Peripheral artery disease, 200 million worldwide. Etiopathogenesis, we know. But what I wanted to say was we have a category of what is known as Berger's disease or thromboangiitis obliterans. These are the categories, and categories 4, 5, and 6, i.e. a person who has very severe intermittent claudication, rest pain, minor tissue loss, or major tissue loss with gangrene, then these would come in consideration for stem cell therapy. So what I was talking about was Berger's disease. This seems to be becoming less and less. It is in young males in their early 40s, heavy smokers, and it is typically infragenicular disease, below the knee disease, this is how the injection is made. It is fairly straightforward. Just make sure, withdraw slightly, that you don't enter a vein. It would not be a catastrophe, but it is not advisable. So, what is the clinical evidence in India? 541 patients across 79 centers, a very small number. And I'm proud to say in my center, I have done 18 patients. So, somewhere about 3% of Indian experience, not very huge. And in Berger's disease, also, we have used them, and it is very useful. Yesterday, there was a question about the safety of mesenchymal stem cell therapy over 15 years, and this article has been published in an open access journal, which says that meta-analysis of randomized controlled trials does not show any safety concerns. Typically, the reactions are very mild and self-limiting. So forget about this study. Basically, the rest pain goes down, the ulcer size decreases, and some studies have shown a slight rise in ankle systolic pressure or ankle brachial pressure index, which to me is a little surprising because neovascularization usually does not result in that. We have had good results, no major amputations so far in these, as far as I know, in these 570 odd cases. So this was another similar study. I'll skip this. So the efficacy endpoint is the ulcer healing, and it is remarkable rest pain improvement. So to say in summary, in PAD patients, mesenchymal stem cells in about 80% relief of rest pain, decrease in ulcer size, slight increase in ABPI, and increase in quality of life. Thank you. Thank you very much.
Thank you very much. We are very happy to hear that, and we will be very diplomatic in the scoring.
Thank you, sir.
So,
Next is tips and tricks of vascular cannulation for ECMO by Varun Bansal.
Good afternoon, respected chairpersons and the members here. Thank you for this opportunity. Mine is not a case-based discussion. It's mainly technique-based discussion because thankfully in last 6 years, we have not had any complications related to our cannulation in any of our ECMO patients. I'm Dr. Varun, consultant cardiac surgeon. I'm not a cardiologist or intervention as most of you are here. So I'm sure you would all know types of ECMO. I would not waste my time on this. VA ECMO and VV ECMO, different types of indications for that. When heart is involved in kind of cardiomyopathies, be it cell-force poisoning or viral cardiomyopathies, the indication is VA ECMO. And when it's only lungs involved, it's VV ECMO. The relevance for peripheral cannulation is we mostly used to do cut down cannulations earlier, but now it is peripheral cannulation in common practice. The reasons are rapid bedside access, minimal invasive and favored in emergency and temporary support. Goals of cannulation are adequate blood flows, 50 to 150 ml per kg for infants and 60 to 80 ml per kg per minute for adults. The answer is to avoid complications, whether it's vascular, limb ischemia, or bleeding. Preparation for cannulation is very important. It has to be ultrasound guided. If you're not doing it in periphery, we have had our chances of doing a peripheral retrieval as well. Their ultrasound is sometimes a challenge, then it's experience based mostly. Anticoagulation has to be checked before you cannulate. The ACT has to be above 180. ASAP techniques and full barriers. Equipment should be ECMO cannulas. Please check all your cannula inventory properly. Dilators and guide wire ultrasounds, fluoroscopy. One complication which I remember in 2019 we had is we were unprepared. The patient was was undergoing a HOLEP. He had sudden air embolism. We undertook the patient for peripheral ECMO. We were not ready with the cannulas. And when we started to do this, we put in an oversized cannula and had a retrograde dissection. Retrograde dissection extending from iliac to the ascending aorta. We had to cut open the chest, did Bentals for the procedure for the patient, and thankfully he survived. Cannulation techniques are mostly Seldingers, ultrasound guided, identify vessels. Please avoid side cannulations. Insert needle 30 to 45 degrees. It's very important that dilator entering the skin is a different angle from the guide wire. Serial dilatation and cannula insertions with attention to depth and direction. Venous cannulations, real-time ultrasound, mark skin, and right atrial wall contact is sometimes possible, and it readily gives arrhythmias which must be prevented at all costs. Please choose the larger of the two femoral arteries. If there's a problem with one, you can go to the other one. There's no problem going to the axillary as well. Distal perfusion cannulas are almost always necessary. If you're not putting, please keep a watch on the limb. There are high chances of limb ischemia. Limb ischemia is very, very devastating complication for the patient because you might save the patient, but if there's a limb ischemia and the patient loses the leg, the life is not worthwhile living for many. So the larger cannulas might cause limb ischemia. It could be the other causes which influence are female gender, younger age, thromboembolic events, diabetes, patient with peripheral vascular disease earlier, venous stays, and distal artery compression. The idea is to prevent it. BSA calculation, femoral vessels, echocardiography, bedside selection is very important. Combine surgical and percutaneous techniques. If there's a problem with one artery, you can cannulate both the femoral arteries to establish the complete flows. These days, even distal perfusion cannulas are available. They have a small hole. Even in cardiac surgery, we are using Levonovo cannulas. They have a small hole which perfuses the distal artery adequately. Troubleshooting is no black flow. Please reposition needle. Do not rush into it. Guide wire resistance may be in the wrong vessel or coil. Please do check. Bleeding duration dilatation, tamponade and compress. If it's not an emergency, if it's an elective procedure, you can compress and take the patient again after 2 hours. It won't matter. The idea is establishing ECMO at the right time, but it's not rarely urgent. Poor flow after cannulation, kink, cannula, clot, or vessel dissection. Please check everything before you start the flow or even continue with that. Possible cannulation complications are cardiac arrhythmias. They're readily seen on the screen. The idea is to withdraw the guide wire to prevent any kind of cardiac arrhythmias, laceration of vascular structure, hemorrhage, including occult, such as retroperitoneal hematoma. Unfortunately, we lost a patient who we pushed the venous cannula over and over again, and he bled retroperitoneum. We could not do anything, and the patient succumbed to his illness. Air embolism, selective cannulation of smaller vessels, cavitations, bubble trapped in cannula. Everything has to be very, very carefully planned so as to avoid any kind of complication. We haven't had a chance to publish our result because we take our patients very, very carefully. But these are the published papers where there have been liver injuries, arterial complications, even iliac vein injuries, and endovascular repair was attempted. If you have a vein injury, it's reasonable to put a covered stent and save the patient. Vascular complications undergoing femoral complication are not very common, but must be prevented at all costs. Post-cannula care is secure cannula with sutures, adhesives, regular site inspection. During decannulation, we have percutaneous devices for decannulation now, including ProGlide, ProStyle, AngioSeal, and Manta devices. Ultrasound is your best friend. Please use it wise. We have 19 seconds. Sir.
Thank you very much. Your talk was good, no comments, and we are going to thank you, sir.
Thank you.
We are going to give the results. We have number 1, number 2, number 3. Number 3 is yourself, the one who gave this presentation. You are number 3. Number 2, it's Sumit Bhatnagar. Come down, come up, and you smile. You are number 2. You're on the podium. And there is a great suspense for the first one. The first one, you are the first. It's not diplomatic because you are a good speaker and the topic was innovative. You are the number 1. Photo. I would like to give a take-up message a personal take-up message. You are good doctor, doing good, especially the young, but I think you have to be more prudent. You see the master like Dr. Khanna doing so well, you want to copy. You need experience because Dr. Khanna does the same thing since 30 years, me 40. So we have the experience, especially to go away from a complication or to treat a complication immediately. I've seen that your bladder was full of contrast, so you put a catheter before. So because he can have a spasm of the bladder in the recovery room. Second, sometimes you hear me, please, please, you hear me, please. And second, sometimes you want to do too much. And one stage, two stage, three stage, you go to complication. And finally, be smooth, be prudent, and don't oversize your balloon. It's better to be 1 millimeter less than 1 millimeter more and create a fistula or extravasation. Some cases were dramatic, were catastrophic, going to death. You can kill people going too far. So this is what I want to say. You have something to say, madam? No, she's a good colleague. Thank you very much.
The expert panelists for this session are Vijay Trehan, Rakesh Yadav, Vishak Mohan, N.N. Khanna, V. Hariharan, Preeti Gupta, K.H. Srinivas, and D.H. Natish. And we also want Dr. Buske to stay over for this important oration. Yeah, and Dr. Preeti Gupta too. So let me invite Dr. Rajiv Lochan. He is here, no? So let me introduce Dr. Rajiv Lochan. He is one of the senior most cardiologists of the country. He's been a very different sort of international cardiologist who has inspired us, especially me when I was even doing my DM. And he's been innovative from day one. And now he practices in Dubai. And he is going to speak about novel and nearly no contrast balloon angiography imaging system, which he has developed with the concept, and now it is patented in US. So we are very proud that he's coming and giving this oration. And also the fact that the balloon and the system has been manufactured in India, in near Delhi by Newtech. And we've been very fortunate to do some of cases using this technique with him in our cath lab. So over to you, Dr. Rajiv Lochan.
Thank you, Dr. Khanna. Always you have been very kind to give such a nice introduction or my background. I'm really pleased because this I'm discussing and showing our results of the study where Dr. Khanna has been instrumental to get into the product made, because he introduced me to the company and they helped me, because I have tried before this 4 different companies in Europe and 1 in China, and they couldn't make the product which I wanted. But this company has been really great. And it was started with Dr. Khanna's advice that you contact this company. Anyway, let's go forward to the what I'm going to talk. So I'm talking something different. This is a balloon angiography imaging system. I have just given an acronym as bias, just for a people may be unbiased to make them unbiased. So this technique of balloon angiography is performed with a very soft balloon, which has been especially developed, though it is similar in appearance to coronary angioplasty balloon, but much lower compliance. much lower than even semi-compliant balloon. The balloon is advanced over a coronary guiding catheter, which is in the place, and contrast is injected into the balloon, not in the vessel. So balloon contrast remains in that soft balloon, which is placed in the vessel, and angiography images are routinely documented or reported, and then we aspirate the total amount of contrast from the system. Contrast is completely out, so nothing goes in vascular system, nothing has to pass through the kidneys. So the people, those who have impaired kidney function, heart failure patients, there is no risk of overload. Procedure is intended to be completed within a very minimal amount of contrast. So this is a cartoon on the left, which is on the showing that the normal angiogram, as you have a lumen there and there are some branches you can see. Below that, in the same vessel, we have put a balloon, and this balloon is showing indentation or stenosis, same as in angiogram. So it tells you exactly the same thing what you're seeing in angiogram. Same stenosis you can detect with the balloon. And this is on the right side, the picture, set of picture is on my bench test, which is a tube which has got I have created some stenosis and then filled with the dye. In the same tube, after removing the dye, we put a balloon, and similar stenosis or nearly similar stenosis can be diagnosed. So on the bench test, severe stenosis can be detected. So the balloon is so soft, it can pass through almost 90% plus stenosis in this area, which has been showing a tight stenosis, and multiple views it can be seen, LAO, RAO, and this was the whole idea, to show that the balloon can pass through a very, very small area. Now, on another bench test, we did some creating ectasia. This balloon is so soft at 2 atmospheric pressure, from baseline, it can go up to 7.5 millimeter in diameter. So it's so soft. So that's why it takes the shape of the vessel, whether it is stenosed or it is dilated, that can be detected. Now, this is some cartoon which is useful to understand how this balloon is going to be used in case when we are doing angioplasty. So this is the guiding catheter. From there, one of the balloon, which is the larger balloon, is the angiography soft balloon. I think this marker is not working. Sorry, can this marker be activated? This one, no? No, marker. Okay. Right. Thank you. So this, you can see the atheroma in this cartoon on the top, and then there is a stent or angioplasty balloon capped, and below that is my soft angiography balloon, newly developed. So what we do, this balloon, when you inflate, you can detect whether your balloon or stent is in place across this atheroma. If it is not, you deflate this balloon and then reposition it and then inflate and confirm that you are in the right place. Once you are in the right place, you deflate this diagnostic angiography balloon. So do not confuse. One balloon is angioplasty balloon and one balloon is angiography balloon, which is I'm labeling as bias. And this will be deflated, taken back into the guiding catheter, including the wire. If it is a stent, you can inflate the stent, deploy it, and after that you can rewire through the stent, and then you can inflate the balloon again. So then you can confirm whether it has been fully expanded stent or you have received the result which you wanted. So this is some patients' examples I'll show you here. This is the right coronary artery. On the left, there is a balloon angiography where you can see some stenosis. In the audience, can I just ask if this is a significant stenosis where they say my pointer is? How many of you will say it's a significant stenosis? 1, 2, 3, 4, 5. Almost half. So this is significant stenosis. And this one, Is it significant? Same. So basically, what you have seen, the balloon can diagnose the similar stenosis as we can see in a standard angiogram. So control angiogram is to compare, this is our control, and can see that balloon angiography, which is showing a stenosis, can be diagnosed on this. And this is on the set of picture on the right, is the post-stent employment. There is a deployment, there is no stenosis, and on the balloon angiography, same as on control angiography. So this angiography, newer system can diagnose the stenosis removal after the stent placement. I'll show you some examples to make you familiarize how this technique is working. Here is another patient with LAD who previously had interventions, and there are some stent, and after the edge of the stent, there is a tight stenosis on the balloon angiography. This is the newer technique in multiple views, and you can detect that there is a stenosis here. It is similar to the control angiography, which we are more familiar with. So this is the similar stenosis as you see in the top. Similar stenosis diagnosed, but you don't need all this dye which is going in different branches and to the system. Here, after the procedure, my dye will come back. It doesn't matter whether you use a ionic dye, non-ionic dye, because non-ionic I prefer because that's opacity is better, because dye is not going to the system, so it doesn't matter whether you use which kind of dye. And the same is in other view. You can see that is stenosis, balloon, and after control angiogram. Another example, this is interesting. There are multiple views and ectasias. You can see that with the balloon angiography, stenosis here, ectatic segment, another stenosis, and another stenosis. So these are the area which multiple stenosis. And then I just want to make you clear, because the balloon length is maximum 50 millimeter. So in this picture, I have fused 3 pictures, sequential pictures. They have been fused together just to give comparison, because we are more familiar with the whole arterial tree rather than one part of the artery. So to familiarize with it, on the right side, there's similar narrowing, which can see on a control angiogram as we have seen on the balloon angiogram. Fewer techniques like stent boost or stent clear, this picture becomes much more clearer. You can define it even better than angiography. If you have a stent boost and a balloon angiography, you can define the stenosis or dilatation very well. There are other methods we try to confirm what we are saying is a correct, whether the stenosis is there. I was confirmed there's the tight stenosis as we seen in a balloon angiogram, similar to our control angiogram, an ectatic segment, same as seen on IVUS, same on balloon angiogram. So I'm trying to say that I'm trying to compare with other accepted technologies to understand this technique is acceptable. Not only that, we did some quantification studies where the same artery with the balloon angiography, and same on the right, we did a angiography. And figures are very similar, 64, 66%, 81, 78%, 63, 60%. So all these 3 narrowing were correspondingly very similar on QCA, whether it is a control angiography or it is balloon angiography. This was an interesting case because this patient had on CT coronary angiogram which showed LAD 100% block. So we took for angiogram. Angiogram on the right, you saw almost total block, but there is some streaking of blood flow. I have to put this pointer to make you understand the course. It was almost 1K99. It's not 100%. So my balloon could cause. So this is another point. This balloon is so soft, which is almost crossed across the 95 to 99% stenosed artery, and it was luckily not calcified. In very heavily calcified, I don't think I can cross with this balloon. So that's a limitation of this technique. This cannot go to the CTO or totally blocked artery or very heavily calcified artery. But it showed very tight stenosis, similar to our control angiogram. In QCA, similar degree of stenosis on control angiogram or on balloon angiogram was shown in this case also. And this is after post-dilatation and a stent expansion. Sometimes you can see the under-expanded stent as well. So we did some more study on this, and we wanted to show that this technique is safe. And this IVUS showed that after balloon angiography, there was no increase in intimal injury of this patient. And this was the whole idea to, I think it's not moving. The whole idea was to just understand ourselves that we are not causing any damage to the intima of the artery, how it's working. So this is just our understanding, because we are also learning with this new technique which we are doing, whether it is really safe for our patients who are not really having severe problem because of this new technique. So this is the bench test, where the stent was under expanded purposely, and then we passed this diagnostic balloon. It is so soft, it is kept in a tube. When we expand it, the balloon went up and down. You can see the balloon marker is here, but it has grown longitudinally. It's so soft, it can go longitudinally as it gets the place. And the stented part is under expanded, which we could detect with this device as well. Here also, and you can see that in another bench test, this area is irregular, is of the stented segment, but it is not very smooth. When we post-dilated it on the right set of pictures, these lines become parallel, which means that balloon has been fully expanded. I'm trying to make it useful to the technology which we are used to. For this, if you want to see that it's fully expanded, and if you know the diameter, you don't have to do imaging for understanding the expansion of the stent. We have so far experience in about 32 patients, and this is the various patients and vessels which we're doing and degree of stenosis we are diagnosed. We're very similar onto the balloon angiography, same stenosis we detected on the corresponding coronary angiogram. So we are trying to collect more data and more information and experience to make it easier to understand, make for others to accept. This is a new technology. Anything new, as a human nature, we don't want to accept the change. Change is very difficult to accept, number one. But wherever it's useful, we should be able to use it. So this novel technique of balloon angiography is an effective procedure to diagnose vascular stenosis or dilatation or ectasias. It will avoid the risk of acute kidney injury, contrast-induced nephropathy, or aggravation of congestive heart failure during the diagnostic angiographies. It is also valuable during the interventional procedures, which normally requires much higher volume contrast and can be minimized with this, at least in high-risk patients. This also confirms the under-expansion of the stent. It may be particularly useful for BVS. BVS we don't use anymore and that much in practice, because BVS you can't see with IVUS. But this will be able to tell whether the BVS has fully expanded or not expanded. And it avoids the need of OCT, which in this patient of CRF, for example, OCT will need another load of contrast, which can be avoided. Total less than 5 and 8 ml of contrast is required. One is to initial shoot to define the coronary artery tree, and the final result, what you want to do, and to see whether you have done the good job. So this size, I'm pleased to announce that this has been last month been patented by US patent, has been granted for it. And this, we are still collecting multi-center studies going on and to get some more data on it. Because this is a new technique, and I have presented in only part of it in cases and few other smaller meetings. It was recently presented in PCR, also in Singapore Live. And there are some questions which I framed, they have been asked. Maybe a lot of you have something similar question. Why should one change the established practice? Is this new concept of balloon in place in cine angiography is correct, the concept? And balloon angiography imaging system, is it reliable? I have tried to convince you, showing the different techniques to compare. It is safe for CRF and reduced ejection fraction patient, but is this technique atraumatic? That we try to do with OCT and see it does not cause any injury. Can this balloon cross through the tight 95 to 99% stenosis? That I have shown one example. Can it go to the side branches? And that was interesting. I have gone in side branch through the stent. It was a stent which was old stent, and I have gone into the diagonal and taken those pictures as well. Sorry, I have not shown that pictures. Can it be detected in a stent stenosis? Yes. It can detect better than angiography because it gives a localized view, and you can see it very much better because dye goes around the stenosis. It gives sometimes a blurred shadow, which is much better in the balloon injury. Can it detect the distal flow? No, it cannot detect the distal flow in the coronary artery, but it has got limited value. This was the question asked by one of my participants. Thank you very much for the patient listening. Although usually there is a dictum not to have questions, but if anybody has concern, I will ask Dr. Khanna to give approval to, because this is being a relatively new subject. Is that okay for you?
Yeah, it's okay.
If anybody has a query or question, you can, or comment, you can most more welcome to come. Sure, Dr. Trihan. Thank you very much.
In angiography, we usually don't insert wire. In your case, we have to insert wires, unnecessarily creating a complication.
Absolutely.
Wire induced, similarly, with the use of the balloon, we can, when we will dilate the balloon, we are unnecessarily injuring all of the intima from proximal part to the distal part. Third thing, in your method, suppose a patient who is having thrombus burden, which is highly, means it is, there is some flow, but thrombus burden is there. You have put the wire, you have inflated the balloon, you have taken out the balloon. The artery will go into slow flow or no flow, what will be? Thank you.
You have given very good points, and some of them are important, and I will discuss in person with you after this because I think I don't want to keep everybody busy. But this is absolutely fine. This is absolutely true. There's a hardware which is needed, but this is I'm not recommending as a replacement for angiography. It is for the selected group of patients to start with till we learn it more about this technique, like high renal failure or heart failure patients.
Sir, I'm not discussing this particular thing. It's a great thing. I've worked with you personally for around 4 years and learned so many things from you. And I found you one of the most innovative cardiologists which India has produced, sir. On the table, whatever, whether it was the first case in the country, but you never reported it in the journals. It's a different matter, sir. Sir, I'm not discussing about this thing, but sir, with your kind of brain, sir, carbon dioxide has been used.
Yes.
So why don't you try some gases or something? And let's, I mean, a little bit of something we can inject and we can see everything in a second. And carbon dioxide thing should be taught to I feel every student, so that no contrast is used or something like that. That would also be a great thing, sir, and something other you can try, sir.
Thank
Thank you, sir.
Thank you very much. Deepak will discuss with you on the carbon dioxide. It's not safe for the cerebral circulation. That's fine. Thank you very much.
Thank you, Dr. Lochan. Can I have the plug, please? We wanted to hand over the Gopi Devi Oration plaque and award to Dr. Rajiv Lochan, which states, for the year 2025, Gopi Devi Oration Award has been conferred to Professor Dr. Rajiv Lochan from Dubai for the topic Novel Nearly No Contrast Balloon Angiography Imaging System at the 17th Asia Pacific Vascular Interventional Course held at New Delhi, India from 11 to 13 July 2025 for his distinguished contribution to the field. Asia Pacific Vascular Society wishes him many more years of good health and academic excellence. I would request the chairperson to hand it over to Dr. Rajiv Lochan.
The topic for this session is tips and tricks mitigating complications learned from experts. The expert panelists for this session are Vijay Trehan, Sudesh Kumar, Rajiv Rajput, Ranjan Kacharu, Amit Jain, N. Shastri, and Raman Chawla.
Can I have the members of the panel to come up? Dr. Vijay Trehan is here. I may request Dr. Asokan, Dr. K.H. Srinivas, and Dr. Chawla, and also Dr. Sanjay Tyagi to please come up. So this session is on tips and tricks mitigating complications learned from the expert. And so we have 6 presentations, the case presentations, and we have a special talk on retrieval of embolized material by Dr. Vijay Trehan. He has an emergency at the hospital, so he's requested that his talk to be shifted up. So we'll start with Dr. Vijay Trehan's talk. And I believe we are running quite late in time, so I will skip my talk on complications on muscular bleeders, reasons for tracheostomy. We will probably do it tomorrow. Dr. Vijay Trehan, please.
Thank you, Dr. Khanna. Well, I'll also go by case. This is a symptomatic patient, significant disease in the right coronary. And if you see here, you see the calcium in the left. With most of the time, we don't interpret calcium in the left system. This calcium is not appreciated until you anyhow, doesn't matter. So I had to throw an anchor in the conus to deliver an IVUS, and hugely calcified vessel went up to 175 drill, was able to create some impression here, not too much. And finally, I had to take an 8 French guide extension to take a long peripheral IVL balloon and treat all the way and end up like this. So having tested calcium on the right, now there's a turn to look at in the left. And this is the carina side. Even if you go with a 1.5 bar, I don't think it's going to do any impression here. LM prox part was fine. And then I thought probably I will not go with the Aorta, I'll go with IVL, but the IVL ruptured here. Couldn't dilate. Fortunately, no harm. But if you see carefully, that's the wire which is going, and the vessel is low down. It's like vessel is here, the intima gets stretched up, and into a crevice is lying the wire. The wire is here. That tells you about the extreme guide wire bias, which one should be aware while we are trying to handle this case. So took the next IVL, started to work around shorter pulses at the left main, higher pressures to end the pulses, and some difficulty, but finally I was able to deliver a science expedition to the site, positioned it, deployed it, then podded all the way to get this kind of result, which I think is quite okay. But my partner was not happy. The reason is he finds something there. So I said, okay, balloon it, did the ballooning, and this is the result. So my partner says that fine, the result is excellent, but why not treat this area with drug? I said, okay, you take another small short stent there. He tried to take it there, finding it difficult. So he tried to change the trajectory of the guiding catheter, didn't work. Used a buddy wire, didn't work. Tried to change to a shorter stent, didn't work. Took a thinner stent, stent, didn't work. And took the guidezilla into the LED. And even with the guidezilla into the LED, if you see, he's done a full dilatation. Still, that short stent, he's able to walk into the LED, but not reach the site where we want to deliver the stent. So he tried to increase the support, but see what is happening. If you're trying to push, your guidezilla and guide extension both get out. So realize that probably you cannot deliver it. And if you see, there is no forward but only a backward motion of the guide extension, and the stent itself is not moving forward. So it looked like it's coming out, but I think didn't realize it here that it's not really coming out. It's in fact getting slipped off the balloon, and the balloon is getting pulled out. Did not realize it here. I think it was pretty late to realize at that point in time, and finally realized that the stent is totally off the balloon. So my partner is good enough to snare it, and it was the easiest of the fishing. So took the snare, caught it, but somehow he's finding it difficult to get it out. So he said, okay, fine. And I thought I'll come. I engulfed the stent into the guiding catheter. Then I thought, now it's pretty easy. All what I need is just take a balloon, advance the balloon close to the tip, inflate the balloon, this will trap it, and I should be able to take it out. That's what is being done. You see, this is a balloon which is coming out. And I didn't realize it that as the balloon is coming out, the stent gets pushed out rather than getting trapped there, because there is a part of balloon which is extending beyond the marker. Sometime during the procedure, you lose the anatomical marks. So probably realized only after I found that the stent is out. So now the stent is on the bar left in the distal part, and rest of the things look kind of okay. Flow is fine. So I said no issues. Took a snare over it. I thought I'll just catch it. No issues. Caught it and pulled it. I thought everything is fine. It will be out, and I'll deliver another stent from here. But after the stent has been snared out in aorta, now I cannot pull it any further. Now it is almost as if I'm pulling the heart. I'm feeling very vigorous contraction of the heart. Sometime if you want to take out a permanent pacing lead which had been there for quite some time, and you want to have this lead out, you will feel the heart pulling it from inside. That's what was happening with me. Now the snare has been pulled out of the catheter, but it's still kind of pulling the heart. My PTC bar had come out, and now stent is off the bar, and snare is not able to pull this stent into the guiding catheter. I'm in a dilemma. Look at it. This is a snare. But what is this? There is a bar. I had already pulled out the bar. What is this wire? Now, this is pulling out the heart. And if you see carefully, that's the stent here. I just tried to see whether I've done something wrong with the heart. I thought another guide. Check it. Check shoot shows that everything is fine. Nothing is wrong. At least no perforation, no collapse of the vessel. So then I thought at least have a safety wire in the left. I took it. The wire was taking some funny course, and that's how the balloon was not following it. So tried to rewired it well, then took a balloon, and in a form of Reiki, I tried to dilate everywhere just in case I have to do anything. I have to take another stent there, I have to take a stent graft. Let me just do a Reiki and fine. So things were done. Now see here. This is a second guide and a wire through it and a balloon there. I anchor this area with a balloon just to give counter traction to my system, which is trying to pull out the stent. Even dilatation and inflation of a balloon here, trying to give a counter traction, didn't work. And you see what is happening here is a lot of pressure, tremendous. Then I thought sometime loosening the snare will work. So I loosened the snare, but it didn't work. Tightened the snare, it didn't work. Now you see, that's the guide. This is a stent which is out, part of the stent is in, and the second wire is there. This is a stent which is not getting inside the guiding catheter, and there is another wire additional there, which I had not wired. And then look at it, this goes in. This goes in. You see it? This goes into the guiding catheter. So this is something different, and the stent has gone inside. Now let's see it all again. I pulled it down to the plate all again. See that? It caught it. Stent is outside. Wire is there. Stent gets in and everything is out. Fortunately, things are okay. Then I think I just delivered another stent, and that was the final result. So this is what came out. What came out was not one stent. The stent which I delivered from LM to LED also came out. So there are several points to learn. I was asked to talk about retrieval. I've shown one retrieval with some difficulty. One must listen to one's partner, fine. But sometimes listening and following may not be good enough. So, and better is the enemy of good. We could have just done a DEB rather than a stent there, because plastic material was in fact going easily through that stented LM to LED area. Mike, till the time they are settling. So I could have just ended here with a DEB. So we did a mistake. This thing we should have just learned here, that if you look at it, look at the trajectory. That's the guide. This is the left main. That's the LED. Very funny kind of angle. We should have been taken a cognizance of this kind of an angle, because this could pose problems to us. And we had already seen this extreme guide wire bias at the carina, which did not pose a big threat to a plastic material in the form of a new balloon going, but is likely to pose a problem if you take a stent through the stent, freshly deployed stent, and then you want to take another stent through it. So a malleable plastic easily went, but the metal through metal might be difficult. Second is, I use Guidezilla, which is not one of the best malleable guide extension. Had I Guide Plus 2, which is from Nipro, or a telescope, which is from Medtronic, I think that would have just gone past the stent, the lesion, and I would have been able to just deliver the stent. Then we did not really realize that the balloon is getting off the stent here. At this point in time, I think things were still easy. You could have just delivered a stent here and things would have been pretty easy. But realizing it at this point in time, I think we were already pretty late. Another very important thing, my partner was easily able to take a snare over it and catch it and bring it out. But somehow he was not able to take the stent into the guiding catheter. Generally, it is because of malalignment. But since he had worked a lot on it, and when my turn came, by that time, one of the edges of the stent got inverted because of the guide catheter manipulations. And the mistake which I did was, I tried to open my mouth too much and too early. See, had I opened this snare, was opened too much and too early. It went like this and it caught both of them. It caught my stent, which I wanted to take out. It also caught the edge of the stent, which I delivered, which I didn't want to take out. Had I opened the mouth not too much and opened it only close to the stent, this thing wouldn't have taken place. So that was a mistake of mine, that I opened it too much and I opened it too early. And I didn't realize it until the stent went off. Another good point in this case was, in a big vessel where even 175 bar has not worked anything, creating a dent with 175 bar and trying to use a 8 French guide extension and a peripheral IVL balloon. Peripheral IVL balloon is 4 times longer. It has 4 times the number of pulses. So effectively, it is able to give 15 times efficacy than a routine coronary balloon for the same cost. Thank you very much for your attention.
Doctor, a very small point. Instead of, you said your snare was open too much, so you put the proximal end. I felt other way around. The distal end of the stent, which you're trying to take it back, was already intermingled with the previous stent. So that is the reason, not the snare being open too much. What do you feel?
No. Actually, initially I caught the distal end. But I had been generally teaching everybody in all the conferences that if you have to catch a foreign body, don't go too far. Like, I started to open the snare first. I went over the snare, over the stent with the snare almost till the bifurcation, and I caught it there with the bifurcation. But that's wrong, because if you catch the stent far distally and now you want to take it, it will not come into the guiding. So I thought it is better to catch it as close to the proximal end as possible. For doing that, I opened my snare, which was a little bigger. I opened it a little earlier than what I should have, and I advanced it and then closed it. So that is what it did. It caught both the disfigured previous stent with the guiding catheter, and that the stent got kind of inverted because there was an angulation between the guiding catheter and the LM. Guiding was going up and the LM was going down, so it will try to kind of invert one of the edges of the stent. So that was probably missed. This case I am showing because I always used to say, तुम कोई भी कोई चीज छोड़ दो, मैं निकाल लाऊंगा. Sometime I used to tell my resident, take a wire, break it, throw it into any part of the corner. I'll bring it out. And even today, I feel very confident. You break anything, I'll take it out. But here I did a very big mistake, which I'm just trying to tell you that this kind of a mistake can be done. And I think the biggest mistake, other than the other things which I've kind of told you, is don't open your snare too much and don't open it too early, because you are likely to catch some unnecessary fish.
You said to break it, keep things anywhere you take it out. Wait for my case. Then I'll ask you how you'll take that. What I'm going to present is something really unique. I really want your opinion. How will you take it out? If you have 5 minutes only, I might present my case in
I'll
front of
stay
you.
on.
You'll stay.
Yeah.
Good. I don't know.
Thank you very much.
Thank you, Professor Trihan. Always wonderful presentations by Dr. Trihan. Now, you would like to present Dr. P.K. Ashokan from Kozhikode. He is one of the senior most members of the Executive Committee of the Cardiological Society of India, presenting on adductor canal SFA pseudoaneurysm. Dr. Ashokan, please.
Chairpersons and friends. The reported incidence of pseudoaneurysm is 0.2 to 2%, and the incidence is increasing, and radial intervention is maybe up to the tune of 0.3%, femoral artery interventions 1.2%. And the incidence is more if there's a complex procedure, and because of the more potent antithrombotic agents we're using nowadays, and larger catheters and devices, and early diagnosis necessary to avoid potential complications. So there are various methods of treatment of pseudoaneurysms. One is a watchful waiting for spontaneous resolution. That's ideal in small case asymptomatic patients and small aneurysm, and ultrasound guided compression and ultrasound guided thrombin injection, and surgical treatment, especially large aneurysm when the size is more than 2 centimeter and neck is more than 1 centimeter, and or if there is history of embolization or early evidence of infection or pain, then you have to send this case for early for surgery. And the effectiveness of the ultrasound guided thrombin injection, first phase itself is 90%, and second phase is around 97% in radial and 85% in femoral intervention. This is a radial pseudoaneurysm. You can see that there is a large pseudoaneurysm here, and neck is here, it's around 2 millimeter, and you can see that jet going to the aneurysm cavity, and you inject thrombin. Here, the quantity of thrombin is very important. You can use around 100 international units or 200. That comes around 1 ml maximum or 1.5 ml. Not more than that is required here. And you see that it immediately is thrombosed, and you have to see that it is the flow in radial artery, and that is present here, and this sac is completely thrombosed. Now, coming to my case, pseudoaneurysm of the adductor canal. That is HD is very rare after the femoral intervention. His case has been reported after the trauma, after the orthopedic procedures. So this case is 85-year-old male, is a case of severe diabetic CKD, hypertension, and admitted with ACS and NSTMI, went for PCA to RCA through right femoral artery route. 24 hours after the procedure, patient had mild pain on the femoral site, and he had received by the time Paxil transfusion for anemia, and abdominal ultrasound was done to rule out any retroperitoneal bleed because we could not see any swelling at the femoral site. That's very important. Second one is also did that time send the case for ultrasound examination of the femoral site, and except small hematoma, nothing could detect that. 40 hours after the procedure, patient pain over the femoral site, not able to walk, and pain and numbness of the leg. Then again sent for repeat ultrasound. We showed a large hematoma, 6.5 into 3 centimeter, right aortic compartment, adjacent the vessel arising from the right common femoral artery. And so in this case for CT angio, you can see the common femoral artery and this muscular branch supplying the adductor. And here you can see the large pseudo aneurysms and hematoma here. And the size of hematoma is very big. So, and you can see the hematomas. And here this artery arising from the common femoral artery branch. And you can see the pseudoaneurysm here. And this is a case you injected thrombin into the sac, so around 2 cc thrombin, and we immediately thrombosed the sac. And after the patient is totally asymptomatic and follow up ultrasound, and there is no evidence of residual or recurrent pseudoaneurysm here. So, what I would like to say here is an adductor canal pseudoaneurysm is very rare, potentially serious condition because of the stretches that are present in the adductor canal. It can have vascular neurological problems, and because the blood is collected in the sac, early detection is essential and can be treated with the thrombin injection. Thank you.
Thank you, Dr. Ashokan, for this wonderful presentation. Just for the benefit of some of the fellows here, can you explain the technique of thrombin injection, which is very important?
Thrombin is available in India is around 1 ml is 500 international units. So you have to use the small needle if it's a radial. You can use a 28 gauge needle and femoral 24 to 25 gauge needle. Then you have to do the thrombin injection under ultrasound guidance. You can see the needle, and before you inject, you should not use the color Doppler so that you can clearly see the jet from the pseudoaneurysm sac, and inject the thrombin away from the neck of the pseudoaneurysm slowly, 0.3 or 0.4 ml. Then wait for a few seconds, then inject further, and maximum say 1 or 1.5 ml, not more than that. And the other complication here is the thrombus formation in the native artery. And if it occurs, immediately to give heparin, and you call the surgeons and go for the thrombectomy.
Thrombin has to be pushed by saline?
Actually, you can dilute it, but even 100 ml, 100 units per ml, that's enough, sir. So you need not dilute it. You can take 2 cc syringe and inject it.
Initially, thrombin has to be there, then it has to be pushed with the help of saline. Small amount, very small amount of saline. That is what. Otherwise, it will stick in the needle, and the needle will get entangled.
So before that, you can inject the saline, see that the site, then inject the thrombin, and not maybe 0.5 or 1 cc saline, not more than that. Otherwise, it may leak into the arteries.
Thank you, Dr. Ashokan. Now we go on to the next presentation on the renal artery stenting by Dr. Saurabh Kumar Singh from Delhi.
Good evening, everyone. So I'll be presenting on renal artery stenting. So this is our case, like he's 70-year-old male with uncontrolled hypertension with multiple hospitalization for hypertension urgency with no other comorbidities, with BP of 186 by 90 at presentation, and systemic examination was normal. And he was initially on ARBs, CCB, beta blockers, and diuretics, MRAs, but patient developed AKI in the course, and then he was switched to CCB, beta blockers, and clonidine. His urine routine examination was done, suggested to have proteinuria and urine microbiome present, and he has AKI, and echo was suggestive of normal LV function. So, and this was his ultrasound bilateral kidneys. We can see left kidney was relatively normal size, but CMD was maintained, but right kidney could not be visualized. So CT angio was done, suggestive of atrophic right kidney, and the left kidney was normal in size with no evidence of hydronephrosis, but right renal artery was not visualized as was in ultrasound and suggestive of chronic thrombosis. And left renal artery stenosis was present at the origin from aorta for the length of 2.6 millimeter, along with soft tissue we can see. So The renal angiogram was done from the right femoral arterial axis, and we took the left renal angiography. You can see there is critical stenosis from the ostia, and the JR guiding catheter was taken, and the whisper wire was taken to cross the lesion, and with the no touch technique, another wire was kept parallel in the aorta to prevent any atheroembolism or the plaque erosion, and the lesion was crossed with the whisper wire, and then dilation was done. Balloon dilatation was done initially with the smaller balloon, and on repeat injection we shows partially dilated artery. So again we pre-dilated with the 3 into 15 millimeter NC balloon, and the sizing was done. And then the Herculean Elite bare metal stent of 6 into 15 millimeter was placed under fluoro guidance with 2 millimeter stent hanging outside the ostium. And then we did PD with the 4 into 10 NC balloon, and the ostial flaring was done. And this was the final angiogram. And we also did the coronary angiography. A patient has peripheral arterial disease, and so we can see there was RCS CTO. So basically, this case, like the renal artery stenosis, has a high prevalence in older patients and is frequently associated with resistant hypertension and impaired renal function and their attendant consequences. So renal ostial stenting is the most common endovascular intervention for the treatment of atherosclerotic renal artery stenosis. And ACC-HA guideline recommends percutaneous revascularization in patients with hemodynamically significant renal artery stenosis with recurrent unexplained CHF, sudden and unexplained pulmonary edema, and the class 1 indication. And the two most common indications for renal artery stenting are refractory hypertension and progressive renal insufficiency. Appropriate patient selection is the key for the optimal clinical outcome of the renal artery revascularization. Thank you.
Thank you, Dr. Saurabh. Because of the paucity of time, we will not have discussion. We go on to the next presentation by Dr. Mohan Paliwal, When Things Go Wrong, How to Manage.
Very good evening to all the chairperson. We had a case of 70-year-old gentleman, known case of systemic hypertension and pre-diabetic on medication, presented to us with complaints of dyspnea on exertion, class 2 to 3 since last 3 years. Patient also had past history of 3-time hospital admission for acute left ventricular failure during last year. His CAG was done in 2022, was suggestive of normal coronaries with T-MET2 flow and was treated as a non-obstructive coronary artery disease. This time we again planned to rule out coronary artery disease and found he had LAD osteoproximal 80% lesion. Also renal angio was also planned because of recurrent LVF as his EF was 60. We found that right renal ostial was 90% disease was there and left was normal, and UHG was suggestive of normal size kidney with maintained CM differentiation. Hence, the plan was to treat renal and coronary vessel in the same setting was made. Lab parameters were normal. HB was 16.7 and creatinine was within normal limits. So routine PTCA to LAD was done with TIMI2 flow. So we went ahead for renal angioplasty. Right femoral artery puncture was taken. 7 French sheath was inserted, and right renal was engaged, and with renal diagnostic catheter 3.5 French, and shoot was taken suggestive of 80% lesion was there. We thought it was a routine procedure, so we went ahead with pre-dilatation. The lesion was crossed with Fielder FC, and went ahead with pre-dilatation with 2.5 by 12 balloon, and Renofit stent 6 by 15 mm we negotiated, and its position was confirmed. And we thought we would come out, we would inflate and just come out easily. But the stent balloon got ruptured before inflating the stent at 2-3 atmosphere only, and the stent was not able to inflate properly, as you can clearly see in the first fluoro. The multiple attempts were made to recross through the stent with different wire, but we were not able to cross the as the balloon was stuck inside the stent only, and it was under inflated stent. Wire could not be crossed through the middle portion due to the stuck balloon. Wire was crossed through the struts, but we tried to negotiate a small balloon over it. But as the stent was unexpanded, the struts were not open, and the balloon, even small balloon, was also not able to cross it. Again, we tried to give some jars, but it was not assembly was not coming out. So what we did, we cut the distal end of the system, and we railed over the guide liner to trap the balloon and the system. But again, we tried, but it didn't work. And while trying all these, the balloon shaft also got broken. Wire was still inside. So actually, we tried almost the whatever the thing that guideline has said. So we tried to we pull it off, but it didn't come. We tried to recross another wire through the center, but it was not going. And we crossed through the stud, but balloon was not going. Then we used the guide liner, but the trapping technique didn't work. Then during this the shaft got broken. We again tried the bioptome. The fluoro is not saved actually, so it was not still it didn't come. So finally we compared the remains of the balloon catheter with the same type of balloon from the same company, and noticed that the balloon shaft was broken precisely at its junction with the catheter. So we decided to leave it at the same place, and finally after so many failure we thought of crushing the stent and balloon with a new stent. So we took another puncture from left common femoral artery, and 7F sheath was inserted, and again the guide was engaged. Uh, and a new wire was placed. The renal artery was engaged with a new wire, and a small. We pre-dilated first with small balloon 1.5 by 10. Then we crushed with a larger coronary balloon 3.5 by 10, and stent crushed at the ostium to facilitate the new entry, new entry of the stent. And this time we took a larger stent of 7 by 15 across the lesion, and position was confirmed and it was inflated. And also we did the osteoproximal planning also. So you can see here for the final should suggest you of good result with the crushed stent. And we left the balloon. The balloon was partially inside the renal, and partially inside the aorta hanging. We left it there. So the guidelines for there are guidelines for coronary that we only applied because there are no clear guidelines for renal complications, and that's it. And that we know. Thank you.
So you are trying to dilate the stent, your
Sure.
balloon ruptured, right?
Sorry, sir.
You are trying to dilate the stent, your balloon ruptured. First one.
Yeah, sir, it was a balloon mounted stent, and just
Balloon
yeah.
ruptured.
Yes, sir.
So you could not withdraw the balloon.
No, sir.
Because it was entangled into the stent.
Right, sir.
This was the problem.
Yes, sir.
So you tried to pull it, it didn't come out. Then you tried a guide liner by cutting the shaft of the balloon.
Right,
You did not do it. Most of the time, balloon is broken at the hinge point. You know where the rapid exchange wire comes out. What you can do is take one more wire in the guiding, take the balloon and trap it proximally. Then once you have the force which is much closer to the broken thing, that will definitely come out. So this is called entrapment technique, what we use in the CTO.
Right, sir.
Entrap the balloon shaft proximal at the just guiding ostium with another balloon inflated outside the shaft of the broken balloon, then will entrap it, comes out.
Right.
Second thing is, once you are pulling it, try to push the guiding so that it comes that way. Now, you left the broken balloon half into the aorta, and broken balloon and stent was crushed there.
Yes.
What do you feel is going to long term happen to this broken balloon shaft and the stent, which is
Sir, but it was anyway, it was stuck only previously only, and this time also we plastered it with the new stent.
but
Actually,
if
it will
half
not
of the balloon is hanging into the aorta, half of the broken shaft and the balloon is
sir,
hanging
actually
into the
the
aorta.
balloon got due to multiple attempts, the balloon got elongated, sir. Actually, kind of.
But
Yes.
that's where shaft is hanging into the
Yes, sir.
aorta.
Yes, sir.
One can also go over the balloon and snare it out, as was done by Dr. Trehan in the previous case, with the balloon, or balloon along with the stent can be snared out. That may prevent the foreign body, and then you can put in a fresh stent and the balloon there.
Right.
Next case.
Basic concept is you should try to put the force as near to the broken thing as possible. That's by entrapment or with a snare, whatever it is. Yeah, next.
What could be the reason for balloon ruptured at such a low pressure?
Sir, actually, actually we thought there has to be some calcium or something like that. But when we inflated the newer stent, it inflated easily. Actually, there was no.
That's why I'm asking this question. What
Sir,
could be the
maybe,
reason? Because you pre-dilated the lesion as well.
Right, sir.
Yeah, but again, the balloon ruptured at such a low pressure of 2-3 atmosphere,
Right,
like you've
sir.
told.
Maybe.
This is something.
Maybe manufacturing defect, sir. I don't know. Sure. Thanks,
Yeah.
sir.
Next is Ajay Joshi. He is going to present renal artery stenting nightmare when innovation saved the day.
Good evening, everybody. I have no disclosures, and this happened at Udaipur when I was posted in 2022. And a young lady came, hypothyroid, history of prenatal hypertension, blurring
Because
of
we're
the
running short of time, just
Yes,
shortcut
sir.
the history, come
And
to comprehend
she
directly. So
was
we can
on
learn
3
from that.
antihypertensives, hypertensive, and this was a renal angiogram. And this we felt was 70 to 80%, but significantly tight. And we found it's downward and rightward, upward oriented artery. And we thought we'll just go for direct stenting. We took the guide, DRC, and took the wire across and tried to deploy a 7 into 15 stent. And the stent slipped forward. And probably the operator was quickly inflated, and it didn't slowly inflate, and the stent had gone. Now what to do? Now the stent balloon was out. Now should we pre-dilate now? I did not. I thought probably dissection, we will not be able to manage with the guide support and the wire. We got the balloon out, took another stent, which was just 615. We never had a 715 on the shelf. Now see next what happens. The nightmare is unfolding. This stent slips backward, and there's a geographical miss. So now in this whole era of geographical miss, trying to deploy one more stent through into geographical miss with a guide, like with the guidezilla, the wire came out. Now the wire is not going through the main lumen of the proximal stent. Now what's happening is we are trying to wire, but the whole stent is now getting, the proximal stent is now getting deformed. And in this whole aggressive maneuvering of the proximal stent dislodges and then reaches the left external iliac. So the stent has migrated, and what we tried, we took a 7 French sheath on the left side and tried to snare this. This was a snare system which we had, a 7 millimeter 3 French snare, tried to snare it out from the left side with all the techniques possible, proximal, distal, with the buddy wire along. Tried the splitting end of the sheath, it didn't work. And then what happened, because of manipulation, the mangled stent came onto the right side. So again, with the same techniques, we started taking a buddy wire across, trying. But the problem which was now occurring, we didn't have an 8 French sheath, and it was all getting stuck in the mouth of the sheath. And this was Udhampur, and we had a vascular surgeon who was very keen to open, but we had something in the shelf for ETO. We tried all our tricks, nothing was happening. So in our cath lab, we used to have these crocodile alligator forceps, and which were actually for retrieval of the stones from the ureter. They used to come to cath lab for ETO, and our technician suggested it, and this is what we did. We took this across. It was just a 5 French alligator for something like bioptome, but with a better grip. And then, as you can see, it came out very easily inside the. It had a slip, but then it came out easily. I was able to. The problem was at the mouth of the sheath, and then finally this thing came inside. The problem occurs that the mask gets mangled. It becomes very difficult to get it inside. So finally, I got it inside, and which I can show in the next video on the right. You can see the thing had come inside, and then finally, after I retrieved it, this was the mangled renal stent. We did an angiogram again, and then we deployed a 718, and this was the final angiogram. And this patient, after follow-up with the CT, is doing well, and the two overlap stents are well opposed, and the patient is just on single antihypertensive. So now I say it's a deceptively simple procedure. One has to be a little stubborn. I had a lot of snaring to do, but the innovation with these alligator urology forceps saved the day for me. And probably I should have pre-dilated. Initially, the guy should have not inflated the first stent very quickly. And a firm guide support will always prevent renal stent slip. And you should always have different type of snares. You should well versed with snaring techniques. And if possible, one can always have these alligator forceps to prevent an open cut down. Thank you for patient listening.
Yeah, thank you very much. Nice presentation. I would like to comment one point. Whenever you have to place the renal stent, the guide has to be coaxial with the renal artery.
Yeah.
Most of the time it slips because the guide is not coaxial with the renal artery. So whenever you are going to inflate the stent, just give a slight push to the guide so that it becomes coaxial with the renal artery. So the chances of slipping out the stent will be
Chances
very,
are
very
always less.
less.
And sometimes the anatomy, which I later on searched, there are different type of anatomy, the downward, outward anatomy, and probably a very slow evolution. Sometimes guide too much inside also will push the stent proximally, sometimes too proximal. But I think at the time of deployment, one has to be little slower and yeah, dog booking occurs, and then you go at very high pressure.
So better pre-dilated.
Yeah,
Better
better,
pre-dilated.
better.
Thank you very
Initially,
much.
it was initially looking that I'll
Javasar.
get away with a 7 into 15, but I should have used a cutting balloon or a high pressure 4NC, and then would have done.
Thank you very much. Wonderful presentation. Thank you. Now, the stalwart, Dr. Raman Chawla is
See,
here.
I will not be talking much about the history. Patient of recurrent TIAs, forget it now. This was the lesion. Carotid artery angioplasty, this was a lesion, ulcerated eccentric. Lot of toxicity was there. Crossed with the wire. Crossed with the wire. I was planning to put the filter inside. Filter was put in, and I was trying to put the stenting down. Significant toxicity was there. I was trying to push the stent. Now, what happened? Stent was being pushed into external carotid artery. Anybody realize what happened? Filter got broken. Filter is hanging into internal carotid artery, which is already opened up, and part of the wire is in common carotid artery. The filter is broken, lying free, opened up into internal carotid artery. Now I have to take the filter out. I have to take the stent as well as the broken wire out in one go. So finally, my filter is lying free into internal carotid artery, which is opened up. A lot of toxicity. It got broken. I was trying to push direct stenting on tortuous internal carotid artery. So I thought I'll remove the filter by intertwining wires. So one wire is already into it. I was trying to put the second wire into internal carotid artery, trying to intertwine it. It did not work. So I was trying to intertwine the wires. It did not work. So I thought, let me use snare. So I was trying to use gooseneck snare to catch hold the proximal end of the broken filter. My gooseneck snare could not reach common carotid artery in the place where the wire was broken. So trying to put it, it was not coming. Next plan was intertwining wire from the common carotid artery. So I am trying to intertwine the wire in common carotid artery, trying to protect the filter out. Tried multiple times. I have tried at least 4 wires. It did not work, not moving at all. Now tell me what options we have. This is why Dr. Train to be here. He said he can take everything out. Any suggestion? I will not be late. Any suggestions? Okay. So I thought I'll take the coronary snare into internal carotid artery. So plan to snare filter from the internal carotid artery by using coronary snare. As it was a lot of toxicity, I used budding wire in external carotid artery to take the filter, to take the snare into internal carotid artery. So I was trying to put snare into internal carotid artery. This is very difficult, a lot of toxicity. I finally went into internal carotid artery and trying to snare it again. A lot of difficulty in reaching that. I failed again. I tried multiple times. I could not catch hold of filter. See, you can see I'm trying to catch hold of filter, take the wire out. Nothing is working. Again, trying to put it, go forward, backward, but nothing is working. Any suggestion at this time? Okay. So I said, finally, why not intertwine the filter wire, and the snare together? So now my snare is at the point where the filter is already opened up. Now I'm trying to intertwine the snare within my hand, one wire, so that trying to catch hold of like multiple intertwining wire, which was a filter. So I'm trying to hold that. Finally, I was able to intertwine the filter by rotating the snare itself along with the wire, and collapsed filter was taken out without any damage to carotid artery. I did not retrieve filter in aorta. I thought I will retrieve it in iliac artery so that filter does not go back. That's why I did not put it back into the sheet from the aorta. So filter was retrieved into the sheet from external iliac artery, and then finally it was taken out. And I did check angio again. Nothing has changed. Patient was fine. So this was a DSA, which showed everything was fine. So do not underestimate tortuous to carotid artery. Avoid direct stenting if possible. But I am almost always prefer direct stenting in carotid artery. I don't want to pre-dilate unless I'm looking for hyperperfusion syndrome, where it's preferable to always pre-dilate so brain get used to the increased blood supply. Avoid direct stenting. Be very focused. Avoid direct stenting with a closed cell design. Rogan filter is a dreaded combination. I don't think there was any other way to take it out. This was the only way I could have taken out. If there any situation, they're most welcome. Thanks. Thanks for your patience hearing. Thank you.
Thank you, Dr. Chawla. Then ultimately you stented, put in another stent into the internal carotid or left it? Not left. Next presentation, Dr. Khanna. Or, okay, Dr. Trehan has already done. So we are done with this session, I think. Thank you everybody for such wonderful cases and the panelists for such wonderful discussion. I think we have an important presentation, Dr. Suresh Sarwale from Nagpur. Dr. Suresh, please.
So good evening to all of you. Myself, Dr. Suresh Sarwade from Nagpur, going to present an unusual exercise complication of percutaneous coronary intervention. So we had a patient of 62-year-old male diabetic hypertensive smoker, had typical chest pain for 1 day, was hemodynamically stable, ECG suggestive of anterior wall ischemia, echo suggestive of LAD territory hypokinetic with 40% of ejection fraction. So because of radial pulses were feeble, so we did his angio from the femoral root suggestive of single vessel disease of LAD. So plan was PTCA to LAD with true drug-eluting stent. But on second day, we found in the right groin there was a swelling, tenderness, there was thrill present, on auscultation continuous murmur, DPPTA was normal. So provisional diagnosis of right femoral AV fistula was made. From the left femoral root, we did his angioplasty with true drug-eluting stent. While coming out, we took check shoot of the right femoral showing there was a communication between right common femoral artery and femoral vein, suggestive of right femoral, right AV fistula. So here you can see that there is a communication, 3 mm fistula tract between femoral artery and vein. So options were like whether endovascular repair or surgical closure. So plan was endovascular repair with covered stent. So by using left femoral root with 10 French sheath size, we inserted self-expanding fluency plus vascular stent graft of 10 by 18 mm size, with also preserving the profunda. As we know, CAG is most effective method for diagnosis and treatment of CAD. Like every interventional procedure, some complications may arise even if the operator experience is sufficient. Incidence is being less than 0.08% of it. It can happen by simultaneous drilling of both artery and vein by the needle. So as we know, the safest zone to puncture is located from 1 to 2 centimeter below the inguinal ligament and above femoral bifurcation. These are the different method to ascertain this location. Almost 60% use this palpatory method, 11% use fluoroscopic method, and only 2% use ultrasound guided puncture. But those who use that last one found at 95% decrease in complication rate. So these are the risk factor for development of these complications. So you can diagnose by clinical examination as well as angiography and ultrasound. So if not treated, they can lead to cardiac insufficiency, edema, local aneurysm, ischemia distal to limb according to size and duration of the shunt. Although there are no clear criteria for treatment of approach, endovascular surgical intervention is must in symptomatic patient, those with high output heart failure, size more than 3 mm, and those fistulas are not closing in first within 1 year. Endovascular method have advantage of early mobilization, short hospital stay, and less risk of infection. Surgery can be done like ligation, revision, and patch repair. So take home message is accurate puncture technique is important. If possible, imaging guided is always best. Adequate compression for satisfactory initial hemostasis is must. And some complications are unavoidable, but early recognition and intervention is the key. Thank you.
Thank you, Dr. Suresh, for such good presentation. I think we have to go on to the next session, 23, for the guest lectures.
The topic for this session is guest lecture. The expert panelists for this session are Varun Bansal, Sushant Mishra, V.H. Natesh, Dinesh Kapoor, Jacques Bousquet, Nitish Anchal, Ajit Jain, and S. Azharuddin. May we now request Dr. E.P. Jain and Frank Beat to come on stage and deliver their presentation.
Good morning, or good evening. Thank you for the invitation to present our work today. Our work is entitled Long-Term Multicenter Outcomes Show Prosthetic Bypasses to Tibial and Peroneal Arteries Are Worthwhile.
Sir, you can start your presentation. Are you able to hear us?
Can you hear it?
Yeah.
Okay. The peripheral arterial disease and its most common presentation, chronic ill-threatening ischemia, are increasing globally at alarming rates, driven largely by a sharp increase in diabetes, metabolic syndrome, and increasing pace of population aging. Currently, about 230 million people worldwide have PAD, and 11% or 25 million suffer from CLTI. Given the lack of effective medical therapy, revascularization represents the cornerstone of treatments with the primary treatment goal of relieving ischemic rest pain, healing ischemic tissue loss, and preserving limbs. In the absence of level 1 evidence, CLTI care has been marked by substantial treatment variability and heavy reliance on treatment bias of individual providers. While surgical bypass has been the gold standard therapy for the better part of the last 6 decades, endovascular treatments have become increasingly utilized. Spurred in part by ongoing technological advances, many have adopted endovascular first approach. Against this backdrop, it is critical that we understand the impact of commonly used surgical and endovascular revascularization techniques. The BEST ELI trial was conceived to address the critical shortage of high-quality data guiding therapeutic decision-making for the treatment of the CLTI. The BEST ELI was a prospective, randomized, multi-center, multi-specialty, pragmatic clinical trial to compare the clinical effectiveness functional outcomes, cost, and cost effectiveness in patients with CLTI and infrainguinal PAD were candidates for both open surgical bypass and endovascular therapy. The trial has a number of clear messages. For patients with CLTI considered candidate for both open and surgical and endovascular therapy, surgery was significantly more effective at preventing major adverse limb events, avoiding reintervention and preserving limbs. In patients with and without an adequate segment of saphenous vein, both open surgery and endovascular therapies are safe and effective with equally low level of peri-procedural stroke, MI, and stroke. However, many patients with CLTI lacks adequate autogenous conduit. The use of the PTFE conduits for bypass for infrapopliteal arterial targets was first described in 1978 as a treatment for CLTI in patients facing imminent major amputation but lacking suitable autogenous vein conduit. These procedures represent an aggressive limb salvage strategy for both diabetic and non-diabetic patients. Early studies demonstrated promising outcomes with infrapopliteal PTFE bypass. However, over time, their use declined due to suboptimal results at many centers, and evidence from randomized controlled trials showed inferior long-term patency compared to autogenous vein bypasses. Recently, there have been renewed interest in PTFA bypass for patients with limited revascularization options, particularly those at risk of major amputation. Despite some favorable reports, PTFA bypass is generally considered suboptimal option for revascularization. For this, we wanted to evaluate long-term outcomes of the infrapopliteal PTFA bypass for limb salvage in patients with a CLTI. So we looked at all the patients undergoing infrapopliteal PTFA bypass for CLTI at two major academic centers in the United States from 2001 to 2018. These included VA Western New York Healthcare System and Northwell Healthcare System in New York. Every patient underwent either arteriography, CT angiogram, or arterial duplex ultrasonography. Those that were ineligible for endovascular or autogenous vein bypass were included for the study. Patients with a missing follow-up outcomes were excluded. The primary outcome was a primary bypass patency at 4 years and secondary bypass patency at 4 years. Secondary outcome included limb salvage, major amputation-free survival, and overall patient survival at 4 years. Surgical techniques vary between amongst the surgeons, but adhere to the core principle of ventricular technique. Bypasses were performed with or without adjunctive distal anastomotic vein patch, plain or heparin-bonded PTFE grafts with or without external support rings were utilized. Distal anastomosis measured between 1.5 to 4 centimeters in length, and they were constructed with evenly spaced fine sutures, ensuring incorporation of all arterial wall layers. Proper graft tunneling was utilized to ensure and prevent kinking, tension, and twisting. Completion arteriography or duplex ultrasonography was routinely performed to confirm adequate prograde and retrograde flow. Identified defect or vasospasms were addressed using a pharmacologic agent or surgical revision with angiographic verification of the final result. A total of 110 patients underwent infrapopliteal PTFE bypass for CLTI. This table summarizes demographic characteristics, comorbidities, and clinical presentation. The mean age was 72 years, and 86% patients were male. 77 patients had tissue loss consisting of ischemic ulcers or gangrene. The most common comorbidity was hypertension, followed by hyperlipidemia, diabetes, CAD, CKD, and COPD. Active smokers accounted for 26% of the cohort. 41% had undergone prior ipsilateral revascularization, including 27% with failed bypass and 14% with the failed endovascular interventions. All patients had significant perfusion deficits with advanced ischemic wounds or severe vest pain, and they were facing imminent major amputation. The most common inflow artery was a common femoral artery, followed by external iliac artery and 5% popliteal and deep femoral arteries. The outflow targets included most commonly perineal artery and 40%, followed by posterior tibial artery and the anterior tibial artery. Heparin-bonded PTFE grafts were used in 64% of the cases, with a distal pre-cuff PTFE in 22% and standard PTFE in 14%. The 30-day mortality was 4.5, and early graft failure occurred in 12% within 30 days. Postoperative antithrombotic therapy included warfarin alone in 22%, warfarin plus antiplatelet therapy in 27%, and antiplatelet agents only 37%. The mean follow-up was 48.5 months. It ranged between 0 to 259 months. The primary patency at 4 years was 38%. Secondary patency at the same interval was 45%. The freedom from major amputation was 63%, while the amputation-free survival was 30%. The overall patient survival at 4 years was approximately 48%. Among the 37 major amputations that were recorded, 76% followed graft occlusion, 13.5% were due to graft infection, and the remainder was performed despite patent bypass. This is a patient, 72-year-old male with external iliac artery to perineal artery bypass with PTFE that maintained patency at 13 years. This is a patient of a 68-year-old male with external iliac artery to contralateral anterior tibial artery bypass with PTFE that maintained patency at 5.5 years. This is a 70-year-old patient with a common femoral artery to posterior tibial artery bypass with a PTFE and a distal vein patch that maintained patency at 6.4 years. Finally, this is an angiography of a patent bypass to an isolated segment of the posterior tibial artery below the ankle joint that maintained the secondary patency at 6 years. The current study of patients with CLTI undergoing intrapopliteal PTFA bypass with up to 13-year follow-up supports the continued use of a PTFA bypass as a valuable option for limb salvage in high-risk patients without alternative revascularization options. These findings are particularly meaningful as they reflect outcomes from diverse institutions employing various techniques and types of PTA graft, which enhances the generability of the result. Autogenous great saphenous vein is a conduit of choice for lower extremity bypass. However, many patients with CLTI who are appropriate candidate for limb salvage interventions do not have adequate conduit. Other patients may have severe comorbidity options and would benefit from a quick operation that avoids the time and the trauma of vein harvesting. For these patients, PTFE graft are reliable and a commonly used prosthetic bypass for lower extremity bypass. Our 4-year all-cause survival of 45% underscores the high competing risk of death in patients with CLTI. The benefit of limb salvage extends beyond the immediate clinical outcomes. Patients undergoing successful revascularization often experience better survival rates and lower healthcare costs compared with those requiring major amputation. The recent data have shown alarming 50% increase in amputation rate among diabetic patients from 2009 to 2015, reversing the prior 30% decline attributed to the advancement in endovascular interventions. This underscores the importance of aggressive revascularization strategies such as PTFE bypass in reversing the troubling trend and improving the patient outcomes. Reticular surgical technique is crucial for optimal outcomes during the infrapopliteal PTFE bypass. Precise placement of sutures, preservation of adequate flow in the target artery, and thorough completion angiography to confirm the technical adequacy are essential. Additional interventions such as a local intraarterial administration of papaverine or nitroglycerin or correction of anastomotic defects may further optimize intraoperative result. Other adjuncts such as distal vein patch may also improve patency of the prosthetic graft, although the data are limited in scope and quality. In our series, these adjuncts were employed based on the surgeon preference with comparable outcomes achieved with or without their use. The limitation of our study includes a retrospective design and the inherent selection bias associated with contributing centers, variability in graft type, surgical technique, perioperative medications, and postoperative surveillance further limits the generability of the findings. However, the heterogeneous findings also reflect the real-world clinical practice. The patients treated at different era with different surgical techniques, conduits, and postoperative regimen better represents the spectrum of management decisions faced by contemporary vascular surgeons treating high-risk CLTI patients. Our cohort illustrates practical challenges and outcomes across the institutions and provides a complementary insight that adds to clinical depth by demonstrating feasibility and utility of infrapopliteal PTFE bypass in select patients. In conclusion, patients with CLTI requiring infrapopliteal PTFA bypass were found to have a limited 4-year survival. Despite this, our 63% limb salvage and 45% secondary patency at 4 years demonstrate utility of PTF bypass in high-risk cohort with no other revascularization options. Among the long-term survivals, the majority avoided major amputation after successful revascularization, and this reinforces the clinical utility of the PTFE graft in appropriately selected patients. Contrary to prevailing perception, PTFE graft can be durable revascularization, and their use should be considered in carefully selected patients facing major amputation. Thank you for your attention.
Dr. Chang. Dr. Chang, I'm Dr. Jacques Busquet from Paris, France. I'm your moderator today. I'm a very good friend of Frank Wyss, and I really appreciate your presentation. As you know, the Basel trial shows the competitivity of a bypass compared to endovascular technique in the distal. So you are doing right, and you save legs. But I have a question. I've seen that you prefer arteriography, the classical arteriography, either diagnostic or control for control instead of CTA. I have the same way to do. What is your position? Give me your feeling.
Yeah, thank you for the question. I mean, personally, I prefer the angiography over the CT angiogram. I think, our practice really depends on the availability of the CT scan and how quickly it can be utilized in these patients with CLTI, because a lot of these patients require a semi-elective procedure, and the place I work does have availability to the cath lab where we can actually do this angiography. And I think it's quite helpful, especially when we're dealing with patients with a tibial disease where the contrast may not wash all the way down to the tibial vessels when these patients get the CT angiogram, especially if they have a long segment, femoral popliteal occlusion. So I do prefer arteriography as an intervention, as a diagnostic way, so that I can look at the outflow and the caliber of it, and which level I could perform a bypass to. But I think CT angiogram could provide similar pictures, but it may not give as good of a picture in these patients with a long segment femoral popliteal occlusion that has a small tibial vessels.
I agree totally with you. By the way, Dr. Chang, you are a very good presenter. Where do you work, Montefiore or somewhere else?
I work at Hackensack University Medical Center in New Jersey.
So how do you know Professor Wyss?
I trained at NYU where he was the professor there. I was involved with multiple researches, and I actually am currently working on multiple projects with him.
So you know Enrico?
Of course.
I know him very well. I admitted him in the French Academy of Surgery recently. He was very proud of that. And I will probably see you personally in November for the Frank Wyss. Will you be there?
Yes, I'll have a couple talks to present at the meeting.
If you see me in the platform, you say hello to me.
Of course, I will. I'll find you.
Is there any other question so we can stop with Dr. Chang, who is probably very busy? No, it's okay. Everybody is happy of your conference. Here we are live in New Delhi, not New Orleans, New Delhi. And see you soon, Dr. Chang. Thank you very much.
Thank you for the opportunity again. And I watched a couple shows, and it's been great presentation. So thank you very much again.
Thank you, Dr. Chang.
May we now request Dr. Subhash Chandra to come on stage and deliver their presentation.
Thank you, Chairperson, and thanks to Dr. Khanna for inviting me to deliver this talk. This is to deal with coronaries, and I'll highlight the new tools in the domain of coronary angioplasty. So we know that in India, in particular, the coronary artery disease happens a decade earlier than West, and alarming proportion. The other facts are that when you put permanent implants as in stents, there's a 2% attrition rate in terms of MACE, and at the end of 5 years, almost 10 to 20% patient will succumb to high MACE and stent thrombosis. We also know that if a patient has ISR and there are two layers of ISR, the eventual process is bypass surgery and not repeat PCIs. And the long stented lesions obviously invite high rate of stent thrombosis, death, and myocardial infarction at the end of 3 years. And as per the bifurcation club, 20% of PCIs have bifurcation, of which almost one-fourth require two stents. Finally, as per the National Intervention Council, 1 out of 3 cases have multivessel disease, which majority of them are going for bypass surgery, but few are not eligible for bypass, and therefore angioplasty is the only option left. When it comes to fixing stents, it's not about just fixing the holes, but actually approximating them closely and hence making them customized to patient's need. So if you look at these classical patients in our practice, this is a classical type A lesion in a young smoker and single vessel disease. The artery has different sizes and a tapered artery. The case 2 has a 57-year-old female, has significant LED D1 bifurcation where it's a kind of dual LED lesion. And we definitely need tools here which can salvage the side branch in the bifurcation lesion as in Medina class 111. So, and lastly, the cases which have long diffuse disease, hypertensive patients, elderly, triple vessel disease, sometimes not eligible for bypass, and they come to us for angioplasty. And for all this, you need customized approach. It could be ranging from doing a metal-less angioplasty or using drug-coated balloon or having dedicated bifurcation stents and of course tapering stents. And they all come from our own company, which is Merrill. The whole emphasis is on minimizing the metal load, but actually rationalizing it as to at which areas we can use metal and on which areas you could just use drug-coated balloon, which is the way forward. So if we know the history that Andreas Grundzig, who did first angioplasty in 77, the same patient came for a follow-up angiogram. It was a plain balloon angioplasty, and the vessel is actually underwent negative remodeling. It has grown in size. So balloon angioplasty has a place, provided it is done diligently. And of course, later on, the stents came. But these metallic stents had its own problem in terms of losing the vasomotion of the vessel. And if ISR happens for future surgery, surgeon is not able to put distal grafts on these. And there are problems of the polymer leading to late and very late stent thrombosis. This slide is taken from the BRS era where Absorb came, and when these patients were follow up, it was seen that on account of negative remodeling, the luminal area is actually growing, as you see in the last column of 7.3. So that is the beauty of using BRS. Unfortunately, that technique and the technology fizzled out because of various reasons, where stent thrombosis was high in this 150 micron scaffold, and therefore these were the problems with that BVS scaffold, which was given to us and lasted for good 6 to 7 years in our practice. So to overcome them, Merrill came out with a novel tool, which was a 100 micron scaffold. In profile, it was very nicely deliverable. It was nicely visible because there were 3 dots incorporated both the ends. There was a huge size matrix to choose from, and overlap was possible. Storage conditions were not as stringent as was the case with Absorb, and there was better outcome as studied in our own national trial. So thin strut, improved mechanical property, PSP, which I'll tell you in the next slide, where preparation of bed, proper sizing, and post dilatation with higher size balloon is the key to ensure good outcome. And of course, imaging guided implantation of these scaffolds, of course, requiring prolonged DAPT because it takes almost 3 years for these scaffold to absorb from the coronary tree. So this is the scaffold where 24% scaffold to artery ratio, so not much of PLLA in the artery, with a good radial strength, 100 micron, and the trademark Merrill were closed cell design at the end and open cell in the center, enabling the side branch access and bifurcation properly. And this is from the animal data. At the end of 3 years, nothing is left behind in the artery. And this is being asked by the general public and society more and more, that I don't want any metal in my coronary tree. So therefore, BVS and the drug-coated balloon is the way forward. And I'm just touching upon those. This is the study which was conducted in our country on this BVS. And to our surprise, the MACE rate are almost comparable or even better than the metallic stents. So this is PSP. Prepare the lesion well with 1:1 balloon. Size the scaffold the artery by doing some kind of imaging, preferably OCT or an IVS. And once you're deployed, then use a 0.5 millimeter high size balloon. Go full hog, high pressure, so that you ensure that the scaffold is nicely apposed into the wall and there are no loose struts of the scaffold. And that prevents the stent thrombosis and MACE. I'll just show you classical cases because in my experience, I've started just using them on the type A lesion, learning from our experience from uh, BVS absorb. And this is the type A LED proximal lesion, which was pre-dilated with 1:1 size balloon. And then a 3.529 Meres 100 from Merrill was chosen to be placed here. And you see the scaffold is nicely seen because there are 3 dots incorporated at both the ends. Once done, then 4 into 15 NC balloon was chosen for post-dilatation. And after this post-dilatation, an OCT run was captured, which to our surprise showed that there were some loose struts of the scaffold. And therefore, some more job needs to be done here to ensure that the MACE does not increase, stent thrombosis does not happen. So the same balloon was again inflated to very high pressure of 24. And having done that, we again captured a run. And this is the best result which we see. So today we are using this scaffold in our practice, backed by imaging at our disposal, either IVS or OCT preferably. One more type A lesion, as we see here, the same philosophy of 1:1 dilatation, 324 Meres 100, and then capturing an OCT run, a well-opposed BRS, as we see here. Having gone from the type A lesion, sometimes because of the high creatinine, OCT is not possible. So we have used even IVS in some of these cases. And that has given us exact dimension to predilate, prepare the bed. And in case there's a underlying fibrotic lesion, then Wolverine cutting balloon was chosen to prepare the bed. And then the BVS was implanted, as we see here, 3.529 Meres 100. And again, seeing it on the ultrasound that everything is nicely opposed. And that's the way we moved on to do some of the complex lesions, as in ostial lesions or the smaller vessels. And even there, we have seen the scaffold is nicely deliverable across the bends, as seen here in the circumflex. And then, of course, the best result here. Some of the large diagonals where pinching the main LED is an issue has also been addressed by using BVS in these cases. And this is one of those cases where a large diagonal was done by using BVS, and we are not worried about compromising the ostium of LED where the diagonals are arising from. And of course, there are OCT runs. So these are some of the cases which have been done with MERS 100. We are very nascent and early in our experience, and we are taking baby steps so that not to mess up this technique as we did in case of absorb. I suffice to say that the post-dilatation is the key, and imaging should be the part of most of these scaffolds which are being used in our practice. And I would urge confine it to type A lesion in the beginning. Don't go over to do complex lesion with this stuff. The next part of the talk is about drug-coated balloon. And as we know, the inherent advantage of these balloons is that there's a positive remodeling and late lumen gain. And the DAPT duration can be abbreviated, especially in high bleeding these patients or patients who have diabetes or long diffuse lesions. Two drugs are available. Paclitaxel is a drug which is hydrophobic, and therefore it sticks to the balloon. It has the largest data so far. It is approved in European guidelines for the in-stent restenosis treatment. However, sirolimus, which is a hydrophilic drug, is also coming up with great promise. And there are balloons in pipeline like sirolimus-eluting balloons. The trials are awaited. And this is a mosaic sirolimus-eluting balloon from Merrill, which again has been undergoing through trials. This 7 atmosphere is the minimal nominal pressure and 16 atmosphere burst pressure. And these drug-eluting balloons are being used for in-stent restenosis practice or smaller lesions, vessels, or diffuse lesions. The key is that you must prepare your bed very thoroughly, so much so that you can even cause type A dissection so that the drug nicely seeps into the intima and media and ensures that the long-term results are good. This is a case of instant restenosis on circumflex and LAD. So the circumflex bed was prepared and then drug-coated balloon was kept here for 60 seconds. Having done that, we went on to treat innocent restenosis of LAD, which is here, and treated the bed, and then again touched it with the longer drug-coated balloon. And this is the end result, which we see in the last run. So DCB technology is emerging. The future is open. Both paclitaxel and cellumus are showing promise. The future is for bifurcation PCI. The side branch can be treated. A small, long, diffuse disease or instant restenosis. So patients high bleeding risk, especially slated for future surgery, the non-cardiac surgery, are the situations where drug-coated balloons could also be used. Thank you so much.
Your overview, sir, was splendid. You speak of the history, you speak of the current trends, and you speak of what is new. The concept of left nothing behind seems to me very important to avoid the late stent thrombosis. I hope this bad incidents would disappear. And you didn't speak much of the new anticoagulation post-operative after the angioplasty. What is your preferred anticoagulation or antiplatelet therapy?
So if you're using the BVS in an elective non-ACS patient, the default strategy is to use clopidogrel and aspirin and use it beyond 1 year, preferably for 3 years. That's the time of absorption. So that is our strategy. If you're using an ACS situation, then ticagrelor aspirin in the first year, and thereafter 60 mg ticagrelor twice a day for next subsequent 2 years.
constitutes about 15% of all comers. And this is a very high-risk situation. Almost 50% of these patients will develop some cardiovascular complication in next 3 to 4 years, and most common being heart failure. So, well, what can we do? Even little steps can move mountains. Even with 5 millimeter mercury blood pressure drop, which doesn't seem like a lot, will reduce the cardiovascular events by 10%. So it's a huge gain just with little movement. Despite that knowledge, we have noticed that blood pressure control, even in resistant hypertension subgroup, is seen only in 50% of the patients. And why so? If we know it's so important, then why only 50% of our patients in hypertension realm are controlled? And there are many reasons to it. Most common reason is non-compliance. There is published data, not in one study, but multiple studies, that 50% of our patients don't take medications as prescribed, either totally or partially. And when we add another medication, since blood pressure is uncontrolled, like if I add 7th medication to that patient, compliance will go even further down. So that has been studied. So definitely that's not the answer we are looking for. Secondary hypertension workup is very important in these cases. So if you're already on 3rd and 4th medications, secondary hypertension workup should be done in 100% of the cases. If I would say the most yield is in primary hyperaldo. So a morning renin-aldosterone ratio is very important. And it is almost present in 30% of all comers who are presenting with resistant hypertension. Other test I would say would be renal artery ultrasound. You can pick up renal artery stenting. There was a fantastic session before us. And fibromuscular dysplasia, which is very common in young females. Other causes, I would say, if you have a suspicion, then look for it. It's a 10-minute presentation, so I'm speaking fast. I hope I'm clear. Another point I want to make is kidney is in right, left, and center of hypertension. And we owe it to our nephrologist. Kidney is a very intelligent organ. As it senses a decrease in volume or ischemia, it triggers a response, which is flight or fight kind of reaction from the brain, which leads to vasoconstriction, hypertrophy, arrhythmias, and then the brain would give renal efferent nerves, which would further ask kidney to retain more sodium and water, and thereby causing this cascade of flight and fight reaction, which is producing a lot of hypertension just as a mechanism for escape, not helping the body either. So this would be an easy thing to do, right? If it's all the game for sympathetic nervous system, what can be done? So let's take you to 1940s when there was no drug. If your blood pressure was above 200 systolic, you get sedatives. So barbiturates, or those were the treatment. At that time, patients who were symptomatic and have blood pressure above 200 systolic, there was a surgeon in Boston, Dr. Smithwick, who would do dorsolateral sympathectomy, knock off the whole dorsolateral sympathetic nervous system. And that procedure, though barbaric, was very effective. Mortality in the surgical subgroup was around 20%. And in medical subgroup, which was really nothing, was 56%. So you cut down mortality, a hard endpoint, by 1/3. Seems like a good idea if you don't have any other alternative. But it led to a lot of complications, drastic lowering of blood pressure, high perioperative mortality. So when the medication started coming in 1950s and 60s, then the procedure was abolished. However, it created a thought that if we could offer sympathectomy safely, it would be a good idea because the idea works. So then, if we realize from the dorsolumbar system, the renal nerves, they actually travel as a plexus around the renal arteries, as you can see in this diagram. And then they are present in 2 to 6 millimeter from the renal artery in the perinephric area, perirenal artery area in the fat. So if we can target this 2 to 6 millimeter, maybe we can target 30% of the sympathetic nervous system. And then 3 devices came into market. One was radio frequency based renal denervation, one is ultrasound based, and other is like alcohol septal ablation. You inject alcohol and the nerves will be burnt. Then this whole host of trials started in 2009. Lot of excitement. Simplicity 1 dropped blood pressure by 20 millimeter of mercury. Lots of companies invested into it. Then there was a trial which was led by Deepak Bhatt with a sham control arm. So everybody goes to the cath lab. Half of the patients do not get procedure, but they get groin puncture, and other half get renal denervation. Guess what? They could not show consistent benefit in dropping blood pressure. Then they realized technology has to improve, catheters have to be improved. And with the better technology, with multiple circumferential ablation and ultrasound-based ablation, by 2018, 2019, we had 4 trials, sham control trials, showing consistent benefit with no complications. So you have a better technology for all interventionalists in the room. It's fairly simple to wire the renal artery and denervate it. So simple procedure, no complications, a win-win situation. FDA approved in 2023 2 technologies, RDN and ultrasound-based. And the beautiful thing about this technology, if it works, is maximum coronary events or stroke happens early morning. This is a one-time procedure in lifetime of the patient, dropping blood pressure by 10 to 20 millimeters of mercury with the preservation of circadian rhythm. So early morning, there will be a dip. A nocturnal dip will be preserved. What about long term? So if you see in the red panel, that's short-term 6 months result. And in blue panel, it's long-term results. So as time passes, blood pressure control is even better. So if you had 10 millimeter benefit, then it'll be 20 to 30 millimeter benefit by 6 months. With improvement in cardiovascular events by 26%. So what happened to our patient? Despite being 82, all secondary workup was negative, so we took her for renal denervation. Wire the kidney, inflate the low pressure balloon with sterile water circulating, cooling down the intima so that you don't have renal artery stenosis or injury, and then denervate focus 2 to 6 millimeter. So you denervate at one spot and then repeat 3 more areas in 2 kidneys. One denervation takes 7 seconds. So procedure is fairly short. You are done within half an hour. These are pictures from our angiograms from our patient. Patient is doing very well. She was a hyper responder, dropped from 200 to 140, and is only on 1 medication, so dropped 5 medicines as well. So I would say that it's a third pillar in hypertension treatment and has been advocated by both European and American societies for control of resistant hypertension. Another thing I would like to mention, there's a new drug in the pipeline, and that technology will be more and more popular, which is siRNA interference. So as you all know, angiotensinogen is a precursor for angiotensin peptides, and we target that with many medications. So now there is an investigational agent which alters the siRNA, messenger RNA, and then it would reduce the blood pressure by 10 millimeter of mercury. This is not available for the clinical use, but this is like a vaccine. You give, patient will come every 6 months, you inject, then there is no issue of compliance. It will be effective for next 6 months. So very promising indeed. With that, I would conclude my presentation. Thank you very much for your time.
Thank you very much, Surabhi.
Thanks.
Can you stay?
Sure.
I've seen that you work in Sacramento.
Yeah.
In US Davis, so you are American.
Well, I'm Indian by heart. I'm Indian by birth,
But American. So do you know John Laird in
oh yeah.
is
John.
my good friend.
Oh, wonderful.
John is a pioneer like me. We began together like 30 years ago.
Wonderful.
Is he still active?
So he moved to Medtronic. We lost him to pharma.
For money or for spirit?
He's making good money.
Both. My question is very personal. As an American, do you consider your patient as an American doctor with respect of randomized trial, or like an Indian with a personal feeling?
I would say that, we have to live by data. See, this technology did not see the daylight. It was almost killed by 2012. And now we have 5 randomized controlled trials, sham controlled trials showing the benefit. So now this is prime time for this technology to be adopted. But I would say the gut feeling works at individual levels, but I think we have a responsibility to still follow the science.
Any other question on the panel for the lady? No. Oh, finally, yes.
And any potential, how do you assess for potential contraindications for renal denervation therapy?
Very good question. I didn't go into the detail because Dr. Khanna will be discussing the trials and renal denervation specifically. But renal artery stenosis is a contraindication, more than 50% for Medtronic and 30% for RECOR, the one case I showed. Renal failure, with GFR less than 30 is a contraindication. And any other secondary etiology which is uncorrected. So hyperaldo patient, till it is not corrected, will be first.
Thank you, Surabhi. We have to go on with the convener.
Thank you.
Dr. Khanna. He will move on the hypertension with denervation of the renal artery. You have 10 minutes.
So just to take this forward, some part in the concept building has already been done. Now, renal artery denervation, as Dr. Surabhi said, I used to be a proctor 15 years, 12 years back. And then, it was just a single catheter, 3-4 ablations, and I think Dr. KH would agree. We used it with a lot of hype, but eventually it did not really control the pressure. I think whatever achievement we had was a placebo effect, as we have seen in the trials with the new catheter. Now, if you look at it, what was the need? The need was that very few people, actually have a good control and a compliance of antihypertensive medication. At least 50% do not reach that criteria. And even if you reduce 10 millimeter of systolic pressure by any means, you actually get to 20% reduction in MACE and 13% reduction in all-cause mortality, be it of any cause. So it is very important to actually control blood pressure and not to take it lightly for long run. One of the ways is to neuromodulate or the autonomic nervous system, and we know there is a strong autonomic connection between the between the sympathetic and parasympathetic nerves which connect the brain and the kidney. And if you can alter this, we can actually influence the afferent and efferent channels and the nervous system and have less central sympathetic drive. Now, the new catheter is a spiral renal denervation system, which actually is a helical system, and it has an advantage that now it has four electrodes over 360 degrees, and it can be readjusted. And what it does, it actually takes care of all the renal arteries, nerves around the renal arteries. It's very simple, and the same catheter can be used for differential sizes of renal artery from 3 millimeter to 8 millimeter. And there have been various trials with this new, spiral hypertension clinical program. The first trial was in 2017, which was hypertension of medicine pilot study, where the medicines were stopped and you did a RDN, and we saw the effect. Then in 2018, we had spiral hypertension on pilot study, which was with medicines, and we saw that in both the pilot trials, there was a significant reduction of blood pressure, either as a primary therapy or over the medical therapy. Then came in pivotal trials in 2020 and 22. And again, these were of two types, on medicine trial and off medicine trial. And it actually found the same result. In the real world experience, we have more than 25,000 cases which have been performed by Medtronic RDN system. So again, if you look at the safety, it is a safe procedure. There was actually no complications except one femoral access complication. And what we see is both off medicine and on medicine, pivotal and pilot studies. What we see, there's about a 10 millimeter mercury reduction. And actually, if you look at the global registry looks at not 6 months data, but 3 years data. And the reduction is to the tune of 16 millimeter of mercury and about 20 millimeter of mercury. What is also very important, if you look at the circadian rhythm and you look at the blood pressure control over 24 hours, it is a sustained effect of blood pressure control. It does not have that sort of, peaks and troughs. The blood pressure control is very uniform over 24 hours. And as I told you, if you look at the safety data, only 0.4%, that is one patient, had a femoral artery excess complication, which was the operator's fault rather than any major issue. So it is a very safe procedure. There was no renal artery dissection. And for long-term safety, again, this has proved to be a very safe procedure, even when we are looking at all-cause death, MI, new strokes, hospitalization for hypertensive crisis, emergency vascular complication, major bleeding rates, and renal failure. And this shows that this effect is sustained in the global registry for, in terms of systolic and diastolic pressure, both in patients with chronic kidney disease and in patients with no chronic kidney disease. But we are looking, when we are saying that, we are looking at GFRs above 60. And what we are seeing here is over 3 years, there is a stable reduction of blood pressure, and the renal functions are also preserved for longer time. Just to give you how it looks like, so it's a spiral catheter with 4 electrodes, and it has a it has a unit which we call as RF generator. These two are connected by radio frequency, via telemetered and wired cables. When we treat these patients, we heparinize these patients, give them a light anesthesia. We keep them on dual antiplatelet therapy, sometimes even single antiplatelet therapy. We have a saline flush which is sort of continuously flushing the catheter, thereby taking away the issue of thermal injury to the renal arteries. The same catheter can be used from 3 to 8 millimeter, and when it is 3 millimeter, for 3 millimeter vessel, the length of treatment is about 21 millimeter, and when it's a 8 millimeter vessel, the length of treatment is about 17 millimeter. What is very important and what we have learned from the previous times and now, if you look at the sympathetic nerve distribution, that is very important. The more distal you go, the more these nerves are more closer to the renal adventitia, and the more proximal or near the ostia where you go, these nerves are far away. And that is why it is very important when you are doing renal artery denervation, you have to do each and every branch which is more than 3 millimeter in diameter and spare the ostium. And we were doing the opposite in 10, 15 years back when we were doing ostium and proximal part of the renal artery. In fact, one should not do the ostium because it is near the ganglion, and at that position, you may actually get the patient into autonomic neuropathy and postural hypotension. The other thing which you need to avoid is to avoid ablating near accessory renal artery or an arterial branch which goes to the adrenal gland. And if you look at it, if you treat these patients, there is a sustained and a very robust decrease in the sympathetic activity. And how we do it is like you go and do a renal angiogram, go with a guiding catheter, get on a 014 wire, you get this catheter up to the distal most renal artery, which is about 3 millimeter in diameter. What you need to avoid because of paucity of time, I'm saying you have to avoid the ostium and the branching points. And you can do that by repositioning the catheter. Or if you have, if you can't do it, what you do is you have these 4 electrodes, and you can turn off that electrode which is near the ostium or which is near the bifurcation point. So you have a very controlled denervation and RF energy distribution. So this is one of our patient. This was one of our first patient which we did. This patient had and presented with acute hypertensive LVF with a BP of 220 millimeter of mercury. And in spite of 4 drugs, this patient had been my old patient, had recurrent strokes and also acute coronary syndromes in the past, for which he got 3 coronary stents in 3 different admissions. And he had an angioplasty to the carotid as well as vertebral artery. So clearly a person with polyvascular disease and a patient with hypertensive crisis not controlled on 4 antihypertensive drugs. So once you get the catheter in place, as you see here, we withdraw the 014 wire and start ablating, and then go to each branch and ablate these renal arteries. So you do an angio again, go down on the other branch, and this is how you do it. So it's not a one-time procedure in the sense one-shot procedure. Earlier, while we were doing RDNs earlier, Dr. Srinivas would agree, it was just a 5 minutes job. Now here it takes at least 45 minutes to do a proper job on both sides and all the branches of the renal arteries. So the same thing, we go to the lower renal branch and do it. What is very important is, while we are doing it, you see for 2 things. You look for the impedance and you look for the rise of temperature. If the impedance is not, if the contact is not good, you will not have a good, impedance. And while you are ablating, what you need to do is, you need to see how the impedance starts falling and the temperature starts rising. The machine has a cutoff. If the temperature goes above 70 degrees centigrade, it actually stops ablating for the safety. And if the contact is not good and the impedance is not falling, you can actually switch off that electrode and continue with the renal ablation. So this handle is with the doctor, and he or the operator, and he would want to manipulate it in terms of how much energy is given, whether it's a successful ablation or unsuccessful ablation. This is a typical pattern where you see a rise of temperature and fall of impedance while you are doing it. And in case while you're doing it, if you don't find a good result, like on electrode 1, because these are numbered, you actually switch it off and go and ablate, either by repositioning or you do it, by doing a selective ablation. So different societies have actually taken this sort of therapy for hypertension seriously. So this has endorsement for almost all international cardiac and cardiovascular societies. And now it is being advocated for uncontrolled hypertension, which is not controlled on 4 drugs. In patients with hypertension which have elevated cardiovascular risk, like in my case, patient where you have a primary hypertension without any cause. But while we are doing it, you have to exclude 2 things. One, that the patient should not have white coat hypertension, patient should not have renal failure, end stage renal failure. And third, the patient should not have hyperaldosteronism. Now, this is how you select your patient. And if you have a patient with hypertension who actually has heart failure as well, most of these patients would do very well, because it also cut down the central sympathetic activity. So I'll stop here. And if there's any question, I'll be happy to answer.
Thank you very much, Dr. Khanna. When this technology will be fully available, especially in Europe?
I don't know about Europe, but in India, it's approved by the Indian authorities and it is freely available. Only thing, it's costly. And so that's a limiting factor. And otherwise, it's very freely available. Medtronic would know about the European countries.
Is it reimbursed in here by the mutual or insurance?
Yes, in India, it is reimbursed by private insurances. but not reimbursed by government insurances as of now.
What is the learning curve?
Learning curve for interventional cardiologist, I think, is not much. Maybe 2-3 proctored cases should be good enough, and they have good simulators where they actually teach you. And after that, it shouldn't be a very big learning curve. You only want to know the machine and what to do and what not to do and how to get over problems.
Mrs. Sorabi, do you use this technology? Can you give a word, but very fast? We are late.
Yeah, both Medtronic system and Record, the ultrasound-based technology we do use, depending on which candidate it is. Like if you have patients who have renal artery stenting, then only renal denervation you can do distal branches with Medtronic system. You can't use Record then.
How do you ensure that you have reached effective denervation has been done?
So this is very interesting that the effect starts after 2 months. So initially today you do the procedure, nothing will happen today. But we routinely give everybody home blood pressure monitor even before the procedure to rule out white coat. And then if 6 months there is no benefit, that means they're non-responders. And there is around 20% non-responders.
So how on table you decide that you have to stop now?
Meaning that by at the time of the procedure? No. At the time of procedure, it's preset. Like for renal denervation, for distal branches, you treat with Medtronic system. So you cover all branches which are 3 to 6 millimeter. For recourse system, ultrasound-based system, 3 denervations in the main renal artery, or if accessory is too big, in a non-overlapping fashion, you do and you stop. So it's like a predetermined thing. You don't watch for anything but complications.
I'm sorry, we have to go on. And Dr. Khanna, thank you very much. It was a good demonstration. We move with Sanjay. Sanjay on intervention in hypertension. Thank you. 10 minutes.
Good afternoon, friends. After such an interesting session about the renal denervation, I would like to highlight that renal denervation is primarily for essential hypertension, severe essential hypertension. I'll talk to you about the secondary causes of hypertension. Why it is important to identify secondary causes of hypertension? Because they are reversible causes of hypertension. The important indications for essential hypertension and that has been talked about are renal sympathetic denervation and baroreceptor activation therapies, which are besides renal denervation. There are several baroreceptor activation therapies are also available. But I shall be talking to you about the interventions in reversible cause of hypertension, particularly severe resistant hypertension. The main important cause of severe resistant hypertension, reversible resistant hypertension, are renal artery stenosis, coarctation of aorta, and Takashio's arthritis. Renal artery stenosis is one of the most frequent cause of severe reversible secondary hypertension. As I said, accurate diagnosis of this condition is very essential. Because if it continues to progress, it can cause the renal hypoxia, and which can lead to renal ischemia and renal loss of renal function, critical renal dysfunction. Most importantly, the clinical cues are very important, and non-invasive tools are helpful in detecting these causes. Initial treatment for these cases with renal artery stenosis is medical treatment. That is antihypertensive therapy, the antiplatelet drugs and statins, because the most cause of renal artery stenosis, particularly elderly, are atherosclerotic renal artery stenosis. And you know atherosclerotic is a generalized disease. Initially, the renal artery stenosis may not cause severe hypertension and may not require renal intervention. But as the disease progresses to more severe renal artery stenosis of more than 70%, then it causes renin release, sodium retention, and causes the severe hypertension that is commonly seen in these patients. Progressively, further worsening of renal artery stenosis causes tissue hypoxia and mitochondrial dysfunction in these patients, which leads to reduction in function of the glomeruli and causes severe renal tissue fibrosis and atrophy. And at that stage, this is the ischemic nephropathy, and the renal artery interventions are not effective at this case of severe ischemic renal nephropathy. So one should need to identify these cases at an earlier stage of disease when the treatment of renal artery stenosis is effective, not only reducing the severity of hypertension, but also reducing the progression into renal ischemia. The clinical indicators for renal artery stenosis are severe hypertension, particularly in young patients or above 50 years of age if they have severe short onset of hypertension with severe resistant hypertension despite control of 3 or more antihypertensive drugs, as called is by the definition of resistant hypertension. Unexplained congestive heart failure, pulmonary edema with severe hypertension, or patient with unstable angina along with severe hypertension are also indication for renal artery interventions in patients with severe renal artery stenosis. The renal artery angioplasty is very effective in over 90% of these cases with severe 90% stenosis, and particularly in those patients who have bilateral renal artery stenosis and the resistive index as found out by Doppler evaluation of the renal arteries is less than 80. Renal artery stenosis is not effective in those patients with advanced renal ischemia or chronic coronary artery disease. That should be remembered, because once you have severe renal dysfunction, then renal artery interventions are not effective in reversing the renal artery ischemia. How to find out which cases of renal artery stenosis and the renal failure would be useful, the treatment would be useful. The viability of the kidney tissue is very important sign. So if you can find out these patients early onset, within 6 months of onset of renal artery, severe renal artery stenosis, worsening of renal failure, it may be reversible. But if it is long-term renal artery, chronic kidney disease, then the renal artery angioplasty technique is not that effective. Those patients who have proteinuria of less than 200 milligram or cortical thickness of distinct cortical medullary differentiation are also very effectively treated with the help of renal artery interventions. Renal artery interventions are safe and very effective in these patients, particularly in those patients with atherosclerotic renal artery stenosis, who have a short onset of renal artery, short onset of severe hypertension, and those patients with mild chronic kidney disease. This patient came to me from Jaipur, and patient had total occlusion of the left renal artery. Right renal artery itself had severe stenosis of more than 90%, and infrarenal abdominal aorta also had total occlusions. And I went from brachial approach and then did angioplasty and stenting of the right renal artery. After intervention, not only the number of drugs reduced, but his renal failure also improved from 2 to 1.3 creatinine on follow-up. So this is the beneficial role of those patients with severe renal artery stenosis and mild chronic kidney artery disease. Another cases that are very common in our country, particularly in young females, is Takashio's arteritis. That often involves their proximal ostial involvement of renal artery stenosis, causes severe hypertension with congestive heart failure, most common in children, where they often present with hypertension and heart failure. So revascularization, those patients with severe renal artery stenosis becomes mandatory. Often these patients have signs of the active stage of the disease. So activity of these renal arteries in these patients with Takashio's also needs emergent and early treatment. But revascularization becomes mandatory in these patients with severe renal artery stenosis and is very helpful in these cases, like you have seen here. This patient presented to us with bilateral renal artery stenosis. A young child presented with bilateral renal artery stenosis, and after using a cutting balloon with a blade, we could dilate the renal artery without the use of stents and could get relief from her severe hypertension and heart failure. Also, it is very important to remember that these, as I said, these patients often present with heart failure along with hypertension. So once you relieve their renal artery stenosis, not only their hypertension improves, but the heart failure of these patients also showed good improvement. We started this work 40 years back in 1985 and published our series of renal angioplasty in these patients with Takashio's arteritis, American Heart Journal in 1993, which showed that renal artery interventions is safe and very effective in relieving renal artery ischemia in these patients with Takashio's arteritis. And particularly, I would like to remind you that these patients who are young hypertensive with severe hypertension are effectively
relieved of their hypertension as compared to those patients who have atherosclerotic renal artery stenosis, where hypertension relief is not that great. Like this patient, this young girl came to us with severe bilateral renal artery stenosis. You can see here, even the superior mesenteric artery is also severely stenosed, and infrarenal abdominal aorta is totally occluded. So from the brachial approach, we did the renal angioplasty of both the renal arteries and did angioplasty along with stenting this patient to relieve that patient of her severe ischemia. Next. In these patients, one of our largest world experience on renal angioplasty in children was published, and which showed that in our country, the renovascular hypertension in children is most commonly caused by Takashio's arthritis as compared to those in the western part of the population, which is caused by fibromuscular dysplasia. As you will read in the western textbooks, the commonest cause of renal artery stenosis in children is fibromuscular dysplasia. But you must remember that in our country, the commonest cause of renal artery stenosis in children is aortoarthritis or Takashio's disease, which in our studies, it showed that over 85% of these patients had Takashio's arthritis. And often we found them with severe severe heart failure. Aortoarthritis, as you know, is the most common cause of renovascular hypertension in our part of the world, but lesions, because they are densely fibrosed, are tough to dilate and require high pressure for dilatation, and often dissection is common, but dissection is a part of balloon dilatation in these patients. In the restenosis rate in adults is low to the tune of 15 to 20%, but is higher in children because of the smaller size of the artery and the more active stage of the disease. Now we have a very large long-term experience of these patients. Like this patient underwent, I did balloon angioplasty in 1988. You can see here the left renal artery is totally occluded, right renal artery has severe stenosis. We did balloon angioplasty of the infrarenal abdominal aorta as well as of the renal artery and dilated the renal artery, but there was some residual stenosis. But on follow-up, what we found that the residual stenosis also further improved itself. This is called beneficial late remodeling. This we reported in American Heart Journal, that on follow-up, if you do not stent this patient, the renal artery may show further improvement. And then in 2014, that is 10 years after doing this follow-up, we repeated the CT angiogram of this patient. You can see not only the renal artery continues to remain dilated, but the infrarenal abdominal aorta also continues to remain dilated in this patient. This patient continues to be with me in follow-up on long term and shows continued good improvement in long-term follow-up about 30 years of now. Another important cause of secondary cause of renal artery stenosis is fibromuscular dysplasia, and the commonest cause is the string of bead appearance, the typical appearance of the renal artery. This was a wife of a major who presented to us with severe hypertension, and the renal artery stenosis you can see here has the string of bead appearance. And simple balloon angioplasty is safe and very effective in this type of condition, relieving the renal artery stenosis and relieving the patient from long-term consequences of hypertension and renal ischemia. They do not, most of time, do not require stent implantation. Recently, the recent results of renovascular hypertension angioplasty has been published, which confirms our view that the renal artery angioplasty is safe and very effective in treatment of pediatric renovascular hypertension. But repeat interventions are required in these patients in about 20 to 30% of these patients, and then the results are very good long-term result can be seen. Another important cause of hypertension is the narrowing of the aorta. Common cause is congenital coarctation of aorta. Like this patient presented to us in emergency department of our sister hospital, that is Lok Nayak Hospital, with severe uncontrolled hypertension, hypertensive encephalopathy. You can see here the patient had the severe stenosis of the aorta distal to left subclavian artery, that is congenital coarctation of aorta. And after balloon dilatation, we could relieve the coarctation effectively and improve the blood pressure in this patient. Now the girl has got married and has children and continues to have good relief from her hypertension. Sometimes after balloon angioplasty, there may be residual stenosis of more than 20 millimeters of mercury. Then we started implanting stents in these patients for coarctation of aorta, and we published our results of coarctation of aorta stenting in American Heart Journal in 2003.
and which showed that after balloon angioplasty, if you have residual stenosis, then stent implantation is safe and very effective in relieving these patients. We not only implanted the balloon expandable stent, but we implanted the self-expandable large diameter stents in these patients with coarctation, and we found that it was very safe and effective in relieving their coarctation, as well as gave them the long-term relief from their hypertension. Another important secondary cause of hypertension in our country, particularly in the Southeast Asia, Japan, and China, is Takashus arthritis, where the aortoarthritis, that is inflammation of the aorta, causes severe renal stenosis of the aorta, maybe along with renal artery stenosis. And balloon dilatation technique, as you can see, is very effective, particularly for discrete lesions. The technique shows marked relief in the stenosis, as well as hypertension is relieved in these patients. These patients also often have heart failure. As you can see here, that these patients presented with severe heart failure, ejection fraction 20 to 25%. And after balloon angioplasty, patient had not only improvement in her hypertension, but heart failure also showed good improvement. Sometimes, as I said, balloon angioplasty produces dissection of the aorta, and the implantation of stent is safe and very effective in relieving their stenosis completely in these patients. So, friends, the interventions in patients with secondary hypertension caused by arterial stenosis, that is renal artery stenosis, coarctation of aorta, or Takashus arthritis, is a safe and very effective technique. As I said, in these patients with young hypertension, you can give them lifelong cure and freedom from their hypertension in these patients, as compared to those patients with atherosclerotic renal artery stenosis in an elderly patient, where you can only improve their hypertension and patient continues to require antihypertensive drugs on follow-up. So these need initial careful evaluation with the help of non-invasive techniques to find out the cause of secondary hypertension at an early stage, so that you can relieve these patients. Medical use of technique and careful follow-up is important to find out the recurrence of stenosis, and re-intervention may be required in some of these cases, which can give them long-term relief. Thank you very much for your patient listening.
Thank you very much. You did a very good presentation, very extensive, and thank you very much. You are running after time. We are 1 hour late, so we have to move on. I'm sorry, but it was very good anyway. So next is an invited talk by Tullio. No, he's not here. Where is he? Where is Tullio? He don't want to present. But it's good for the time, good for the timing. So sorry, he refused to connect. He won't be invited next year, probably. So we move on aortic intervention. And it's a semi-final, so it's very important for the people who stay. Case technique and review by experts. So, Shubhachandra Podar, Preti Gupta, Saxena, Swati Singh, Mushe Kaul, Logesh, Raman Shala, Rajaram. Where is he? Sanji, where are you? It's very important because the panel have to give a score. The first speaker is Saurabh Kumar. Saurabh Kumar Singh from Delhi. Where is he? He's not here. So the second is Eva for perforating aortic aneurysm, Sapphil Garde. Who are you?
Swapnil Gare. Second.
Garde?
Yes.
You're French.
No.
No, he's Indian. Garde is a French name. You're welcome in France whenever you want.
Thank you so much.
So, difficult case. You have 6 minutes. Please keep on time because
sir. I'll
your
stick to the
score
time.
will depend of that also.
Thank you very much for the opportunity given to me by the organizers. So let us start the case. Can I have the next slide, please? So this is a story of a 60-year-old male who presented to us in an emergency in the wee hours of the night, and he was admitted at some other hospital with a history of 5 days of acute abdominal pain. So there was a abdominal pain and tenderness since last 7 to 8 days. He has already spent 4 or 5 days at some other hospital. He presented to us with hypotension, raised respiratory rate. His GCS was E2, V4, M5. Creatinine was raised. TLC was high around 16,000. He had PSVT on the cardiac monitor, and he was showing failure to respond to the fluid challenge. The vasopresses were started, and as we look into the previous investigations, his hemoglobin was continuously falling at a rapid trend. He was a known case of CAD, ischemic cardiomyopathy, with ejection fraction of 25%. He underwent PTC in 2015. So this was the initial ECG. Intermittently, he was also having atrial fibrillation, which was difficult to manage because he was having some ischemic hepatitis. So his OTPTs were raised as well as he was deranged creatinine levels. So it was actually the kudos is to for the critical care team who suspected that this might be the aortic disease, and they conducted a CT aortogram which showed that there was a secular dilatation of the infrarenal abdominal aorta extending up to the origin of inferior mesenteric artery with surrounding periaortic hematoma and aneurysmal thrombus. Leak of the right lateral valve was suspected, which was suggestive of ruptured aortic aneurysm. So this was the CT scan, and this is the first case I have done in my life for the repair of the saccular aneurysm. So bilateral USG guided femoral access was taken. 7 French sheets were used, and we introduced the pigtail from the left femoral access, and right femoral access was kept for the intervention. So in the CT scan, there was also bilateral iliac disease of around 50 to 60%, which was reported. Although we could not appreciate much in the in the shoots while we were taking, and there was a dilemma whether the graft stent will go through that disease of the iliac and enter into the aorta. So it was suggested that we use sequential dilatation with the higher French of dilators, and rather than stenting making a way through the iliacs. So we use sequential dilatations with the 7 French, 8 French, 10 French, 12 and 14 French to make a way for our device into the aorta. So we did not do ballooning because we were afraid that it might get dissect and we have to put a stent and then we have to take the graft across the stent, which would be a difficult task doing managing this case in an emergency. So we exchange the JR catheter initially with the Thermo software, then Superstiff wire, Lindercast and Emplards. We took the device through it. You can see the previous stents as well as lower ejection fraction as appeared on the fluoroscopy. And after taking a DSA and proper positioning, this graft stent Endurant 2020 into 82 was it entered easily through the dilatation process, and it's floated smoothly into the aorta, and we deployed the stent after checking a DSA that and we had a good landing zone below the renal arteries. So we deployed initially 2 or 3 struts only, let the stent settle down so that it does not get moved, and then gradually we deployed the whole stent, and there was some amount of endoleak initially, which gradually settled in the upcoming uh, DSAs. Then we took the pigtail which was jailed and then reintroduced inside the stent to take the final shoot. So this was the final shoot on the left side. There is type 1A endoleak which was still visible. Heparin was administered before introduction of the stent, but as this was the case was being done in the emergency and the perclose was not available, the surgeon came in to close the access site, and he could appreciate that there was some thrombus into the femoral artery. So Fogarty catheter was used to suck the thrombus out of it, which we took the check shoots of the both the iliacs and the femorals of the bilateral side, and which was okay as per the previous CT report. And it took a lot of time to manage the patients because he was having a GI bleed, which was endoscopically managed, recurrent VT and VA, for which stellate ganglion block was used. Vasopressors continued for a few days. It took us 21 days to take this patient out of the hospital, and we are expecting a follow-up in 7 or 10 days. He will come back to show us. So it took around 10 PRBCs to manage the patient. So there was a huge blood loss in for this case. Thank you.
Thank you very much. Just a word. You have treated a saccular aneurysm. It's not a fusiform, and the rule of 55 millimeter given by the English is not adapted to the saccular. Saccular, you have to treat it because there is a risk of rupture because of the stream, which is badly affecting the wall. So I think what happened at the end, is it an infection?
Sorry?
You have an infected graft
No,
at the
sir,
end?
this was not an infected graft. He was probably tobacco chewer and smoker, and this could be some other pathology, but he was not. This was not an infected graft. He had an E. coli sepsis, but I think that was because of some urosepsis or something.
Other questions, sir?
See, once you have any infection proved as E. coli, presume it to be mycotic unless proved otherwise.
Okay.
So you cannot say the animal was not infected. You already have grown E. coli.
Right.
It means that should be presumed as mycotic. This is what my
Right.
feeling is.
Okay, sir.
Should give long-term antibiotics also.
So thank you very much. We will score with Madame. And the next exceptionally. Sir, go on. What's your name?
Saurabh Kumar Singh.
Saurabh Kumar?
Singh.
Where were you? You were...
I was just outside.
When you have a presentation, you stay in the room on time. So be careful.
Yeah. Good evening, everyone. I will presenting a case. Yeah. The endovascular repair of tubercular aortic pseudoaneurysm secondary to port spine. So it was a case of 26-year-old male with non-smoker presented with insidious onset, gradually progressive, dull, aching, low back pain for 3 to 4 months. There was no history of any fever or night sweats in the current presentation. However, significant weight loss was reported. He had history of having sputum positive pulmonary cox two years ago, for which complete ATT was taken for 9 months. And there was no history suggestive of any focal neurological deficit in any of the limbs or any other bowel or bladder involvement. CACT abdomen was done, suggestive of saccular aneurysm of measuring 45 into 44 into 35 millimeter, arising from the posterior wall of the thoracic aorta at the level of D12 vertebra, along with erosions of the anterior body and of the D12 vertebra. A hard term discussion was done, and considering a focal and favorable location for endovascular repair, a high risk surgery, a decision for endovascular repair was taken, and after detailed informed decision with the patient. So this was the CT scan. We can see this aneurysm just behind the D12 vertebra, above the celiac artery. There was 2 centimeter above the celiac artery. So the right femoral arterial access was taken, and the pictal was taken for defining the aneurysm. This was the pictal shot, and it was just arising 2 centimeter above the celiac artery. So the life tech TA 2280 millimeters stent graft system was then inserted, and it was placed in the DTA, and the position was confirmed in the angiogram 1190. You can see, and this is how the stent graft being deployed, and the angiogram was done with again pictal shot to check the position and endo leak. And there was no endo leak and the stent was patent. And so the DSA was taken and there was no endo leak again. And this was right femoral angiogram post proglide closure. And there was no any dissection, thrombus or any leak. And the patient, this was interesting, like post-implantation syndrome, the patient developed high-grade fever from day 2 post-procedure along with leukocytosis on day 1, which reverted back to normal on next day. Fever spikes continued for 6 days after the procedure and patient became afebrile on day 7. ESR, CRP were raised, but workup for infection was done and it was unremarkable and the procalcitonin was normal, less than 0.5. Diagnosis of post-implantation syndrome was made. Patient was administered broad-spectrum antibiotic and acetaminophen. Fever subsided on day 6 post-procedure, and patient did well. So the learning point from my case, the coexistence of tuberculous aortic aneurysm and tuberculous spondylitis is relatively rare in patients with TB. Our experience underscores the significance of proper screening for tubercular pseudoaneurysm, referral to vascular surgery or cardiology, and prompt surgical or endovascular intervention as a life-saving measure. Tubercular pseudoaneurysm can be fatal, and therefore it is crucial to perform immediate diagnostic examinations when the disease is suspected, especially for patients with pulmonary TB presenting with persistent chest and abdominal pain and thoracoabdominal paraspinal pulsatile mass. Prioritizing treatment of the pseudoaneurysm to prevent aneurysm rupture should precede vertebral TB surgery. For patients with high risk for surgical complication, endovascular repair is a safe and effective management approach for mycotic aneurysm. Early diagnosis, multidisciplinary coordination, and prompt endovascular repair can be life-saving. Thank you.
Finish?
Yes.
Thank you. Just a part of the tuberculosis, you know probably that after the implantation of a stent graft in the aorta, you have a febrile temperature going up. I think it's because of the inflammatory response of the implantation of foreign body. This could be also fever from particles coming from the fabrics, and also that could be a fever of resorption of the hematoma. So when you have fever after stent graft, don't worry too much. Probably the bacteriology will be negative. This is something that we see often. Who can agree with me on the panel?
Yeah, fever coming immediately within first 24 hours, unlikely because of infection. That takes at least 48 hours. So as you have suggested, it's probably because of reaction to the graft what you have implanted already.
So you did a good job. Thank you very much. We move on.
Next is fenestrated endovascular repair of abdominal aortic aneurysm by Dr. Satyajit Padiyari.
By whom?
Dr. Satyajit Padiyari.
Padiari. You have 6 minutes sharp.
Good evening, good evening, respected judges and all presented here. So I am going to present a fenestrated endovascular repair of abdominal aortic aneurysm. So a brief case history. This is a 57-year-old gentleman and having history of pain abdomen since last 2 months, and he is a known case of hypertension on regular medication, and he is a chronic smoker and recently been diagnosed with COPD. So he has all the risk factor for abdominal aneurysm. On general physical examination, he have a swelling, a parabdominal swelling that is pulsatile in epigastric region. Patient was evaluated outside with ultrasound and they saw abdominal mass, followed by he underwent CT abdomen, and that saw a justarenal fusiform aneurysm that is of size of 69 into 108 mm in diameter with a neck of 22 into 23 and have a suitable angle of 27 degrees. Right common iliac artery is 10 into 10, and he having also left renal artery ostral stenosis of around 80%. So After a hard team discussion, he was taken for the endovascular repair. So in this case, we took 4 access, two bilateral brachial artery access and bilateral femoral artery access. So first we do the left renal artery angiogram, and then so there is significant around 80 to 90% ostial renal artery stenosis, which was dilated with 5 into 15 into semi-compliant balloon. And post dilatation, we can show there is significant dissection, but however there is good flow. There is no flow limiting dissection. Then over the then over the left femoral artery, that we took a JR catheter, and that over there JR catheter, we took the first software, that is thermoware, that was exchanged with the amplifier wire, and from the bilateral brachial artery, we took the 2 check flow long sheath. Then then we took the device over the left femoral artery access, and it was placed in the abdominal aorta. Then we take a DSA to confirm the positions, and then the proximal part of the device was deployed, and through this device we try to cannulate the left renal at first we tried to cannulate the left renal artery, but however we could not do it, so we proceed to cannulate the right renal artery with thermowire. Over the thermowire, we took the renal artery stent of size Bentley renal artery stent, and then the then the main device was deployed, and we take a DSA that so there is no endoleak, and also there is good renal flow. After that, bilateral right and left cup of size 14 into 14 and 120 mm was deployed in the common iliac artery. And this is a post renal artery. We can see there is no flow limitation both the artery. However, post procedure, the patient having severe AKI, and for which he underwent multiple times of renal dialysis, and after that the patient however recovered, and now he is doing well. Thank you.
Sir, I would like to see the CT and the sizing.
Actually, I don't have the CT at present.
Sorry, can you repeat? Can you repeat what you say?
At present, I don't have the CT.
No, can you speak louder?
I don't have the CT. At present, I don't have the CT images of this patient.
I'm sorry, you will have a bad score because you need a CT to show. Where is the CT?
Yes.
You did it like that without any sizing?
No, we have the size based on the CT, but
so no CT. Thank you, sir. Thank you.
Thank you.
No CT. Madam, you saw a CT, but it was not a CT. So we go on. The next is Mohan Palival. Mohan, can you come? It's a very good subject, conquering the Aorta hidden threat. Very good name.
Thank you, sir. Good evening, respected chairperson and all the delegates. So we had this case of 55-year-old gentleman with newly diagnosed systemic hypertension, presented with intermittent chest pain, abdominal pain and umbilical hernia since last 6 to 7 months. He had undergone pre-anesthetic evaluation to get operated for umbilical hernia, and on evaluation, CT abdo-pelvis, incidentally found to have dissection of descending thoracic aorta and abdominal aorta. He was given an option as the dissection was large. It was the false lumen was almost of 55 mm in size. He was given an option for open vascular graft surgery, but was not willing for the same. On examination, the patient was hypertensive. BP was 160/100 in right upper limb and 170/100 in lower limb. Cardiovascular system examination was within normal limits. ECG was NSR with no significant changes, and on echo there was concentric LV hypertrophy was there with good LV function and no evidence of aortic regurgitation. Chest X-ray was suggestive of widened superior mediastinum. This was the CT film he provided to us. The dissection was just after the left subclavian, and the landing zone was there was not much landing zone for the placement of the graft, and dissection was extending up to the inferior mesenteric and renal arteries, just involving the inferior mesenteric and just ending just above the renal arteries. And so we decided for graft placement. The common femoral artery was surgically exposed by our CVTS colleagues. Through right radial artery, we put a 5-way pictal catheter into the aortic arch, and simultaneously, right femoral access was established with insertion of a 6 French sheath and multipurpose catheter guided into the aortic root, which was exchanged with 5-way marker pictal catheter with the help of 0.035 Terimo wire, double length, and we took a check shoot to decide the length and extent of the disease. Lundarki superstrip wire was positioned into the ascending aorta via catheter exchange, and the LifeTech Ankura stain graft 3426 with length of 200 was prepared and delivered over the wire, positioned just distal to the left common carotid artery in the LAO view, plain LAO. Proximal landing position was confirmed with right radial artery shoot, followed by careful stent inflation done, and final angiographic imaging confirm accurate placement of the stent graft. We position the stent across the left subclavian so that we don't miss the entry point of the false lumen, with no contraindication to the false lumen, and preserved flow through the major branches and abdominal branches. The distal shoot we took in steep lateral view, in this view we can see there is some the entry point is there. Here the false lumen is still feeding from the lower side, near the celiac branches. This is the post procedure CT aortogram. Immediately after the procedure, the veil opposed stent struts can be seen. Here also we can see the outpouching of the false lumen that was feeding from the lower side, but we decided not to touch it because the proximal entry point was closed, and we thought that we will follow up this patient, and this false lumen will get thrombosed from upside down, and also the complexity of the abdominal. So in this case, I think what we could have done differently was we could have used a zenith dissection endovascular system, which comes in two parts. The upper part is the graft stent, and the lower is just the stent metallic cage that gives a good support, and early filling of the false lumen can happen. Uh, with a petticoat technique, that is provisional extension to induce complete attachment. And in cases with multiple re-entries, we can use the embracement technique, in which we can place a pictal in the left subclavian and one pictal from the femoral, and we can entangle and pull it back so that we can be sure that we are in the true lumen. So my take-home message is TEVAR is the first-line treatment for descending thoracic aortic pathologies such as type B dissection aneurysm, offering lower morbidity than open surgery. Careful pre-procedural planning with CT angiography is essential for assessing anatomy, determining the landing zones, and selecting appropriate stent graft. Accurate stent deployment and intraoperative imaging are critical to ensure sealing of the pathology, avoid endoleaks, and preserve flow to vital aortic branches. Use of steep guide wires and dual vascular access improves stability and control during the procedure, allowing precise navigation and device placement. And the most important is post-procedure follow that has to be done in the form of CT scan, that has to be done immediately and after 1 month and after 6 months, and then yearly after, is more important to recognize any complication that can happen, like endoleak, stent migration, or aneurysm. Thank you.
Thank you very much. As you know, guiding and catheter manipulation are very important in endovascular technique, especially when you treat the aorta. So you did a good approach. Thank you very much. We have to go on. Thank you.
Thank you, sir. Thank you.
Is Dr. Arvind Dambalkar here? I don't think so.
Dambalkar.
He is not there.
So we are finished. Do you confirm that Dr. Dambalkar is not present? He is not here. So we are finished. So this is the result. Number 3 is Kumar. He went away, Kumar. Number 3. He's number 3. Where is he? Don't be afraid. Come up. Number 2. Come on the front. The second is Dr. Garde. Garde. And the first is Paleva. Thank you. The camera, please. There is another session starting right now. We are gaining time, it's good. The session starts at 7:10 and it's 7:16, so it's good. Can you come?
So this is the last session of the day, and this session is fresh from Owen, Apvic update, game changer pharmacological therapies in 2025. Let me ask Dr. Busquet to stay on. Let me invite Dr. Sudesh Kumar from Punjab to be the panelist, Dr.
It's a
A.K.
pleasure.
Kisrani to come and chair the session, Dr. Raman Chawla to please help us out and chair the session, and also Dr. Surabhi from United States to come and chair the session. So as we are going to introduce this, I probably would be giving you a little introduction on obesity, selecting the outcomes beyond weight loss, and a little introduction about the SELECT trial, and then it will be taken over by the two speakers, Dr. Richa Chaturvedi, who is a very distinguished colleague from our own center in Apollo Hospital. She's going to be speaking on stepping up obesity care with semaglutide 2.4 milligram, and also Dr. Setu Gupta, who would be speaking on art of cardio kidney metabolic health, which is the CKH, a soulful perspective on oral semaglutide. So let me start with my slides. Where are they? ये कैसे जाएंगे?
Dr. Khanna, you have some slides?
Yeah.
What is the subject?
I'm actually speaking for somebody who's not turned up.
Who do you replace?
Dr. Bhushan.
Bhushan
So that's why, I'm just introducing this subject, and
is very lucky to be replaced by you.
how do I open this slide? Is it not selected?
Selecting the outcome beyond weight loss.
Have you loaded the slide? Yes. Okay. Thank you. So this is a very in thing, and I was like observing, I'm sorry to say, many of our cardiologists and vascular surgeons and some radiologists looking at their metabolic health and looking at the obesity. It was not very a happy moment to see at least 1 out of 3 being out of shape and having varying degrees of obesity, which needs to be tackled. There are no financial commitments, and this talk is in no way influencing our scientific content. Looking at the cardiovascular disease in India, we have 71 million cases of cardiovascular disease, and the global disease is a burden. This is from the Global Disease Burden in 2019 study. And in 2016, CVDs contributed to 28% of total deaths and 14% of total disability adjusted life years in India. So that is the burden we are dealing with. And India has the third largest population with obesity in the world. We were only thinking that it is United States and China, but actually India is quite high as per the WHO estimates. And as per the latest ICMR India B study in 2021, there are projections that 254 million adults will have generalized obesity, and about 151 million adults will have abdominal obesity, which is the real issue with Indian obese patients. Now, increasing overweight and obesity-related cardiovascular deaths, 70% of the deaths related to overweight or obesity are due to cardiovascular disease, and overall cardiovascular mortality is related to obesity in direct way, and it increases the mortality threefold. Many a times we actually see this happening in youngsters in our population, both very important social people who influence the social media. Because of obesity, they have a high risk of cardiovascular mortality, and many of these have actually lost their lives. So weight loss improves traditional cardiovascular risk factors, be it hypertension, be it diabetes, and many other diseases. Actually, that is the key. Many people actually cannot do it, or do not have the will to do, improve their diet and increase their physical activity and to tone down their obesity. And unfortunately, a lot of these people psychologically are dependent on a miracle drug which will reduce the weight and also will improve their cardiovascular, uh, you know, reduce their cardiovascular mortality, despite the fact that they do not want to work on themselves. So, while we are introducing this concept, there are drugs, there are therapies which can decrease the weight loss, but it is the patient's will which is the most important, to actually combine that with the drug effect to actually get to a point where there is a sustained improvement in cardiovascular health and treatment of obesity. Weight loss has not been an effective strategy for cardiovascular reduction except for bariatric surgery, but now we have more things to do. It is bariatric surgery. It could also be an endoscopic balloon therapy, which and also now a very good armamentarium of drugs which can actually reduce weight and obesity, and these are FDA approved drugs, and they are both of them are now available in the country, and in injectable forms and also in oral forms, one of them in oral forms. So there have been various cardiovascular outcome trials with pharmacotherapy for management of obesity. The trials I'm not going to be discussing in detail were Scout trial, Crescendo trial, Light trial, Convene trial, and Camilla Timmy trial. And many of these were not done very well, but the most important trial, which has now been up and actually led to a pivotal change in therapy, was the SELECT trial. This is one of the largest cardiovascular outcome trials, which involved 17,604 participants from more than 40 countries across the world, with 40 months of median follow-up. And in this trial, India enrolled 492 participants. So I'm not going to go to the detail of these trials. The two speakers would also be taking care of this, this trial in their discussions. But the main summary points or carry-home points were: despite standard of care, the risk of cardiovascular events remains in people with cardiovascular disease, with overweight and obesity. There is an unmet need for therapies that reduce cardiovascular events and support weight loss management. And Wegovy is the first and the only obesity medication with proven 20% MACE reduction, and therefore is recommended by ESC and in ESC guidelines, and also approved by CDS scope to reduce cardiovascular death, myocardial infarction, stroke in patients with cardiovascular disease without type 2 diabetes. Now we have the drug available in India by the name of Wegovy, and I believe the same drug is available in United States by the name of Ozempic. So with this sort of introduction, let me invite the other two speakers to speak on this form of therapy, and I will hand it over to our panelist and chairperson to take this session forward.
Thank you very much, Dr. Khanna. Risha, this is you. Are you Risha? Are you Risha? Yeah. Nice to meet you. You have a presentation on stepping up obesity.
Thank you. Thank you for the kind introduction. Good evening. It's great to be here in this conference, and I will be speaking about the newest anti-obesity medication available in India, semaglutide, injection of Wegovy semaglutide higher dose, which has been extensively investigated in phase 3 clinical trial program, semaglutide treatment effect in people with obesity. So obesity is not only a result of excessive caloric intake and diminished energy expenditure. Genetic factors play a very important role, along with socioeconomic factors and other factors like environmental factors. Obesity is a chronic disease, and it should be treated like any other chronic disease, lifelong, at least long term. So brain has a very important role in regulating appetite, and these three areas, hypothalamus, brainstem, and subfrontal cortex, are predominant in regulating appetite. These are basically the areas where the blood-brain barrier is imperfect, and so the peripheral inputs from dorsal vagus is received, and then appetite is regulated, modified. Hypothalamus has the largest share of GLP-1 receptors, and it is involved in homeostatic eating. That is, when the energy is really required, it gets the input from peripheral signals like dorsal vagus nerve, and then hypothalamus gives the impetus to eat, whereas there is hedonic eating. Now, as much as we want our people with obesity to restrict calories, many a times it is not possible, because neuronal circuits are disrupted, they are altered, and especially the hedonic eating that is disturbed. What is that? This is the feeling of reward associated with feeding, which is clearly disturbed in people with obesity, as the studies have shown. And we have subfrontal cortex to take care of the cognitive part, control part in regulating appetite. So GLP-1 receptor analogs, they are basically centrally acting appetite reducing agents, and so far very effective for this particular purpose. So these neuronal circuits that we are talking about here are remarkably altered in people with obesity, and this is where the newer medications come into action. Now, this is a slide showing the effect of intensive lifestyle modification on the trajectory of weight loss. Initial few weeks part with lifestyle modification, there is good effect. And then when that is left, it all comes back. The physiological adaptations, they come into action, and this decrease in weight which was achieved is nullified. So why does it happen? Why do we gain the weight back? Because appetite hormones like leptin, the appetite reducing hormones like leptin, their levels decrease, and hunger hormones like ghrelin, they increase, and the basal metabolic rate of the body also goes down. It's a kind of adaptation mechanisms. That is why these whether it is lifestyle changes which cause weight loss, or any pharmacological agent, after the therapy or the intervention is discontinued, there is a tendency for weight gain, because these adaptive factors, they come into action. So research into anti-obesity medications has been going on for a long time with a feverish pitch, and this is second only to the holy grail of anti-aging. So the newest agent that we now have is injection Wegovy, subcutaneous injection, higher dose semaglutide, 2.4 milligram once in a week. So Wegovy is again, it is a centrally acting GLP-1 receptor analog. Apart from its peripheral actions, insulinotropic action, it affects brain also, and regulates appetite. It has 94% homology to human GLP-1. It has direct activation on those appetite regulating centers in the brain we just talked about, like hypothalamus, especially the arcuate nucleus in the hypothalamus. So Wegovy, curbs appetite, both homeostatic as well as hedonic regulation, and it has been assessed in multiple phase 3 trials, step trials, with more than 26,000 patients. So step 1 was, it was tested against placebo, 68-week duration trial we will be talking about. Then step teens, when it was tested in our adolescents, more than 12 years of age, between 12 to 18 years, and the remarkable positive effect which were found in this trial. Because of that, it was approved in teens, in adolescents with obesity, more than 12 years of age. Then select a CV outcome trial of Wegovy in people with obesity without diabetes. We just talked about this. Then Essence is very important trial of injectable semaglutide, 2.4 milligram injectable Wegovy in biopsy proven cases of MASH, metabolic dysfunction associated steatohepatitis, where it has shown positive effects in the initial part of the trial. 72 weeks trial, the second part of the trial is ongoing, and we would know in few years the results. Then step up is higher dosage of semaglutide, 7.2 milligram. And we have more than 8 million people who have been prescribed semaglutide therapies, all oral therapies, which is available by the name Rybelsus, then lower dosage of semaglutide, 0.5 and 1 milligram, globally available as injection Ozempic. And then the higher dose of semaglutide has been tried in step trials that we will be talking about. So step 1, where injection Wegovy 2.4 milligram was tested versus placebo in people with overweight or obesity without diabetes. And they compared the efficacy on cardiovascular risk factors, on body weight, clinical outcome assessments were done, and various other parameters were taken. It was a 68 weeks trial. For initial 16 weeks, dose was escalated. It's very important to start with a very low dose, like 0.25 milligram, so that we minimize the gastrointestinal side effect of this class of medication, and gradually in 4 weeks, the dosage is escalated. We do that in clinical practice also, and it is very important to increase the dosage gradually. And the primary endpoint that they looked at was percentage weight loss and 5% responder. So 5% weight loss is something we call clinically meaningful weight loss, where cardiometabolic parameters improve. So that was what was looked looked at here. So at the end of 68 weeks, weight loss with injection Wegovy 2.4 milligram was 16.9% versus 2.4% reduction with the placebo, which was statistically significant. And more than 5% weight loss was achieved in majority of the people with obesity in this trial, more than 90% of patients. More than 20% was achieved in 1/3 of the patient, and 20% is the figure that we achieve with bariatric surgery, especially with sleeve gastrectomy. So this is what was touched by Wegovy in step 1 trial. So 1/3 of the patient achieved more than 20% weight loss. And other confirmatory secondary points, it decreased waist circumference by minus 15.2 centimeter. To have a perspective here, 5 centimeter decrease in waist size is associated with 7% decrease in mortality in men and 11% decrease in mortality in women. And what we got here with Wegovy was decrease in waist size of 15.2%. Both systolic and diastolic blood pressures were reduced statistically significantly. C-reactive protein also was decreased to the tune of 58%. Again, for perspective, this is the kind of decrease in CRP that we see with statins. And the step 4 trial, where they looked at the effect of semaglutide on treatment with withdrawal. So we always say that obesity is a chronic disease and it requires long-term treatment. What happens when we give the treatment and we achieve the result to a certain extent and then discontinue? Again, as I was saying, those maladaptive physiological regulations, they come into action and weight is regained. That is what they saw in step 4 trial. Initially, all the patients were given semaglutide. Dosage again gradually escalated to 2.4 milligram or maximum tolerated dosage. And then some patients were put on placebo, whereas others continued on Wegovy. So as you can see, those people who discontinued, there was a 6.9% increase in weight from week 20 to week 68, whereas in the Wegovy group from 0 to 68, total 18% weight was lost. And step 5 is long-term data with Wegovy, 104 weeks, which is 2-year data with Wegovy. And here 304 participants were taken with obesity or overweight. If patients were overweight, the requirement was to have one obesity-associated comorbidity like dyslipidemia or hypertension. And more females were there in step trials, which is unlike other diabetes trial where male predominance is there. And in this long-term trial, patients experienced sustained weight loss over 2 years of 16.7% from week 0 to 68. After 68, it sort of plateaued, but still it was maintained. And I think by the end of 104 weeks, it was around 15.4% total reduction. So this long-term trial is showing maintenance of weight reduction with semaglutide 2.4 milligram injection Wegovy, whereas with placebo, there was minimal reduction in weight. So, and we saw, as Dr. Khanna showed about the SELECT trial, which enrolls more than 17,000 patients, and a trial ran for around 4 years. And 3P MACE was significantly reduced by injection Wegovy, which is 2.4 milligram semaglutide injectable. So, and looking at the side effects, I mean, we are, whenever a new drug comes, this is something which we are very interested in looking at, that it should not have, objectionable safety signals. So, in step 1 trial, sort of, as you can see, all adverse events category that was balanced, and but gastrointestinal adverse events, which obviously, I mean, that's expected to be there more in Wegovy group, those were there, and more these GI side effects, they occurred in the escalation phase, and the stabilization phase that had less evidence of that. There were serious adverse events in across 3 trials. They were sort of balanced between placebo group and semaglutide. Discontinuations were more common in semaglutide, but not I would say too common. And most of the these discontinuations, they were because of GI side effects. So Wegovy 2.4 milligram is suitable for adult patients with a BMI of more than 27 kg per meter square plus a comorbidity, or a BMI of more than 30. And this kind of real good weight loss to the tune of 20% is seen in 1/3 of patients taking Wegovy. Sustained weight loss over 4 years that we saw in CV outcome trial of Wegovy Select. It was given for 4 years and it appeared to be safe and effective. Weight loss was maintained. And there were significant health gains in terms of cardiometabolic parameters like systolic and diastolic blood pressure, CRP, waist size. So we have real good data available with us with injection Wegovy 2.4 milligram. Thank you very much.
Thank you, Dr. Richa. May I invite now Dr. Setu Gupta, and he'll be talking about the art of cardio. Probably Dr. Anand Khanna have already spoken in the part of Amit Bhushan.
Dr. Setu Gupta will come after 10 minutes. You can have discussion on this topic, Wegovy, for 10 minutes.
Okay, sure. Why not?
Yes, yes.
If we have time, we can have a discussion. As Dr. Anand Khanna has already said it, this is the first approved drug for weight reduction that is somewhere near more than 16% of the weight loss. Apart from cardiac benefit, major adverse cardiovascular events are taken care. Heart failure preserved with ejection fraction have been taken care, improved. And in the progression of CKD also is much improved, and the glycemic index has been reduced somewhere near in the tune of 2.5 or more. So if at all any questions, you can ask anyone.
Hello. Yes, please.
Thank you so much for such an insightful talk. I would just like to ask, and maybe obviously there's a lot of interest as a cardiology community in these two drugs, like Wegovy and Mounjaro, right? So there are two options available in the market now. And as an endocrinologist, what would be the basic difference you would like to tell the audience in between these two class of drugs?
Thank you. Thank you for the question, Dr. Surbi. So it's a question and a point of clinical concern these days. We have Mounjaro also available, which is a dual GLP and GIP agonist, twin creatine, and we have Wegovy GLP-1, pure GLP-1 receptor agonist. But as of now, we do not have CV outcome trial with tirzepatide or Mounjaro. We do not have trial in various other diseases like MASH or MASLD with tirzepatide. So the evidence for pleiotropic benefit we have with Wegovy in essence, where very positive outcome on MASH is seen, biopsy-proven cases and biopsy-proven benefit. We have that. We have CV outcome trial with Wegovy Select trial, where we clearly saw statistically significant reduction in 3P MACE of 20%. As of now, we don't have that with Mounjaro. So as you know, as a prescriber, I would be more confident in prescribing those medications which have solid evidence base as of now. So I'm sure with time we will know more about GLP-1 and GIP agonist. As far as effect size on obesity is concerned, yes, we all have seen that is more with Mounjaro. But we saw in this head-to-head trial also that effect size was more with tirzepatide. But the dosage comparison should also be of the similar quantum. So in SURMOUNT-5 trial, which was tirzepatide head-to-head with semaglutide, and dosage of semaglutide, the maximum dosage which is available as of now and is available for obesity as of now is 2.4 milligram. And in SURMOUNT-5 trial, that dosage was not achieved in majority of the patients, and majority of the patient, they stayed on 1.7 milligrams. So yes, in that trial, effect size was more with tirzepatide, but I think we need more data to really see what happens when we use a higher dosage of semaglutide versus tirzepatide. And as I said, we have solid evidence for Wegovy for benefit in cardiovascular disease, in benefit in liver disease, in peripheral arterial disease. So right now, I think tirzepatide has a little long way to go to really prove on all these aspects.
Dr. Richa, in this same question continuum, one of the corporate high official, I happened to visit him. He was quite obese, and his BMI is somewhere near more than 35 or 37. He had heard about the semaglutide. So he was after me that the weight reduction, only approved drug semaglutide, I want to use injectable. These were the questions to me put. So I said, okay, you can go ahead. But comparing both of them, what should I have advised him?
As I said, as far as data is concerned, weight loss we have seen with tirzepatide, but CV safety, renal safety, and other pleiotropic benefits, we have better data with Wegovy as of now. I am sure the picture will be more clear in coming years when we have more data with tirzepatide. But as of now, that kind of solid evidence with so many well-designed RCTs we have with Wegovy, like Select, like Essence, and like Stride, so like Flow with Ozempic. So that kind of evidence base, I think tirzepatide still has to build that kind of base.
So today, a coronary artery patient, if he wants to, Dr. Richa here, today, a coronary artery disease patient, if he wants to lose weight, you will advise Wegovy, not
Yes.
the other one, because we don't have trial.
Exactly. This is
So
what
my
I'm trying to say.
next question is this weight loss is less in diabetics than in non-diabetics?
We
And why
always,
so?
yes, we always see this kind with tirzepatide. Surmount CVO will the results will be out, but right now it is. I mean, we really don't know what the combination of GLP-1 and GIP does. We are quite hopeful, but till the time results are out, we can't really say anything. So, as for your question, we have seen in all the clinical trials, and you must have seen that the effect size becomes less in people with diabetes. The weight loss is slow and less. Exact reason is not known, but the reasoning explanation that is given for that is probably there is because there is incretin defect, and there is insulin resistance, and insulin has sort of weight gaining property, probably that. But literature says exact cause of that is really not known, but definitely weight loss is
The
less.
cause may be because the patient is taking
take it,
other
Dr.
other
Poddar.
anti-diabetic drugs
We'll take
like
it later on.
insulin.
Dr.
One
Setu has
minute.
come.
Like insulin, and that may cause weight gain.
Quite possible. Quite possible.
We can take questions later on. Thank you, Dr. Risha.
Thank
Since
you.
Dr. Setu Gupta has arrived, we'll be talking about the art of cardio, kidney, metabolic health, a soulful perspective on oral semaglutide. Earlier to Wegovy, oral semaglutide had come, the escalated dose from 3 to 7 to 14 have been established, and with the time gap, and yes, you want? No? No fight. Okay, done. Thank you. And this was not a fight, this was just a discussion. So as I said it, that cardiovascular events are taken care in the form of major adverse cardiovascular events were taken care. Myocardial infarction, as Dr. Khanna said, it, stroke reduction and heart failure with preserved ejection fraction was also taken care. Restriction of CKD as well as the glycemic control, you know it, this is the metabolic effect. Over to you for deliberation. Thank you.
Thank you so much, sir. So I'll move on. So I'm going to talk about the art of cardio kidney metabolic health, as sir has just talked about, and a soulful perspective on oral semaglutide. I've been informed that a Soul Times is available in all the tables in front of you for reference, so we can go have a look at it after that. It's a sponsored talk, so I have been financially compensated by this. So my presentation is going to talk about these 5 major categories, at what is the impact of oral semaglutide in glycemic and weight management. How does oral SEMA compare to injectable SEMA? Because now we have injectable SEMA available in India, maybe not for diabetes management, but we do have injectable SEMA now. How has oral SEMA fared when it comes to real world data? And what evidence supports the effect of oral SEMA in cardio kidney metabolic risk reduction? And does oral SEMA hold the promise of becoming one of the prime solutions in diabetes and cardiovascular? So first question, impact of oral SEMA in glycemic and weight management. And the thing here is we are talking about the dual management. So we had the pioneer trials, and the one of the biggest advantage of semaglutide, either oral or injectable, is the fact that it's been in the market for long. 2017 is when it got FDA approval, so almost 7-8 years of data we have. It has undergone 19 clinical pharmacology trials, 1 phase 2 trial, 12 phase 3A trials, and 1 post-marketing trial that has also been completed. 6,645 patients have been exposed to oral SEMA, for which we have data sets with us. And we found that 7 out of 10 patients achieved HbA1c of less than 7 with oral SEMA in the global pioneer trials. So the maximum HbA1c reduction was found to the tune of 1.5% by oral SEMA, which was much larger than when we had an active comparator, and quite significantly high when we compared it with placebo. And the weight reduction of up to 5 kgs was also seen by oral semaglutide. The interesting thing was that once the baseline HbA1c was made more than 9%, when we did the sub-analysis, we found that actually the HbA1c reduction was up till the tune of 2.6%. So that's a remarkable reduction, not seen with anything. Again, if we do a sub analysis and we start looking at the dual composition of a percentage of participants achieving HbA1c of HbA1c reduction of more than 1% and a body weight loss of 5%, we found that in Pioneer 1, in which there was a placebo comparator, the proportion was 9.5 times higher. And it goes on when we compared with empagliflozin, with sitagliptin, with liraglutide. So amongst all, we found that oral SEMA performed much better when it came to a dual reduction of both glycemic and weight. Oral SEMA also tends to reduce fat mass while preserving muscle mass. So this was an interesting finding. It was from a 26-week open label real life prospective study of around just 32 patients, not a great sample size. They both had diabetes and obesity, and oral SEMA 3 followed by 7 was compared. And we found that body weight reduced significantly, BMI reduced, weight circumference reduced. But when we did a body composition analysis, we found that fat mass index and visceral adipose tissue is what was coming down significantly. But the fat-free mass index, the skeletal mass index, the skeletal muscle mass, etc., was preserved. So this was an interesting finding, that oral SEMA exerted beneficial effects on body weight and body composition by reducing fat mass and preserving muscle mass. So coming on to probably the major question, how does oral SEMA compare to injectable SEMA? Now, this was answered by Overgrad in 2021, and he did blood concentration levels, and he found that for both subcutaneous SEMA of 1 milligrams per week and oral SEMA of 14 milligrams daily, they had semaglutide concentration was very similar, which echoed an HbA1c reduction. And even the tolerability went hand in hand when they were compared. So 1 milligram of injectable SEMA was almost comparable and had quite a significant overlap with oral SEMA. And so route of semaglutide administration does not influence the efficacy outcomes. And this was the real world data. This was Avdesh Singh's meta-analysis, 3 studies they took. They compared oral SEMA 3 to 14 versus injectable SEMA 0.5 to 1. And in all the studies, they found that oral SEMA performed almost equal, if not better, in some study like Klobakura et al. The oral SEMA tends to have a better impact than injectable SEMA in terms of HbA1c reduction as well as baseline body weight reduction. So kind of similar even in real world data. So injectable SEMA showed comparable reduction in A1Cs and as well as weight reduction. When we do a comparative further on from the Pioneer Sustain, we found that the percentages of more than 5% weight loss from baseline was achieved in similar percentages of patients, 44, 45%, and similarly more than 10% was achieved in 14 or 13%. So even the trials kind of showed that it is similar as far as 5% or 10% weight loss was considered. So these were trials. Have they been replicated in the real world studies? So the Pioneer Real, which is the real world evidence data that they are collecting as a part of phase 3B trials, part of 14 countries. India is also one of them. The final results from the Indian trial has not been yet published, but nonetheless, when the company has done interim analysis, they found that the HbA1c reduction, country-wise, and weight reduction was remarkable. HbA1c reduction, at least 1% was achieved in majority of the countries, and weight reduction of, if we exclude out Japan, which Southeast Asian or the East Asians have been shown to not be that effective to semaglutide or any GIP for that matter. So the weight reduction was at least somewhere around 5 kgs, even in real world data. And this was similar findings that have been echoed. High proportion of patients have achieved composite endpoints of A1C reduction of more than 1% and weight loss of 5%. So, ongoing pioneer real Indian study. We had type 2 diabetic patients who were 18 years, HbA1c value of less than 9%, and who were injectable GLP naive. Followed up for 44 weeks. Sample size was 387, and the endpoints was change in HbA1c. Secondary endpoints were change in body weight and proportion of people achieving HbA1c of less than 7%. So, what the interim analysis has shown is that 90% started achieving better glycemic and weight control. The A1C was poor, and 1 in 2 participants had CVD related history. 1 in 5 were started on oral semaglutide within 1 year. So these were the baseline inclusions that we found, and we saw that Indians were responding much more to A1C reduction than amongst all the countries, and this is something that even I feel I've seen in my clinical practice. I mean, we are quite responsive to GLP analogs. So 2% HbA1c reduction, far better than any other country. And the weight loss was somewhere around 5.3 kgs. So quite significant trial. And so significant HbA1c reduction up to 2% and significant weight reduction seen up to 8.2 kgs. But this one was from Slovenia. And for Indian, it was around 5.3 kgs. So, what evidence supports the effect of oral semaglutide in cardio-kidney metabolic risk reduction? Now, this is an important topic because everybody, including ADA and ACE, everybody is talking about now cardio-renal metabolic risk reduction. So, oral sema reduces systolic blood pressure by 5 mm of Hg from baseline. And why this is important is because each 10 mm reduction in mean systolic blood pressure is associated with 11% decrease in any complications related to diabetes, 16% for death related to diabetes, 11% for MIs, and 10% for microvascular. So, if oral sema can improve systolic blood pressure by 1 to 5, and as the trial shows around 5, then half of these parameters are likely being also met. Oral sema tends to improve lipid profile. This chart kind of shows it to be quite significant, but these were not statistically relevant. But yes, some reduction in LDL, TGs, total cholesterol, and increase in baseline HDL is seen, but these are not really statistically or clinically relevant. HSCRP reduces to some extent and 4 times more than empagliflozin. We all know it's a biomarker of cardiovascular risk, but whether it has any clinical relevance is something that only time will tell. Oral sema has established cardiovascular safety. Now, this we all know from the Pioneer 6 results. At least there was cardiovascular safety, and the important thing to note is that the hazards graph started separating even somewhere around 6 weeks since randomization. So it showed its effectiveness even early on, and it kind of showed that the numbers needed to treat were quite low, and there was 21% non-significant MACE reduction, 50% reduction in cardiovascular death, which was quite significant, and 49% reduction in all-cause deaths. So Pioneer really showed that it was cardiovascular safe, if not superior. And cumulative incidence of stroke again went down. The hazard risk was 0.68 and it was statistically significant. However, the upper limit of the confidence interval was still 1. But overall, it did show that the incidence of stroke decreased with time. So, impact of oral sema on weight loss and HbA1c remains significant in patients with type 2 diabetes and reduced EGFR. And this is a significant finding because Pioneer 5, which included patients with an EGFR of 30 to 59 millimeters per minute of 1.73 meters squares were included, and there were 324 patients. And we found that from with a baseline weight of 91 kgs. There was 3.5 kg weight loss that was there with oral CMAs, and they with the baseline HbA1c of 8%, there was 1% reduction in HbA1c. So oral SEMA significantly decreased HbA1c, and no dose adjustment is required for OD semaglutide if EGFR is even if EGFR is less than 45. And this was again echoed here, like potential mechanisms. Again, this is all theoretical, but we believe that there is increase in tubuloglomerular feedback, which leads to vasoconstriction of efferent arteriole, and then there is an increase in sodium efflux to the macula densa, which again causes positive feedback to the TG feedback, and the cycle goes on, because of which there is reduction in GFR decline. So chronic administration of GLP-1 tends to decrease the decline of EGFR. And the other important finding is the anti-albuminuric effect. I think we've all talked about from the FLOW trial that GLP tend to reduce albuminuria through multiple mechanisms involved in diabetic nephropathy, including increasing natriuresis, decreasing renin activity, and decreasing the renal oxidative stress that's occurring at the level of podocytes. So the trial, oral SEMA in Japanese patients, it was a small trial of 47 patients, and they found that EGFR actually rose. So from 80, the EGFR increased to 82.5, and the UACR was halved over a period of 3 months. So this was the one with the oral semaglutide, a small trial, but an RCT nonetheless. So does oral SEMA hold the promise of becoming one of the prime solutions? Different important points like SGLT2 was also there, but yes, all the patients had standard of care in patients who were type 2 diabetes with established cardiovascular or CKD. So high risk patients with standard of care, and it was a superiority trial. That was the main selling point of SOUL. 9,600 patients who were type 2 diabetes, for 50 years of age, established CBD or CKD, and HbA1c ranging from 6.5 to 10%.